you through the four talks today, quick four talks. I will request Dr. Bhavani Prasad to introduce the first speaker.
Good morning. It's always a pleasure to introduce Dr. Masood, who is a senior consultant in critical care, vast experience in critical care, has been in overseas, in UK and elsewhere, and he is heading the head of the department in Care Hospital, Nampal, and also in Malabar. Welcome, Dr. Masood, sir. Over to you.
Thank you, Dr. Bhavani. My apologies for a small delay. Anyhow, thank you for this opportunity, to the organizers to give this opportunity, and also Dr. Venkatraman Kola and Dr. Bhavani Prasad to introduce me. I'm going to talk about ABG, and metabolic interpretation is the main topic. Because of the time duration, which is just 20 to 30 minutes, I'm going to talk mainly on ABGs, but to basics of ABG. I'm not going to the details and the complicated problems and few clinical scenarios. I think there is a problem with the
I think get ready with your papers. Most probably you need to calculate as well. So Dr. Masood, I think will take us to some concepts about ABG, how to calculate, so that you know basics about how to calculate an ABG, right? So just go through the presentation process, so you'll be understanding neatly about how to interpret an ABG.
I gather that most of the delegates here they are the postgraduates. I think they must be knowing some basics. However, I will go through some physiology steps and clinical scenarios. The reason being that most of the ABGs are done in ER, ICUs, or complicated anesthetic procedures, or HDUs. So though you know them, you may not focus on them. That's why I'm going to little bit physiology. So usually we say ABG, not necessarily it is an arterial, that's why I said blood gases, because we can take from venous as well. The difference between arterial and venous is mainly in the bicarbonate and oxygen, PO2s and PCO2s. So like PCO2 and PO2s. And regarding bicarbonate and pH, there is no much change. So even you can do your blood gases from the venous samples, especially in DKS, where you need a frequent one, no need to puncture the arteries. And why we are talking about the pH, that's a very important concept. Everyone knows it. Just a recapitulation, that we all know that extracellular hydrogen at concentration is 4 × 10⁻⁻⁷, which is very, very minute. So to calculate these things, a small change in these concentrations is related to your life-threatening conditions. So to put it simple, they change it to log 10 to the negative logarithm of 10. So that it will become easy for us to calculate. So in sterile water, the pH is 7. It means it contains 100 nanomoles. And body pH extracellular is 7.4, which means it is 40 nanomoles. If you go from 7, each digit, there is 10 times it is going to increase. See, the pH goes to like 5. There are around 10,000 nanomoles of hydrogen ion, which is a huge difference, and it is actually a patient cannot survive, a human being cannot survive on that pH. So that's why it is a very narrow therapeutic window, and we need to keep it between 7.45 to 7.35 to 45. The reason is why we wanted to keep pH as a normal and near normal, because most of our enzymes, oxygen delivery to the tissues, electrode disturbances, your myocardial contractility, most of them depend on this pH. And it is very quite obvious that very rarely a human being survives if the pH is less than 6.8 or above 7.8. So the nature had given some buffers to us. These are the solutions which will dilute, whenever there is a deviation from the normal, they try to bring it to the normal. These are collective buffers. I'm not going in details about that. So we all know that this continuous production of oxygen is there, and there are two systems. In fact, somebody says three systems, that's a brain as well. They control this. 99% of your, so when the hydrogens are produced, 99% of your acids are excreted through your lungs. Only 1% is by kidney, though it is 1% or 2%, but it has a significant role in metabolic problems. Coming to assessment, whenever you are going to ABG, very basic thing is that you should know about the clinical condition of the patient. Most of the times, common is common. Remember, in medicine, of course, there we do see deviations, but very common is common. So if you know that, suppose pulmonary embolism is there, before I go for ABG, I expect there is metabolic acidosis. Similarly, different conditions like renal failure, metabolic acidosis, COPD, respiratory acidosis, diuretic use, metabolic alkalosis. So I know what I'm going to see. So if you know what you're going to see, it is easy for you to interpretation, though there are some abnormalities will be there. So coming to the terminology, acidemia and alkalemia. So normal arterial blood pH, we know that 7.40 plus or minus 0.05. However, for practical purposes, we take it as a 7.40. Any pH which is less than 7.40 is called as a acidemic, and any pH which is more than 7.40 alkalemic. For calculations, it will be easier for us. That's why we kept a target of 7.40. The process which causes this is called as a acidosis or alkalosis. Coming to the primary disturbances, so we go first what is step by approach, which will be easier for you. So any setup you can use it. So the first step is you know what is acidosis or alkalotic. The second step is it respiratory disturbance or a metabolic disturbance. How do you know? So usually respiratory disturbance is causes alterations in the carbon dioxide partial pressures, and metabolic disturbances by altering your bicarbonate. And though Henderson-Hasselbalch equation is very good, knowing what exactly is happening, how the carbon dioxide and bicarbonate behaves with, and hydrogen ion behaves with the carbon dioxide and bicarbonate, it has no clinical significance. So in that, you can see that if carbon dioxide goes up, hydrogen ion concentration is directly related to that, and when the bicarbonate goes down, bicarbonate is inversely related to that. So in respiratory acidosis, I expect that hydrogen goes up and there is a respiratory acidosis, and when the bicarbonate is low and pH also, hydrogen goes up, and it also causes metabolic acidosis. Coming to the primary respiratory disorders, so first, whenever there is a pattern, always a pattern. If you see that, you know the pattern, it's very easy to identify. If you see this slide, so the pH, carbon dioxide and bicarbonate changes, they're all in one direction. So when they are all in one direction, so when the pH changes, respectively the bicarbonate and carbon dioxide change in the same direction, it is a metabolic. Whereas in contrast, if the pH changes in opposite direction, the bicarbonate and carbon dioxide changes, this is a respiratory problem. Coming to the respiratory disturbances, we wanted to know, we all know that there are some patients who have acute carbon dioxide retention, though it's very less compared to your chronic carbon dioxide retention. Most of our patients have COPDs, bronchiectasis. They come to us with long history of carbon dioxide from years. So when this is there, how do you know whether it is acute or chronic by seeing the ABG? So there is a simple formula, that is change in hydrogen ion concentration to change in carbon dioxide partial pressure. So if it is more than 0.8, it means it is acute respiratory acidosis. Less than 0.3 is chronic. And we all know that most of the patients, they don't come to ER with acute or chronic. They come either at acute or they come with acute and chronic. So when it's a 0.3 to 0.8, it is a acute and chronic one. Next, so if there is a respiratory association, what is the compensation? And the compensation also, we know that kidneys takes time to compensate. So when it is less than 24 hours, the compensation is there, but very less. So when there is acute respiratory acidosis, it is less than 24 hours by acute means, and there is for every 10 millimeters of change of carbon dioxide, the bicarbonate will increase by 1. Whereas if it is a chronic, which is like more than 24, here I have written, but usually it takes like 2 to 3 days. And by every 10 millimeters of change of PCO2, it changes by 4. The bicarbonate goes up by 4. Similarly, in alkalosis, acute, it is 2 millimeters of mercury drop of your carbon dioxide, and in chronic, it is 5. So these are the calculations we should know. Then coming to metabolic acidosis. Once you know that, I already explained what is acidosis, and once the metabolic acidosis you recognize, the first thing you have to do is anion gap. Is the patient has a high anion gap metabolic acidosis or not? So what are the anion gaps? What is anion gap? Anion gap is, we know that we have anions and cations, and there's electron neutrality present in the body. So anions will be equal to cations. However, we cannot measure some anions. They are unmeasured anions, and we call them as a anion gap. So mainly the unmeasured anions are your proteins, followed by phosphate, magnesium, cations or calcium. Usually you calculate by sodium. Some textbooks write potassium, but we do change it, because if we add potassium, the normal value 12 here, it goes to like 16. So usually we don't use it because there are a lot of conditions where potassium will be disturbed. So usually we use it to sodium minus the anions concentration of chloride and bicarbonate. The value is 12. And you should know that, I think everyone knows here, we have been studying this mnemonic. Better to remember mnemonics, because I still remember the mnemonics which I remember when I was in MBBS, still I know them. It's easy for you to follow. So the mud piles is a common mnemonic what we use. I think everyone is aware of that. I'm going to just follow it. However, when you are calculating anion gap, just blindly don't calculate it. Just keep in mind what is, because most of our patients, they do have some underlying illnesses, like patients with cirrhotic disease, cirrhosis, nephrotic syndrome or malnutrition. They do have albumin. We all know that albumin is a powerful anion. So when it is low, the anion gap falsely low. So how do I correct it? So what you do is, for every for 1 gram of drop of your albumin from 4 grams, so you need to cover by 2.4. For example, there is a chronic liver disease patient. He came with severe metabolic acidosis. His anion gap is 9 when I calculate by sodium chloride and your bicarbonate. But it appears to be normal for me. But I know that this patient is a chronic liver disease. His albumin is low. So when I corrected it, it has gone to 14, which is a high. So you must be very, very careful when calculating the anion gaps. Coming to, there are some conditions, metabolic acidosis, which have normal anion gap. Which of them, the mnemonic is like heart gaps and hyperalimentation, acetozolamide, renal tubular acidosis. Usually we see diarrheas and renal tubular acidosis in our clinical practice, and some spironolactone use as well. So when I see there is a normal anion gap, I wanted to know whether it is a renal or extra-renal. That's very important for me for the treatment. Because if it is a extra renal, it is very easy for me to correct it. I can give some fluids to them, it will correct. Whereas it is a renal one, usually I go for giving some sodium bicarbonate, then I'll go what type of RTA is that. So first what I do is I do a urine spot sodium and potassium and chloride. I think this very few labs here do that. When they do that, you can get a urine anion gap. So if it is a negative, it means it is an extra renal cause and causes diarrhea. And when it's positive, it is a renal. Most common is renal tubular acidosis. We all know that 1, 3, 4 are there. And next, once you finish with anion gap, once anion gap is high, you go for your osmolar gap. It's very important as well. The problem with osmolar gap, now you need to have a measured osmolality, which is a freezing point technique they use it. Very few labs have. CARE is one of the hospitals where they do measure your osmolality. Most of the units, they calculate osmolality by sodium, glucose, and urea. So when the labs do that, it's not useful for us. So we need to know the measured anion gap and measured osmolar gap. And so what is osmolar gap? So when you measure osmolality by your freezing point depression technique, you'll get your what is exact osmolality in your blood. Then you calculate osmolality by doing what? 2 multiplied sodium plus urea plus glucose. So once you get your calculator, you subtract measured from the measured from your calculated one. If there is a difference naturally when unmeasured osmoles are there, then you know that there is something which is causing this metabolic acidosis. And the osmolar gap usually is, some people say 10, but most of them we use 20. So if it's more than 20, we means that there is a osmolar gap and there is some osmoles which are causing this. And usually it's methanol poisoning, ethylene glycol, isopropyl alcohol are the common causes of that. And then once some of because patients are not textbooks, they don't behave simply. They are human being is a complicated person. So he may be having 1 or 2 mixed acidosis. So how do you know that? There's something called as delta gap, that is the anion gap, delta anion gap by delta bicarbonate. So what you do is you calculate your anion gap and you subtract it from, you subtract expected anion gap. Also similarly you extract bicarbonate from the normal. So if the value is 1 to 2, it means that's a pure metabolic acidosis is there. Less than 1, there is a normal anion gap metabolic acidosis as well as high anion gap metabolic acidosis. When it is more than 2, anion gap acidosis plus alkalosis are there. Coming to the basic rules, there are basic rules which you must know it. That I just kept this slide so that you must know that never in ABG is overcompensation. When we used to say, oh, there is overcompensation. Never the word of overcompensation has happened in the history because of, and it can never happen. Okay, so there is a never called as a overcompensate. It compensates near to normal, but never to normal or not it exceeds. It exceeds means there is something extra abnormality is there. The second rule is all combinations can happen in mixed respiratory problems, like you can have a respiratory acidosis, metabolic acidosis, metabolic alkalosis, respiratory alkalosis with metabolic acidosis, but never respiratory acidosis or alkalosis combines. This is the nature. And always remember, when bicarbonate is less than 13, it is definitely a metabolic acidosis. It is not something which is a compensatory mechanism. Similarly, if anion gap is more than 20, it is definitely a high anion gap metabolic acidosis. And this is one of the slides where you see the compensations. And I'll skip this slide, it is this one. Coming to the alkalosis, metabolic alkalosis, we know that like the mnemonics, you have a Clover is the one. Mostly in our ICUs, we see either electrolyte disturbances, mostly hypokalemia, or diuretic use. These are the most common conditions what we use it. Here, you see urine, spot urine chloride. If it is more than 20, usually it is endocrine cause or electrolyte disturbances. If it is less than 20, usually it is a contraction alkalosis where you can give some saline and you can improve your metabolic alkalosis. Coming to the case scenarios, there is a 23-year-old lady with septic shock secondary to bilateral pneumonia presented. These are her electrolytes. Bicarbonate is 15, which is acidosis, metabolic could be, and pH is 7.1, and her anion gap is 23. So it is a high anion gap metabolic acidosis. However, when we have seen her carbon dioxide, so what do you expect carbon dioxide? It is low, but in this case the carbon dioxide high. So this patient has a combination of primary high anion gap metabolic acidosis as well as primary respiratory acidosis. There is no compensation. So this patient has a mixed acidosis problem. Similarly, there is a 25-year-old diabetic. He ran out of insulin. The day later he came to ER, and these are the investigations found. His pH is acidotic pH. Carbon dioxide is washing out. There is a severe bicarbonate is very low, and NN gap is high, 24. So definitely we all know blindly, we can tell that it is a high NN gap metabolic acidosis. So actually I never start, and it is not recommendable to start sodium bicarbonate. However, low bicarbonate, we have treated bicarbonate of 3, pH of 6.9 with aggressive fluids and potassiums, and we never gave bicarbonate, and all patients within 12 to 24 hours with the aggressive protocols, they become normal. However, here they have given sodium bicarbonate, and they forgot for 10 hours doing ABGs. Usually, DKS, we do 2-hourly or 4-hourly ABGs in good condition, but here, because of limitations, we do like 6 to 8-hourly. After 10 hours, the pH was 7.4, so perfectly normal. Carbon dioxide is normal, bicarbonate is normal. However, when I checked NN gap, it is 28, which means the patient still has severe metabolic acidosis. So this patient has a high NN gap metabolic acidosis, which is not reverted because it's still 10 hours, not aggressively treated. Artificially, I've given bicarbonate, so the patient has a primary metabolic alkalosis. And there's another boy, 80-year-old boy, by mistake he has taken aspirin, 20 tablets, and his PCO was 16, NN gap is 23, so pH is 7.4, perfectly normal pH. And there is a, when I calculated his expected carbon dioxide for this bicarbonate of 9, so it is 18. But his carbon dioxide is 16, it should be 22. So when, but the patient's carbon dioxide is 16. So what he's doing, he is washing out because it is a salicylate. Patient has a both metabolic acidosis as well as respiratory alkalosis. There is a 70-year gentleman who is a COPD, congestive heart failure, and diuretics. COPD, we all know that he must be retaining some carbon dioxide, and there is some bicarbonate compensation is there. Now he came to the ER with a one-day history of urinary tract, upper respiratory tract infection. His PCO2 55, bicarbonate is increased by 1.5, and his pH is acidotic. But supposed to be with this, so his pH is supposed to be acidotic. But when we did his pH, it is 7.44, which is on alkalotic side. And when we did bicarbonate, it is 36. So there is something which is increasing his bicarbonate. That is metabolic alkalosis because he is using excessive diuretics. There's time is there still? Yeah. I'll do one thing. I'll skip this slide because I wanted to talk something about the sodium as well. Yeah. So this is a 56-year, that case was about ethylene glycol poisoning. I'm skipping it because of lack of time. So he's a 56-year-old gentleman. He presented to the hospital with history of cough and fever of 4 days. He's a known diabetic. So his investigations had revealed that his serum sodium is 125. So 125, we all know that it is a hyponatremia. However, when I went and checked his glucose, it is 500. So the purpose of this slide is that we should calculate the sodium. We should correct the sodium for the hyperglycemia. We all know that there is a factor of 1.6. Somebody use it, but I use it 2.4 because the recent trend is using 2.4. But for practical purpose, examination purpose, they like 1.6. So for every 100 milligrams increase, we need to correct more than 100 milligrams. So more than 100 milligrams from the blood sample, if it is more, we should correct by 1.6. So when I correct it, it is 131. Apparently, it appears to be for me 125, but it is not hyponatremic. So yeah, hyponatremic, but not severe. So it's 131. There's another case, a 67-year-old gentleman who is hypertensive on medication. So he's using telmisartan and hydrochlorothiazide. He came with a history of low level of consciousness and seizures, and MRI brain was done because our ERs, MRI is done, doing MRI is easier, waiting for the results. We have sent investigations, they haven't come yet. And MRI was perfectly normal. I was looking for any stroke, ischemic or hemorrhagic strokes, but MRI was normal. So after 1 hour, the electrolytes have come, and they have 109 is the sodium. So this is the flow chart of that. First, we need to see the tonicity, and then you need to see the hypovolemia, euvolemia, or hypervolemic. Depending upon that, you will classify urine sodiums, osmolalities, and this is a little bit complicated. I'm going out. And regarding the treatment, before we used to use continuous infusion, but when the patient is symptomatic severe, always try to give bolus of 3% saline or 5% saline, whatever available. Here, 3% is available. Give it like 150 to 200 ml, and then check your sodium immediately after like 1 or 2 hours. If it doesn't go up, give another bolus. This practice was not there before. The new guidelines, European Society of Intensive Care Medicine and endocrinologists, I think they're suggesting to give boluses when the patient is hyponatremic, and then continue your infusions. So always give boluses for symptomatic patients. Don't forget to give boluses. Yeah. Thank you. Thank you very much.
Thank you, Dr. Masood. I think we will take questions later.
Thank you.
Now I invite Dr. Mahati Pavluri, Senior Consultant Intensivist and Pain Medicine Specialist. She is a member of Spurge Critical Care Team. She heads the new branch of Omega at Gachibowli, as the Critical Care and Emergency Chief. Dr. Mahati will be talking on basics of mechanical ventilation.
Good morning, everyone. Good morning, sir. Thank you for the kind introduction. And yeah, I've been asked to talk about basics of mechanical ventilation. 20 minutes will be enough only to talk about the headings probably, but I'll try to do my best. Can I have the presentation, please? I'm hopeful that by the end of this presentation, the delegates here should be able to look at the ventilator and put basic settings when somebody has given you the patient intubated. So, okay, so by the time the slides come on the screen, I will be discussing about types of ventilation, both invasive and non-invasive. And in invasive, we'll talk about the basic settings, modes, triggers, targets, so that when you have the patient there in the ICU, you should be able to put up the settings to be able to ventilate the patient. Direct నామేల్ని ఓపెన్ చేస్తాను. Next slide button. So these are the topics that we will be discussing: settings, modes, and we will discuss the advantages and disadvantages between different modes, and what guidelines should we be following in initiation of mechanical ventilation and also maintenance, and some troubleshooting examples and a case discussion. So there are multiple indications to intubate a patient and put on mechanical ventilator. So most common one are respiratory arrest, acute lung injury either due to trauma or infection, tachypnea, and hypoxia. And also clinical deterioration, low GCS, patient in coma or GCS of less than 8. And neuromuscular diseases like Guillain-Barré syndrome, where the respiratory muscles are paralyzed and the patient is not able to breathe on their own. So in types of ventilation, there are non-invasive ventilation and invasive mechanical ventilation. So in non-invasive ventilation, we put a mask on patient's face and the tubings are connected to the machine. So there is no tube, endotracheal tube into the trachea. And in invasive mechanical ventilation, the endotracheal tube is placed and the patient is connected to the ventilator. So there are some advantages for non-invasive ventilation when compared to invasive ventilation. So the overall cost is decreased. The tolerance by the patient is better. We usually don't have to sedate the patient when there is no endotracheal tube in situ. It is more convenient. It can be started even by the nursing staff. And it can be used outside the ICU. The BiPAP and CPAP machines can be used outside the ICU. And there is also, we can take breaks in the therapy. So if we have to feed the patient, the mask can be removed and the patient can be put on oxygen and feeding can be given. And they usually airway skills are not required for this because this is a non-invasive mode of ventilation. But the disadvantages are, if the patient is very uncooperative or very drowsy, we cannot use it. And if there is a risk of vomiting and aspiration more with mask ventilations. And suctioning is not very effective because there is no tube, endotracheal tube. And it cannot be performed on patients who have poor GCS. If the consciousness GCS is less than 8, we cannot put people on NIV. Also, the mask fitting is very important because leaks are a very common problem when we put patients on NIV with a mask. And the work of breathing can also be increased because the patient has to breathe on their own. Even though the machine is giving some support, the patient has to breathe on their own. So these are the basic settings for putting a patient on invasive mechanical ventilator. So I will be discussing these topics one after another. So there are trigger. So what is a trigger? When we are putting the patient on ventilator, the ventilator has to start giving a breath, isn't it? So there has to be a trigger. So the triggers change depending on the mode of ventilation that we are going to use. So we can use pressure triggering or flow triggering. So when pressure is used as a trigger, the ventilator breath is delivered when a certain negative airway pressure is generated in the system. Then the breath is initiated by the ventilator. And in a flow trigger, there is a continuous flow in the mechanical ventilation system, which is called as bias flow. So when there is a drop in flow, the ventilator will trigger a breath. Then comes the target. So target is, okay, the breath has been initiated. So there needs to be a target. How much tidal volume has to be delivered at what pressure? So these are the targets. Again, based on the mode, the target varies. So if the common target variables are pressure, volume or flow. So in pressure controlled modes of mechanical ventilator, the target is a set pressure. So the ventilator will keep delivering air to the lungs until that pressure is reached. And once the pressure is reached, the ventilator will stop delivering the breath. And in volume control modes, there will be a set tidal volume. Like if we have said 450 ml of air to be delivered to the lungs, then it will deliver 450 ml and stop at that point. Then comes the cycling. A cycle in breathing means inspiration and expiration together is called a cycle. So when the inspiratory phase has to stop and the expiratory phase has to start will be depending upon the cycling target that we keep. So the target can again be a tidal volume in a volume control mode or a certain pressure in pressure control mode. So once the target is reached, the inspiration is stopped and expiration is initiated. So this is a chart showing the three things that I've said. The trigger usually time or pressure. So there has to be a trigger to deliver the breath. Then comes the limit or the target. So a certain tidal volume or a certain pressure where the ventilator stops delivering the breath. And then the cycling. So cycling again depends on what target we have set, whether it is a pressure target or a volume target. Now coming to tidal volume. So tidal volume is the amount of air which is delivered with each breath. So how do we decide that this is the amount of tidal volume that we need to give to the patient? So tidal volume is set as ml per kg body weight. So what body weight do we take? So we usually, because when the patient is on the bed, we cannot measure their weight directly. We use ideal body weight. So ideal body weight is calculated with the formula. It has a separate formula for males and females. Once you get the ideal body weight, based on the condition of the lung. Suppose the patient is in ARDS. The lungs are very stiff. We tend to give lower tidal volumes, 5 ml, 6 ml per kg body weight. Usually in other patients, we target a tidal volumes of 8 to 10 ml per kg body weight. So there is no optimal mode for setting a respiratory rate. So respiratory rate is usually titrated based on the CO2 and oxygen levels. So if we have set a very high respiratory rate and there is CO2 retention because we are not letting the expiration complete and the next inspiration starts. So then we might have to reduce the respiratory rate. If the oxygenation is not improving with the respiratory rate, then we might have to increase the respiratory rate. So it depends on the oxygenation and carbon dioxide levels to adjust the respiratory rate. Then comes the PEEP, the positive end expiratory pressure. This is again a very important setting. So now we are using, all our ventilations are positive pressure ventilations. In olden days, they were negative pressure ventilations. So where externally pressure was generated to press the chest for exhaling the gases. And then the chest recoil used to fill the air. But now what our ventilators do, the ventilator delivers air into the lungs and passively exhalation happens. So in this, when we are pushing air into the lungs, the alveoli open. And when the air is coming out, the alveoli again collapse. So what does PEEP do when there is a end expiratory pressure? So when at the end of expiration, there is still some amount of pressure left in the alveoli so that they don't collapse completely. This is very important in ARDS because in ARDS, the problem is recruitment. The alveoli are totally collapsed and the lung is very, very stiff. So very high PEEPs are used in ARDS cases. So if at the end of expiration, there is no PEEP, the lung alveoli will collapse again. So again, the next inspiration has to start the process from the beginning. So when we are using higher PEEPs, the basal alveoli stay open because of the end expiratory pressure. So the picture is demonstrating the first set is the derecruited alveoli where there is no air. Then when we put an optimal PEEP, the alveoli are opened. Now, why is it important? If the alveoli are collapsed, the gas exchange does not happen because the alveoli are not getting filled with air. When there is an optimal PEEP, the gas exchange happens. Gas exchange where? Between the air and the capillaries, because the capillaries are the ones, aren't they, which are carrying oxygen. So when this air enters, the gas exchange happens, oxygen goes into the blood and the carbon dioxide comes into the alveoli and it is exhaled. But when they are over distended, there is over pressure on the capillaries. So again, the gas exchange does not happen. Even the alveoli are full of air, the gas exchange is not happening because the capillaries are compressed. So what will happen then? There is only a dead space. Dead space means no gas exchange is happening, no oxygen is coming into the blood and no carbon dioxide is going out. So we need to set up an optimal PEEP. Then the flow rate. So flow rate, okay. Flow is the total air flowing through your ventilator circuit system. When the patient is on ventilator, there is a ET tube, then the ET tube is connected to a tubing and the tubing is connected to the ventilator. So there is lot of dead space inside, isn't it? So all that space has to be covered with the flow. So some air has to be flowing. Normally 30 liters per minute flow is good enough, but when the patient is on a mechanical ventilator with increased work of breathing, we set flow rates of around 60 liters per minute. So what will happen if there is insufficient flows? The patient will become dyspneic, the work of breathing will increase, oxygenation will not happen properly. Then comes the IE ratio, the inspiratory time and expiratory time, because the cycle of respiration has both inspiration and expiration. So normally in a spontaneously breathing patient, inspiratory-expiratory ratio is 1:2. So if inspiration is for 1 second, expiration is for 2 seconds because all the carbon dioxide needs to be exhaled out. If the expiratory time is not enough, then breath stacking can happen. What does breath stacking mean? That means before the whole carbon dioxide is exhaled, the inspiration has started. So some amount of carbon dioxide is staying in. So what will this cause? This will increase PCO2, carbon dioxide levels in the blood, and the patient will become drowsy, and it will also hamper the oxygenation. So that's a simple diagram where you can see when there is an inspiration, expiration, the alveoli, the lung is all collapsed, and when there is inspiration, the lung is dilated. So you have to give enough time for the lung to open up and also to breathe out all the carbon dioxide. Then fraction of inspired oxygen, that is FiO2. So this is the amount of oxygen that we are setting in the ventilator to be delivered to the patient. Normal air has oxygen levels of 21%, as we all know, and we can set up to 100% of oxygen levels based on patient's requirement. Again, we have to be very careful. This oxygen levels can be titrated with arterial blood gases, about which Sir spoke just now. So you can take ABGs and see PaO2 levels. If the PaO2 levels are very high, we need to come down on FiO2, because too much of oxygen will cause free radical injury. There will be a lot of free radical injury happening. So hyperoxygenation is not advised. Now coming to basic modes of ventilation. So assist control mode in both volume control and pressure control, pressure support ventilation, synchronized intermittent mandatory ventilation, again both volume control and pressure control. So in assist control mode, we set a tidal volume if it is a volume control mode. So here we need to understand that there is a volume control mode and a pressure control mode. In volume control mode, a set tidal volume is delivered, and in pressure control mode, the gases are delivered at a set pressure. So in assist control, the ventilator allows the patient to breathe along with the set respiratory rate and tidal volume. The ventilator will assist the patient to take a breath. Suppose the patient has initiated his or her own breath, the ventilator will deliver the pressure to take that breath, so it will reduce the work of breathing. In pressure support ventilation, there is no respiratory rate set. We set only the pressure support and PEEP. So whenever the patient is triggering a breath, the air will be delivered with set pressure so that the work of breathing is reduced and the patient doesn't become tachypneic. In synchronized intermittent mandatory ventilation, there are a set number of fixed breaths with a set tidal volume or pressure. And again, when the patient wants to breathe, the ventilator will give support. So what is the difference between pressure support and SIMV? In SIMV, there are fixed breaths, and also it supports the patient to breathe on their own. In pressure support ventilation, the patient is breathing on their own with the pressure support from the ventilator. So these are the advantages of each mode. In assist control, there is reduced work of breathing when compared to spontaneous breathing. In assist control volume ventilation, there is a definite tidal volume delivery. In assist control pressure control ventilation, there is limitation of peak pressures. So what happens here when a set tidal volume is being delivered and the alveoli are too stiff, the lung is too stiff, but still the ventilator will deliver that tidal volume. So trauma can happen. Excess of tidal volumes are being delivered and it can cause alveolar injury. In pressure control ventilation, that complication is prevented, but adequate tidal volumes might not be delivered. So when the pressure limit is reached, and it might not deliver the adequate tidal volume. In pressure support ventilation, the patient is comfortable and patient ventilator interaction is better. There is no dysynchrony because the patient is breathing on their own with pressure support. And in SIMV, there could be increased work of breathing because there are forced breaths. When the ventilator is delivering a breath, and the patient tries to trigger a breath, then there could be a little dysynchrony. So what are the guidelines in initiation?
You have time limit, so please.
So what are the primary goals? So primary goals are oxygenation and reduced work of breathing. So initial FiO2 we have to set at 100% and then we titrate according to the patient's requirement. The tidal volumes can be set at 8 to 10 ml per kg body weight, and body weight is ideal body weight. In ARDS, we consider lower tidal volumes. We take 4 to 6 ml per kg body weight, and we use higher PEEPs in ARDS. So in ARDS, higher PEEPs help in better oxygenation. And when poor oxygenation is there, there is inadequate ventilation, and there is patient dysynchrony with the ventilator, we can consider increasing sedation of the patient and or paralyzing the patient. So coming to troubleshooting, some common problems: high peak pressures, patients with COPD, ventilator dysynchrony, and ARDS. So if the peak pressures are too high, Then we have to look for causes of resistance. So there could be bronchospasm. If there is bronchospasm, we need to give bronchodilators and reduce bronchospasm. And there could be an obstruction in the ET tube, which can be causing the increase in peak pressures. We have to do thorough suctioning. And if both peak pressures and plateau pressures are high, the lung compliance is not very good. Then we have to think about the alternate methods to improve lung compliance. So these are some differentials where there is a high peak pressure and low plateau pressures. So a mucus plug, bronchospasm, ET tube blockage, biting of the tube are the conditions. And high peak pressures with high plateau pressures are commonly seen in ARDS, pulmonary edema, pneumothorax, and effusions, large effusions. So if there is a patient with COPD and asthma with worsening oxygenation and increasing hypercapnia, then we have to consider the disease process and adjust the IE ratios and tidal volumes. And here the respiratory rate is very important because breath stacking or auto PEEP is the condition which can worsen hypercarbia in these patients. So what do we do in these cases? We try reducing the respiratory rate, increase the flow rates, which I said 60 liters per minute, and adjust the respiratory rate and IE ratio. So here we see that the expiratory time is a little longer so that carbon dioxide is exhaled. Then in a patient with agitation and dysynchrony on the ventilator, it could be due to overall discomfort because there is a tube in the throat. So increasing sedation might help. There could be other causes for air hunger, which like decreased flows, inadequate tidal volume, inadequate respiratory rate, adjusting IE ratios, all these can solve the problem. So if there is a ARDS, then we have to consider the hypoxia and radiological findings. And here we take the PF ratios, that is PaO2 by FiO2 ratios. So based on the PF ratios, the oxygenation levels and the PEEP levels are optimized. So usually in ARDS-NET protocol, we use lower tidal volumes, we use very high PEEPs, and we sedate and many a times paralyze the patient for the first 48 hours to improve oxygenation. Thank you.
Thank you, Dr. Mahathi. I think it was quite difficult to cover the ventilator. We have the topic to cover in 2 to 3 days. She covered in 30 minutes. These are the basics for the people who are practicing as a physicians or postgraduate students should know the basic thing, when to consult for the expert people. Because of limitations of the time, I think all the questions will take at the end. I'll invite the next speaker, Dr. Shweta Chandan Kede. She'll be speaking about the sepsis and septic shock. I think it is a bread and butter for all the clinicians which working in the hospital, and particularly for the diabetes. They presented with the various reasons to the hospital. Everybody have their own protocol to treat. I think Shweta will take us through about the protocolized treatment of the sepsis so that we maximize the outcome for the patient. Over to Dr. Shweta.
Good morning, everyone. Thank you, sir, for the introduction. I eternally thank FDRS team for giving me this opportunity. For soft-spoken people, when they come on the podium, they have to ask, am I audible? For midgates like me, I have to ask whether I am visible. Most of the time, they don't know where the voice is coming from. So, you are gone back. Okay. So, in the next 15 to 20 minutes, I have to talk on sepsis and septic shock. Basically, sepsis is a huge topic, and whatever information I can give in the next 15 to 20 minutes is so small that you cannot even sniff it. So, again going back. So, Okay. So, sepsis is a major killer in critically ill patient. The death toll is as huge as 11 million deaths per year worldwide. On an average, sepsis kills one patient every 2.8 seconds. So, out of the one death, every fifth death is because of sepsis. Now, sepsis is the number one cause of mortality in the hospital. It is number one cause of hospital readmissions, and it is number one cause of healthcare cost. So, if Mr. Rajamouli Garu was sitting in the audience, probably he would have produced a movie 111 on sepsis. So, most of the sepsis, around 80% of the sepsis occurs out of the hospital. So, what is this sepsis? Basically, it is a dysregulated host response to infection which leads to life-threatening organ dysfunction. So, it starts basically with a local infection and gradually it progresses to a generalized inflammation. Now, this inflammation leads to individual organ deterioration. After some time, multiple organs deteriorate simultaneously or subsequently, and they may lead into multi-organ dysfunction. Whenever there is circulatory collapse, it leads to sudden decrease in the blood pressure, and this is called as septic shock. So basically, sepsis is a common pathway to death by the majority of microorganisms if they are not diagnosed quickly and not treated early. So who can get sepsis? Anyone can get sepsis, but people with lower immune system can develop sepsis, and this includes patients who are more than 60 years of age, children less than 1 year of age, people who don't have spleen, people whose immunity is suppressed because of diabetes mellitus or because of AIDS, and patients who have chronic diseases of heart, liver, and lung. So, what can cause sepsis? Any bacteria, virus, or fungus can sepsis. So, what are the common reasons for sepsis? Pneumonia is the most common cause of sepsis, accounting for 35% of the cases, followed by urinary tract infections, then meningitis, skin and soft tissue infections, and even the viruses like malaria, dengue, and COVID-19 virus can cause infection leading to sepsis. Now, let us take down a case. This gentleman, 61-year-old, known case of diabetes, had history of fever for 5 days. He had swelling of the right lower limb for 5 days. So he came to the hospital after taking self-medication. So he came after 5 days because he had breathing difficulty, he was slightly drowsy, and he had a decrease in the urine output. On examination, he was febrile, he was tachypneic, he was tachycardic, he was drowsy, and his blood pressure was on the lower side. When seeing on the right lower limb, it was swollen and red. So how do we manage this case? Now, there are various sepsis guidelines which keep on coming. Every 4 years, these recommendations keep on changing. But how do we manage this case? So the basic key to survival is early identification of the sepsis. The subtle signs of sepsis should be identified. Now, sometimes sepsis mimics a non-infectious cause of acute illness, and sometimes a non-infectious cause of acute illness can mimic sepsis. Therefore, at this point of time, we may have various differential diagnoses. For the patient in our reference, he has fever, he is having low blood pressure, he is having breathing difficulty, he is having swelling of the right lower limb. So whether it is cellulitis leading to multi-organ dysfunction, or is it DVT which has led to subsegmental PT, and over a period of time his thrombus load increased, which has caused circulatory collapse and thus multi-organ dysfunction. So there are various scores which can be used for identification of sepsis. But mind you, Using one score is inadequate because it has less sensitivity. Therefore, it is prudent to use a combination of multiple scores to identify sepsis early. Seeing this, sepsis is an emergency where every minute matters. Loss of 1 hour in treatment of sepsis can lead to increase in the risk of death for the patient by 7.6%. So now this patient comes to the your ER. How do you manage the patient? So first things first, always see the airway, breathing, circulation of the patient and manage it. Now this is a case where he has come into shock, and we think that there may be sepsis looking at his clinical picture. So basically we have to approach like we have to go ask a detailed history quickly. We have to do the clinical examination and send lab test, and thus come to narrow down our diagnosis. Now, in cases of sepsis, when the chances of sepsis are very high, it is recommended to give the antibiotic as soon as possible and ideally within 1 hour. Before giving the antimicrobial therapy, it is prudent to take the blood cultures to get a good yield. Now, if the patient is in shock, hypotension, fluid resuscitation should be started immediately, and whenever required, vasopressors should be used. Now, the next thing is whether we should use lactate in the management of sepsis. We know that lactate has good relationship with prediction of the mortality. It should not be used for the diagnosis of sepsis alone. But yes, it can be used for the management of fluid. Now again, it was a high quality recommendation in the previous guideline, but it is downgraded to weak recommendation. Why it has happened? Because a few patients we cannot decrease the lactate level. So when we are actually using lactate, it can be used for resuscitation and seeing whether the lactate levels are coming down. But in low resource setting, when the lactates are not available, it is okay not to do lactate. And in these cases, capillary refill time can be used for guiding the fluid therapy. Now in studies, it has been shown that capillary refill time did not perform worse than lactate for determining the fluid response. So coming to the timing of the antibiotic, when shock is present and when sepsis is definite, or when there is high likely chance that it is sepsis, the antibiotic should be administered as quickly as possible and ideally within 1 hour. Now, if shock is absent or the likelihood of sepsis is doubtful, then we need to re-evaluate the patient. So, to come down to a diagnosis, whether it is infectious cause of the acute illness or whether it is the non-infectious cause of acute illness. And if still there are concerns of infection, sepsis, then give the antibiotic within 3 hours. Now, what I want to emphasize here is that when we are in doubt, keep on re-evaluating your patient frequently. Ask detailed history again, do the clinical examination, do the lab test. So for the patient in our reference, we had a doubt whether it is cellulitis or it is DVT causing PT. So we did his clinical examination. We sent labs like CBC and other important labs. We did his echo, DVT scan, and CTPA. His DVT scan was negative, his CTPA was negative, there was no PTE, and his leukocyte count was on the elevated side, and his clinical picture was all suggestive of sepsis. So this is how we have to re-evaluate the patient when in doubt. So regarding the antibiotic, there are lots and lots of recommendations, and it is beyond the scope of this lecture, but I just want to tell you few important points. For a patient in sepsis or septic shock who has high risk of MRSA infection, an antimicrobial with MRSA coverage should be started immediately. For patients with sepsis or septic shock who have high risk of multi-drug resistant organism, a dual antimicrobial coverage with gram-negative antibiotic should be started empirically. Now, once the causative organism is known, there is no role of dual antimicrobial therapy. Then the most important thing is source identification. So whenever possible, the anatomical source should be identified, and measures to be taken quickly to rectify or remove the source of infection. Then how do we de-escalate the antibiotic? So it is a very difficult question. So your clinical judgment is required. Plus, use of procalcitonin along with the clinical judgment should be done. Nobody should forget the antibiotic stewardship program when we are managing the antibiotic. What is the antibiotic duration? Again, this is unclear. This question has an unclear answer. There are almost 5,000 papers on the duration of antibiotic therapy in PubMed. So what we can say that the antibiotic therapy should be short. And again, your clinical judgment is important on narrowing down the antibiotics and de-escalation of the antibiotics. So now when we are dealing with shock, the first thing is that it should be managed immediately. Whenever we say that the patient is having low blood pressure or he is in hypotension, he is not having a good tissue perfusion, we should start IV fluids immediately. So it is recommended or it is suggested to give 30 ml per kg of IV crystalloids within 3 hours. Now this was again a strong recommendation in the previous guidelines, but now it has become a weak recommendation. Why? So again, after even the initial fluid resuscitation, few patients are further fluid responsive. So in these patients, we guide the fluid therapy with the dynamic parameters of for assessment. What are these dynamic parameters? These are passive leg raising, stroke volume variation, pulse pressure variation, use of echo with passive leg raising, or a small fluid bolus, for example, 4 ml per kg body weight. It is not recommended to use starch or gelatin for fluid resuscitation because of the harmful effects. So when we are dealing with sepsis, it is recommended that we should keep a MAP target of 65 millimeters of mercury. So if the patient is adequately resuscitated and still he does not maintain a MAP of 65 millimeters of mercury, add a vasopressor. And the first vasopressor of choice is noradrenaline. Initially, when the central line is not available, start the vasopressors through the peripheral line, but do not delay adding the vasopressor. Now, if the patient is still not maintaining a MAP of 65 millimeters of mercury with a noradrenaline dose of 0.25 to 0.5 microgram per kg per minute, add vasopressin. If further the patient is not maintaining the blood pressure, adrenaline can be added. Whenever possible, use arterial line for titration of the vasopressors. So sepsis is not only about dealing with the infection, shock, fluid management or antibiotic. There are a number of things which we have to do, and it is actually out of the scope of this lecture. There are various guidelines and bundles, and all these are for guiding the clinician for how to manage sepsis, but they do not replace the clinician's judgment on how to manage the cases when there is a unique situation. I want to emphasize medicine is both science and art, where
She said, see, many of these infection may be self-limiting, many of them may just need a oral antimicrobials at home, which can cure. But patients like diabetes, patients like immunocompromised host, patient with a suspected or a confirmed infection comes with a organ involvement. She's trying to focus on that, ki when an organ involvement is questioned, whether this patient had an altered mentation, whether this patient blood pressure is dropping, whether this patient's kidney started dropping urine output. These all probably give you a clue that these patients' organs are getting affected. So as he pointed out, like heart attack, where a chest pain makes a lot of alertness, a paralysis makes a lot of alertness, organ failure with an infection we should also make a equal important alertness, so that we should rush to a hospital or a healthcare facility where this can be managed. And she gave a 5 or 6 major points. Do a culture appropriately, because that will help you in guiding your antibiotic. Give antibiotic as early as possible. Maintain the blood pressure with IV fluids. If IV fluids are not helping, you may need to add your vasopressors like noradrenaline or a vasopressin as required. And the last thing she said, lactates, even though are recommended to do in many of the septic conditions, if in resource limited setting, if you don't have lactate, you may consider alternatives to lactate as a site of perfusion or a sign of perfusion, where we see 3 windows of perfusion. One, if your brain is working, that's the first sign that if a patient is in completely normal conscious state, you have a good CNS perfusion. The second perfusion state is your skin. You see the capillary refill, the warmth of your skin. If the skin is clammy, cold, and low perfusion, bluish, then there is a problem in perfusion. The last one is your urine output. It is considered as a giving a indirect evidence of your kidney failure, indirect evidence of your renal failure. And what happened is, in the last few weeks, when we thought ki all our clinicians, either they are an endocrinologist or they are a clinicians or they are a GP practitioners, all of them need a orientation of some of the ICU areas. We felt ABZ and metabolic syndromes will be one area which everybody wants to know. Basic mechanical ventilation, which Dr. Mahathir spoke about, a NIV mask which many of you have used with a BiPAP of setting somewhere 4 to 8, then 6 to 12, and then putting some oxygen onto it. Then few of the patients who are intubated by your intensivist or anesthetist, you may be asked to take care of them in the resource crisis situation. So she was giving a whole view that you have a oxygen to set up as an FiO2, respiratory rate, tidal volume. Then she was also talking about some troubleshootings when many of our ICU, there are many deaths happens because a tube is blocked, nobody attended, a disconnection happened, nobody attended. So with this, I think because this was a FDARS and we are talking about endocrine and endocrine related metabolic syndromes, hormones and many things, we felt our critical care symposium will be incomplete if we don't cover endocrine emergencies. And to bring that, we have none other than Dr. K.C. Misra, who heads the unit in the Department of Critical Care Medicine in Yashoda Hospital, Somajigoda. I invite Dr. Misra to give an overview of endocrine emergencies in critical care. Thank you.
Thank you, Dr. Venkat, for your kind words. Actually, I was waiting for my turn. At the outset, I need to thank the organizer to giving this opportunity, my esteemed chairpersons, my senior, my juniors, and my colleagues. See, the topic which was given to me is endocrine emergency. It is a vast topic. It is impossible to cover in 20 minutes. Maybe the emergency in endocrine should be one-day class. So I will try to see only the most important points, and practical points we will try to discuss, not the detail. It is impossible to discuss. And let's see, like there are many endocrine emergencies. It is impossible to cover. So what do you know about endocrine system? We know like multiple things are there which are the secret hormones basically hypothalamus, pituitary, thyroid, pancreas, and your adrenal glands. They are the most common endocrine glands, what is very important when it comes to human. So these are the regulatory proteins, complicated ones, which usually works as a housekeeping for the human body. So few of the things are more often go for malfunctioning. Unfortunately, today what I believe is there is a mix of audiences. I know few slides will be more basic and few slides may or may not be that basic, but maybe we can discuss all those things later. There are a lot of endocrine emergencies. If you see, let it be glucose metabolism, the most common thing what we see in our ICUs, because we are discussing about ICU and endocrine emergencies. So hypoglycemia, diabetic ketoacidosis, hypoglycemic states, then thyroid disorders. Thyroid disorders, we have myxedema, coma, we have thyrotoxicosis, we have non-thyroid illness syndromes, or CQ thyroid syndrome, adrenal disorders, in that adrenal insufficiency, Crohn's syndrome, Cushing syndrome, all those things will come. In that, one important thing when it comes to ICU is critical illness related, corticosteroid insufficiency, pituitary disorders, parathyroid. So coming to glucose metabolism, I know it is the most common one. That is the reason I just want to spare some time. These are the basic things what we do mistakes in our ICU or day-to-day practices. Those are the things what I am going to stress upon. Let's see, glucose metabolism. We'll come to a case, a simple one. They are all hypothetical cases. They are not true cases what we see in ICU. So just to get some interaction and discussion, I've just kept these cases. A 50-year-old male patient came to ER in drowsy state, known case of a CL lung, who is already cachectic. These are the vitals. Pulse rate was high. His BP was also relatively okay, 130/80. SATs were good. So what next? Most of the time, drowsy patient coming to your ER, emergency department, the next thing what we do is GRBS, isn't it? His GRBS was 42. So 42 is low. When we should say it is significant, what sugar we should say that it is significant to say it to be hypoglycemia? It is 100, it is 80, it is 90, it is 60, it is 20. Everybody knows that if it is very low, it is hypoglycemia only. There is no doubt about it. But what the ADA, means American Diabetes Association, they say is anything more than 70 or 72 to be precise. If it is less than 70, we say it to be hypoglycemia. More than that, usually they may not have symptoms of hypoglycemia. What we say to be neuroglycopenia. If somebody is having neuroglycopenia, means the brain is involved, then we say it to be neuroglycopenia. Most of the time sugars will be low and patient will be drowsy, isn't it? That we say it to be neuroglycopenia. Symptoms, hypoglycemia usually causes adrenal secretions of adrenal things like your sympathetic adrenal system will be activated. You will have tachycardia, tachypnea, sweating, BP might be go high and all those things. What is Whipple tried? Any idea what is Whipple tried? When we say it to be neuroglycopenia, or this sugar is low and because of which the patient is having symptoms, we need to know what is Whipple's triad. These are the few basic things I need to discuss because these are the things what most of the people they don't know or may not be aware of. So Whipple triad is, one, there has to be symptoms of hypoglycemia, then there has to be a plasma glucose which should be less than around 50 and patient should recover after giving sugars. If these three things are there, we say to be this is the Whipple triad and we say that this is neuroglycopenia. Now, I just want, if at all possible, please answer. What should be your first line of treatment? We know it is a neuroglycopenia, patient is having severe hypoglycemia because of which patient is drowsy and all. What should be your first line of treatment? Dextrose 50%, 50 ml. Most of the English books we have 50%, in India it is not available. Second is 25% 100 ml, what is available in India. Glucagon 1 mg IM, and none of the above. So here the basic problem is most of the cases when it comes to our ICU, not ICU, ER, if somebody is having hypoglycemia, the first thing we'll jump to give will be dextrose. And in India, we don't have 50%, so we have to give 25% only. But the basic problem, what we need to say is thiamine. This patient is a, let's see, basically the patients who are malnourished because of any reason, or patients are chronic alcoholic. These people already have thiamine deficiency. If you don't give thiamine before giving glucose, they will end up in severe thiamine deficiency, leading to many other issues like your severe thiamine deficiency related. They can land up in Wernicke's encephalopathy, Creutzfeldt psychosis. They go into severe LV dysfunction also. Why so? Because thiamine, or this thiamine pyrophosphate, I can't show this marker. Thiamine pyrophosphate is very, very important substrate when it comes to glucose metabolism. If you give glucose in a patient who is having thiamine deficiency, they will end up in severe thiamine deficiency and consequences because of that. So first thing, in a cachectic or malnourished patient or a chronic alcoholic, first they present to the ER with hypoglycemia, first thing you should give is thiamine, then you should start glucose, isn't it? The second most, one of the important problem what I see in ER, they give 1 or 2 for 25% dextrose. When the sugar reaches 200, 300, they stop glucose and shift the patient up. That is also a wrong way of treating these patients, because they will again go into hypoglycemia. The rule is, once the sugar is more than 70 or 100, you should continue the patient with some dextrose containing fluid. You can't just stop the dextrose, because that effect by which the patient has hypoglycemia is still there. The patient will tend to go into hypoglycemia again. Third thing, patients on sulfonylureas and few of the long-acting OHS, these are the people, they can go into recurrent hypoglycemias. You just give 25% dextrose, the sugars will go up, but these people require admission and frequent monitoring. Case 2, 60-year female presented to ER obtunded. She is having a sick look. She is a known case of diabetic and hypertensive. And she is having fever since last 4 days. Her heart rate is around 118, BP is bit on the lower side, respiratory rate is high, SATs are good, and she is looking grossly dehydrated. What do you believe the DDs are? With sugars of 350? Urine ketone? Negative. Then? It can be decay, yes, no. Or maybe HHS or hyperglycemic hyperosmolar state, or honk, whatever we say. The reason why I placed this thing is, I know it is a hypothetical case. See, if you see the ABG is having severe metabolic acidosis with a pH of 7.1, CO2 is low, PO2 is normal, BICAP is very, very low, and NANGAP is 25, which is significantly high, which is a high NANGAP metabolic acidosis. The basic reason looking at this ABG, we believe with hyperglycemia, with the obtunded patient, we believe it to be a diabetic ketoacidosis. The problem with the diabetic ketoacidosis, again, this is a basic problem, practical issues what we see. Sometimes it can be negative when you see urine ketones. Because the most common ketoacid which will be high in the blood when the patient is having diabetic ketoacidosis is beta-hydroxybutyrate or butyric acid, which usually will not be picked up with our normal ketone sticks what we use in the urine. In the urine what we see is H2 acid. So that is the basic problem. Initial part of decay you may not pick up in the urine when you do a urine dipstick. You need to do serum most of the time, and most of the hospital is not available. So urine ketones can be negative if somebody is having severe acidosis with high sugars. This is decay. Clear? Now next, sodium is 125, BICAP is 5, chloride is 100, with NANGAP is 25. This thing doesn't fit. I know sir has told about NANGAP. Sodium minus chloride minus BICAP, it comes to 20 only, NANGAP you see. Then why it is, I wrote it to be 25, is it wrong or knowingly I wrote? See, whenever you have hyperglycemia, your sodium will be spuriously low. Okay, so calculation every time when there is a hyponatremia, any patient having hyperglycemia, you should correct the sodium as per the blood sugar. Every increase in 100 blood sugar from beyond 100, the sodium has to be increased by 1.6. 1.6 into the sugar minus 100 is plus the calculated sodium should be your corrected sodium. So this is a decay. So decay is classified into mild, moderate and severe on the basis of the pH, 7.25 to 7.3, 7.0 to 7.24, and less than 7 is severe. So coming to this slide, I will just tell about the pathophysiology of decay. There are three things happens when it comes to decay. So glucose utilization will not be happening because there is low insulin or insulin is available, but it is not being utilized. In those cases, blood glucose will increase. In that point of time, we will have your catecholamines kicked in, your cortisol, glucagon, everything will kick in. then what happens? Your sugars will go high up, then your lipolysis will start because of your cortisols. And because of your lipolysis, you will develop ketones or ketone bodies. That itself will cause acidosis. These three things happens. Because of a decay, your sugars will go up, your ketones will increase, and that itself will lead to ketoacidosis. Coming to this, because I am just trying to just touch upon things, decay versus this HHS. What are the basic differences you see? Decay usually develops within days, mostly in type 1 diabetes, but in our system we see most type 2 diabetes are presenting with decay, and even for the first time, they have never been diagnosed of diabetes, they are coming with decay. HHS usually over a period of time patient will become sick, and they are mostly old people. Coma or the drowsiness and all more common with HHS than decay. Blood glucose levels are very high when it comes to HHS, can go into 700, 900, whereas in decay we see around 300 to 500. Ketones usually present in decay. In HHS, even if the sugars are high, you may not have ketone bodies because they have endogenous, your insulin levels are not that low. That is the reason they don't go into lipolysis, so that is the reason their ketones bodies are not formed, and you don't usually see high ketones and acidosis when it comes to HHS. Acidemia is more common with decay, not in HHS. Ananga will be high in decay, and osmolality. Osmolality will be very, very high when it comes to HHS because of that very severe hyperglycemias. Treatment, fluid. We know fluid is the first treatment when it comes to HHS or decay. We believe normal saline should be given a liter around in first hour, then 1 liter in next 2 hours and so. But the data are slowly changing. First 2 liters or 3 liters of normal saline, then you need to change to half NS. Now things are going toward balanced salt solution, ricurhingal lactate or maybe isolate and all those things. Those are the balanced salt solution which should be used more frequently after your initial bolus of 1 to 2 liters of normal saline. Insulin, as I been taught to us, that the initial dose would be 0.1 unit per kg, bolus then 0.1 per kg infusion. But in HHS, we tend to give less insulin as bolus and infusion, that is 0.05. Sugar monitoring hourly and make sure and see frequent blood sugars, and if your insulin is working well, your sugar should drop around 50 to 70 per hour. If the sugars are going down below 250, then you need to give sugar containing fluids. Potassium, again, very, very important when it comes to decay. We know we give fluids and we start insulin. We tend to start insulin as early as possible. Before that, always check the potassium. Most of the time, your potassium will be high in decay, but still, if your potassium is low, if it is less than 3.3, you are not supposed to give insulin. If you give insulin in those cases, there will be significant drop in potassium that itself can cause cardiac dysarrhythmia. I have seen people having VTVF because they have given insulin without checking potassium. Afterwards, when we have checked the potassium was low. Every time in decay patient, when you are giving fluid and insulin, you have to give supplement potassium till their potassium is not beyond 5.4. Till beyond 5.4, with every fluid you have to give potassium around 20 to 40 milliequivalents in 500 to 100 ml of fluid when you are giving to the patient, because their potassium, they are significantly deficient in potassium. You have to supplement potassium in them. Phosphates are low, but most of the time they don't require. If the phosphate is very low, let's say less than 1.5, we need to supplement phosphates. Magnesium will be low, that also need to be supplemented. Bicarbonate and decay is a very controversial thing. At this point of time, there is no role of bicarbonate when it comes to decay. Even if the acidosis is very severe, they suggest maybe to buy time. If the pH is less than 6.9, you may consider bicarbonate to buy some time, but that also is controversial. So don't use bicarbonate when it comes to decay. Treat the precipitating cause. Let's see, in our case, there was a history of fever of 4 days. Most of the time, there is some infection, MI, all those things can precipitate decay and HHS. So those things need to be treated. Not only your fluids, insulin and all, you have to see and make sure the precipitating cause has to be treated in a proper way. Then once the patient is conscious, his NAN gap is stable, he is able to take orally, that is the time from IV insulin you can switch to subcutaneous insulin. Now coming to adrenal insufficiency. Adrenal insufficiency, you see, hypothalamus secretes the CRS, CRS will go to enteropituitary, releasing ACTH, ACTH will go to your adrenal glands, releasing cortisol. This is how it works. And 90% of corticosteroids are bound, 10% are free, which is having a half-life around 70 minutes. Cortisols are never stored in adrenal gland. Glucocorticoids usually go into the intracellular state with the glucocorticoid receptor that causes your protein synthesis and all those things. So usually causes gluconeogenesis, decreased glucose utilization, protein synthesis will be decreased and increases catabolism. Lipolysis, as I have told in decay, lipolysis will increase, will cause fatty acids. Cardiovascular increases blood pressure and it increases sensitivity to catecholamines. Anti-inflammatory properties, we all know glucocorticoids have significant anti-inflammatory properties. Adrenal insufficiency is more common than adrenal, like Cobb syndrome and all those things. So if you see primary, congenital, or the more important one, which is more common, is critical illness related corticosteroid insufficiency. What we are going to discuss is not the acquired ones or congenital ones, anyway we will not discuss. If you see secondary adrenal insufficiency, one of the most common cause, what we see in our ICU is exogenous steroid. If somebody is on long-term steroids and suddenly they have abruptly stopped steroid, they can present you with secondary adrenal insufficiency. The most, if you see the patient's primary and secondary adrenal insufficiency in adult patient, if they have skin lesions, it is primary. If they don't have skin lesions, it is secondary. Anyway, now what we'll discuss, because in ICU, we'll discuss about critical illness related corticosteroid insufficiency, which is very common when it comes to severely critically ill patients. This is because is dysregulated systemic inflammation, what is the basic physiology when it comes to sepsis, resulting from inadequate intracellular glucocorticoid mediated anti-inflammatory activity, which we believe should be there when the patient is critically ill. Usually, when there is a stress, your hypothalamic pituitary adrenal axis will behave in a different way. First, there will be multiple changes will happen. There will be activation of sympathoadrenal system, releasing lot of your adrenaline and noradrenaline. Activation of HPA will cause increase in cortisol, ACTH, and your CRH level. Whereas, and one more thing is binding protein. The corticosteroid binding protein will come down, drop by 50% by causing increase in the free cortisol levels. But most critically ill patients, they develop HPA or temporary hypothalamic pituitary adrenal axis dysfunction. There will be decreased production of all three, your CRH, ACTH, and cortisol, decreased alteration of the glucocorticoid receptors also. If you see CRH will decrease, ACTH will decrease, your cortisol level will decrease, there will be changes in the receptors also, glucocorticoid receptor, because of which we don't have the proper anti-inflammatory effect what you are supposed to see in a patient who is critically ill. So these are the guidelines. I know it's a bit old one, but this is what I got. This is a standard guideline from ESICM when it comes to CIRSE in 2017. If you see what they've told in CIRSE, the most common presentation when somebody is critically ill, which sign and symptoms which tend like push you towards thinking of CIRSE in a patient who is critically ill. These are the signs and symptoms, out of which the 2-3 important points. One is cardiovascular. Patient will be hypertensive and refractory to fluid resuscitation. Decreased sensitivity to catecholamines. They will be requiring more and more catecholamines to maintain their blood pressure. Their cardiac index will be good because LV function is good, and in sepsis we see vasodilatation. And one more important thing, laboratory finding, you will see hypoglycemia, you will have hyponatremia and hyperkalemia. If these three things are there, somebody is having hypoglycemia with hyponatremia and hyperkalemia, you are supposed to think in terms of a corticosteroid deficiency in those cases. So these are the few the guideline I just go quickly. So what you should do, like corticosteroid response, when you should say that patient is having, how to diagnose actually CIRSE. So by looking at the random cortisol or by giving ACTH stimulation test by giving 250 ml of ACTH. What they have told is there is no clear-cut recommendation which is better. You give 250 ml or 250 microgram of ACTH versus you check the serum cortisol, random serum cortisol. If you are giving 250 mics of ACTH, if the cortisol level doesn't increase beyond 9, or your random cortisol is less than 10, these are the two conditions where you need to think in terms of CIRSE or corticosteroid insufficiency. Free cortisol level versus total cortisol. They say total cortisol is good enough, no need to check free cortisol. I can't go into detail why. And they have seen 1 microgram ACTH stimulation test versus 250. 250 what they are recommending, because 1 mics, if you give ACTH stimulation, you may miss cases of CIRSE. Diagnosis, this is an interesting part. You see, instead of doing ACT stimulation test, you just give hydrocortisone to the patient, 100 to 300 mg, and see the response. If somebody is responding, we believe that the patient is having CRC. But this guideline, they suggest against using hydrocortisone 100 to 300 to see the response and telling that this patient is having CRC. You need to give 250 mics of ACTH to see the response, or you check the random cortisol. If it is less than 10, most of the time these patients are having CRC. Use in critical care conditions. Most important is sepsis. We use steroids left and right when it comes to sepsis, not in high doses, on the lower side, hydrocortisone, most of the time around 200 mg, sometimes we give up to 400 mg. But is there any clear-cut evidence for that? So if you see sepsis without shock, you are not supposed to give. There is a good trial called HYPRESS trial where they have studied, they started in all sepsis patients without shock, they started hydrocortisone, and they've seen that all these people, out of them, how many of them they went into septic shock? They didn't find much of benefit when they have compared hydrocortisone versus placebo. So with this HYPRESS trial, we can say that sepsis without shock, there is no role of steroid, but sepsis with shock, there is a role of steroid. If you see, most of these recommendations are low quality evidence only. They are low recommended, conditional recommendation, but low quality evidences. In sepsis with septic shock, there is a role of hydrocortisone, that 200 mg 4 times a day or infusion. And what they have recommended regarding the duration of the treatment, what they have told is there has to be a long course and low dose. So it is 200 mg, at least the duration should be more than 3 days. Now coming to ARDS, there is some recommendation in ARDS, moderate to severe ARDS, where the PF ratio is less than 200. In those cases, you can consider steroid. Again, this is a weak recommendation. But here the steroid is not hydrocortisone. What we choose is methylprednisolone, usually 1 mg per kg. Sometimes we can go up to 2 mg per kg. The dose, why methylprednisolone over hydrocortisone in this ARDS patient is methylprednisolone has a better penetration when it comes to lungs. Major trauma. This is also a high critical condition where you can think of giving steroid, but the data suggests against that. Don't use steroids when it comes to major trauma. If you see, we'll quickly go through few of the landmark studies when it comes to steroid and sepsis and septic shock. Corticos trial, which was published in 2008, one of the important trial where they have seen placebo versus hydrocortisone. They've given 5 days of hydrocortisone, then they've tapered the dose. They didn't see much of difference between those mortality, 28-day mortality when you in the hydrocortisone or placebo group. One more study, this is a VANISH study, which published in JAMA. Here actually there are 4 groups, vasopressin and noradrenaline plus hydrocortisone or placebo. They have seen the sepsis patient going into acute renal failure. They didn't find much of benefit in vasopressin and adrenaline group or without steroid. One more HYPRESS, as I have told, these are the cases where they have started hydrocortisone in sepsis patient who didn't have septic shock, and they have tried to see that is this sepsis patient went into septic shock. Most of the patient, there was no clinical evident or clinically significant difference between the patients who are on sepsis. If you give steroids, they will go into septic shock or not.
Dr. Misra, we will have a time limit, so...
No, I got late only. So then one more trial is adrenal, where septic shock, there is a big trial, almost 3,800 patients were included in the trial. Again, hydrocortisone versus placebo, where they didn't find much of benefit when it comes to hydrocort. But in this trial, subgroup analysis, where they have seen the shock reversal, ICU days, ventilator-free days are better when it comes to patients on hydrocortisone than placebo. This is the latest trial approaches, both are in 2018. Here actually initially started with our Zygris, which was discontinued. Finally, they have told the trial between your hydrocortisone plus fludrocortisone versus placebo. There they have a beneficial effect when it comes to hydrocortisone with fludrocortisone. So if you see the messages Surviving Sepsis campaign in 2021, in 2016 they given against the use of steroid. In 2021 again they revised it and they told that you should give steroid in patients having severe sepsis with septic shock. The dose will be 200 mg of hydrocortisone over 24 hours. And they didn't tell about fludrocortisone. So take home when it comes to CRC, steroids in septic shock still controversial. Shall we use fludrocortisone in all the patients when there is septic with septic shock? That is again a questionable thing. But the dose of 50 mics is very, very low. When it comes to requirement of fludrocortisone, it should be at least 200 or more. But anyway, we can think of adding, and duration should be at least more than 3 days. And start using steroid if at all you are using early, not late. Patient of sepsis with septic shock, not responding to your fluids, requiring moderate doses of vasopressin, you need to start steroids early than late. Do you have time? Will I go to the next? Thyroid?
Another 2 minutes, 1 or 2 minutes.
Okay. So coming to thyroid disorder, we know like myxedema and thyrotoxicosis and all those things are very, very less common. Nowadays we don't see. So what we'll try to discuss is non-thyroidal illness, what is more common in critical ill patients. We'll go to a patient like 61-year-old patient who is having multiple organ dysfunctions. Sensorium was lagging behind, blood sent for all causes of altered mental status. His TSS was very high. Free T4 is normal, but T3 is low. So do you believe patient is hypothyroid? Because TSS is so high. How will you manage these cases? This is thing called non-thyroid illness syndrome or CQ thyroid syndrome. These are the cases where they may have thyroid hormonal imbalances or the levels will be different, but usually they don't have any previously diagnosed intrinsic thyroid disorder. These are CQ thyroid syndrome. If you see most of sick ICU patients, if you do a thyroid hormone, 70 to 75% people can have deranged thyroid hormone levels. So if you see like in 1982 by Banan and Watzkowski, sorry actually my pronunciation is not that good, they have coined the term called CQ thyroid syndrome. Prevalence is very high, 40 to 70% when it comes to ICU patients. And sepsis, surgery, myocardial infarction, what we see more often in the ICU, they can precipitate a condition called CQ thyroid. And most of the thyroid is bounded to thyroid globulin and albumin. I will not go into detail of those things. There are enzymatic changes, D1, D2, D3 activity, because of which we'll end up in this kind of picture when it comes to CQ thyroid syndrome or patient who is critically ill. What we see is reverse T3 will be very, very high. Their TSH will be normal or high. Their free T4 and T4 levels will be low and T3 will be always low. And that too, it corresponds more with the severity. More the severe disease, more drop of this T3, T4 and free T4 will be there. Told already. Why we should check, maybe there are data, what they have suggested is when your T4 levels are very low, it suggests very high mortality or vice versa. If patient is very sick, their T4 level will be very low. So whenever T4 levels are very low, they have a higher mortality. Similar, one more study also, they have seen that even they have compared your T4 level with Apache. So if your T4 levels are very, very low, it corresponds better about the mortality than Apache 2. So low T3 and T4 levels can correlate well with the mortality. These are all studies on more or less same only. So they have seen like most of the time when your T4 and T3 levels are low, these people in critically ill, they have a higher mortality. So if you see in Apache, this study done in India only, wherever you have seen Apache of more than 20, in those cases, the T4 levels, free T4 and T3 levels are significantly low. So when they are very sick, that is corresponding well with your thyroid hormone levels, basically T3 and T4. And those who are died, if you see died and recovered people have free T3, T4 levels are better compared to the people who died having critical illness. They are all old things. I know I am not teaching endocrine people endocrinology. They know better than me. But anyway, low T3, T4 and free T4 can suggest that patient is significantly ill and they may have higher mortality compared to a person having normal values. So these, what we believe is usually adaptive or protective. This is against hypercatabolism or it may be a maladaptive. Do we supplement free T3, T4 in these cases or thyroxine supplementation should be done in these cases, try to correct those things. The studies are against that. So normalization of serum T4, T3 didn't show any mortality benefit. And acute renal failure also they have tried, they didn't see much of benefit if you supplement T3 and T4. T3 administration in sepsis, they have seen some improvement in blood pressure, cardiac index has improved and all, but overall mortality didn't show much of beneficial effect. So when you should, how will you diagnose that in a severe acutely ill patient with this kind of, anyway you may have significant thyroid hormonal changes, when you should say that it is really a acute thyroid or the patient is having hypothyroidism. If don't rely on one test, you need to repeat the test after the patient get better and out of this critical illness, after a week or so you need to repeat the thyroid hormone again and see that those thyroid hormones pointing towards what. If your TS is very, very high, let's say more than 25, 30, it is usually hypothyroid. If your TS is around 10 and reverse T3 is high, then it is CQ thyroid. Replacement of T4 or T3 anyway is not available in India, cannot cure the patient who is having non-thyroidal illness or CQ thyroid. Modest increment in overall physiological function can be there if you supplement them with thyroxine, but mortality benefit is not there. It is not a magic bullet where you should start giving all sick patients having T4 low or T3 low, start giving this thyroxine and other things. But maybe in future we may have better answers, but I didn't get any recent studies on this. They are all studies, whatever I have shown, they are old studies. Recent studies I was going through, but I didn't get much. So these are the commonest endocrine issues what we see in ICU. There are many. Let's see, thyrotoxicosis, myxedema, hypopituitarism, all those things are very less common when it comes to ICU, and with the constraint of time, I can't touch upon all those things. With this, I will stop here. Thank you.
Thank you, Mr. Bringing that all those overviews in a quick time. We'll take questions. Any quick questions from audience? We can request all the speakers to come on the dais and.
These are very tricky patients. Actually, there is a live case right now in my ICU. So basically, when you see a congestive heart failure, I will just tell a live case which we are treating. She is better now. You see, they are congestive heart failure, they are fluid overload. So in those cases, it becomes very difficult to give them fluid. But sometimes, yes, if your IVC is collapsed, you believe the patient is dehydrated. In those cases, with some NIV or maybe some ventilator, you can give some fluids. But in our case, the live case, what I am telling, not like severe decay, her pH was not very low, ketones were mild to moderate. In those cases, we can still give diuretics, and we gave diuretics. There are the dicey situation where each and every patient is different. You have to take a call looking at the patient. We can't have a standard guideline that CCF with a decay you should give fluid or you should give diuretics. But in our patient, we gave diuretics, we escaped, patient stabilized. So these things, patient to patient, we have to take a call, sir. Very difficult questions to answer as a single liner.
Okay. Any questions? Any other questions to our speakers? When you saw the first lecture, most probably the ABG, you might have been thinking that such a complicated thing. But the best way to always have a good hold on ABG is to practice it every day. So once you do it every day, it becomes very easy, and it doesn't seem so difficult. So that's the best way to practice the ABG. Any other questions you have for our speakers? So we'll close the session. Thank you.
Thank you, doctors. It was a great session. Thank you, doctors. It was a great session. We are thankful to our eminent speakers and panel members to ponder the latest update in critical care. Now it is the time for the felicitation. I request Dr. Pratima Raj ma'am to please come on the dais to felicitate our speakers. I request Dr. Masood Muhammad sir to please come on the dais. I request Dr. Shweta ma'am to please come on the dais. I request Dr. Mahati Priyadarshini ma'am to please come on the dais. I request Dr. K.C. Mishra sir to please come on the dais. Here, the Dr. Pratima Raj ma'am is felicitating our speakers, Dr. Masood Muhammad sir. Dr. Mahati Priyadarshini ma'am. Dr. Shweta ma'am. Dr. K.C. Mishra sir. Thank you, ma'am. Now it's the time to felicitate our panel members. I request Dr. Malik Merchant sir to please come on the dais and felicitate our panel members. Dr. Malik Merchant sir. I request Dr. Venkat Raman Kola sir to please come on the dais. Dr. Madhusudhan Jaju sir to please come on the dais. I request Dr. Pavan Kumar Reddy sir to please come on the dais. I request Dr. Bhavani Prasad Godavalli sir to please come on the dais. Thank you, sir. Thank you, doctors. I request all the speakers to please come on the dais and panel members to take a photo. I request all the speakers as well as the panel members to please come on the dais. Thank you so much, doctors.
Learning is a never-ending process. We at Frontiers Diabetes Awareness and Research Society encourage postgraduate students to showcase their skills and knowledge. Now I welcome Dr. Mohammad Ataullah sir, Academic Committee Chairperson on the dais.
Good morning, everybody. A very warm welcome to all of you. And this is the 5th edition of the Frontiers Diabetes Awareness and Research Society program. This gives us an opportunity to bring together the brightest minds in the field of diabetes to discuss treatments and strategies to reduce prevalence and improve patient care. And the theme of this year's program is spreading awareness about non-communicable diseases, if not now, when. And the content of the program is not only to deliver the pragmatic practice pearls, but also find valuable solutions to the metabolic problems which are suitably addressed in patients worldwide. And the collaboration and camaraderie shown by the faculty in the previous FDARS events has been excellent. And we would like to highlight a special program, the Gurukul program, particularly for the PGs, which have been, it's been a very good program for them because consultants and senior consultants get an opportunity to get all these programs, but the Gurukul program is exclusively for PGs. And we have seen that exponential rise of new drugs coming in the field of diabetology day in and day out. Every day one new drug comes, and how best we can use these drugs despite the fact that we do have so many drugs at our disposal. Screening and prevention should be our main motto. For that, a special session on nutrition, a special session by Dr. Bhandari sir, who has come all the way from Delhi, and he will be talking to about this program. And we believe that this event will give us an opportunity to scale up the right practices to improve diabetic care in Indian practice. And importantly, we have a poster presentation, and we have received posters from almost 16 medical colleges from Telangana, from Andhra Pradesh, and even from remote places like Assam, as well as Punjab. So this gives us an idea that this FDARS program is increasing in popularity day in and day out. So out of which we have received 82 papers, and 35 are displayed in Hall B. And at the end of the program, we will be distributing prizes to 3 top papers, and we will be distributing the prizes to them. So thank you for giving me this opportunity, and I hand over back to the organizers. Thank you very much.
We apologize for the delay. It will take just 2 to 3 minutes to overcome this technical issue. Thank you for your patience.
As you all know, our entire session is divided into different symposiums. Now it's time to get updated with the latest development in the medicine. I invite Dr. V. Srinivas, Scientific Committee Co-Chairperson, on the dais.
Dr.
Good morning, everyone. Welcome to this wonderful academic feast. So after just going today morning in this critical career, now we'll come to the mother of medicine, clinical medicine. So we have wonderful speakers all over our country from north, east, west, south. Before inviting our speakers, I would like to invite the panel members for this session. So we have Dr. Vijay Kumar, who is a senior consultant physician diabetologist from Bangalore. Dr. Sriranga Kari, consultant physician senior from Uday Omni Hospital. Dr. Minaz Zafar, the senior consultant psychiatrist, head of the department, Deccan Medical College. So we have divided this session into 4 wonderful topics. All of us know, starting from subclinical hypothyroidism, is always an important question whether to treat or not to treat. To be taken by Dr. Supradeep Bhattacharya, And another important topic, non-alcoholic fatty liver disease, and the hidden epidemic all of us know after alcoholic liver disease. And sarcopenic obesity, very, very important topic in clinical medicine. And beyond medications are very, very important, especially in chronic diabetic patients, any other chronic disease, a component of psychosomatic illness. So lifestyle and behavioral modifications, what we'll be dealing with Dr. Malik Marchant. So I request all our panel members to kindly come out to the dais. Yeah. Dr. Vijay Kumar, Dr. Minas, and Dr. Srirang Apkari. Now it's a pleasure to invite Dr. Supratik Bhattacharya, who is the Director, SK and Diabetes and Endocrine Center, Kolkata, the Consultant Department of Endocrinology, AMRI, and Apollo Sugar, Kolkata. He has various publications to his credit, 30 international publications and national as a first author of the first 5 book chapters, an international editor of BGEM, a part of multiple phase 3 or 3x4 studies, including global diabetes Ramadan studies. Has got to his credit various awards like Inspiring Endocrinologist and Diabetologist of India 2022 Economic Times, RSDA 2020 Award for the Best Innovations in Diabetes Care, and his achievements as a founder, president, AMOCE, speaker at various national and international conferences, organizing chairperson for National Obesity Conclave. So I request Dr. Supratik Bhattacharya to come out to the stage.
Thank you, Dr. Srinivas, for all your kind words of introduction. Thank you, Dr. Faraz, for this invitation. Thank you, Dr. Kola, and the entire team of Frontier Diabetes, and a warm welcome to all of you who has joined today. So, I'm going to talk about a very practical topic regarding subclinical hypothyroid. This is a condition that you come across in your clinical practice, and many a times we ask the question whether to treat this or not. So, let's define subclinical hypothyroid. So this is a condition where the TSH level is persistently over 4.5 and a normal total of free T4 and T3 and few or no signs or symptoms of hypothyroid. Now, if you divide the patients of subclinical hypothyroid, clearly there's one bracket where the TSH is between 4.5 and 10, and there's another bracket where they're asymptomatic, but the TSH is more than 10. If you look at the epidemiology of subclinical hypothyroid by various groups in India in particular, you see that the numbers can vary anywhere between 8% to around 10%. Now, severity of primary hypothyroid, if you look, TSH is a very sensitive marker, and this is the one which rises first and rises very abruptly, and then followed by decline of T4 and T3, which is slower and later. What about the etiology? So most commonly, it's Hashimoto's thyroiditis, and individuals with subclinical hypothyroid are often asymptomatic, as we had said. Clinical manifestations can include non-specific complaints, or those that are seen with hypothyroid. There can be hair fall, there can be dry skin. In females, there can be problems with the menstruation. So all of these, some of them come with concerns regarding weight gain, cold intolerance, constipation, etc. So we need to rule out transient increase in TSH levels before giving it a diagnosis of subclinical hypothyroid. And commonly known causes of elevated thyrotropin levels unrelated to chronic mild thyroid failures could be either a transient rise in thyrotropin, like recovery from non-thyroidal illnesses, recovery phase of various types of thyroiditis, medications like amiodarone or lithium, and lack of adherence to the treatment. This is very, very common. So we need to have inquired about this, take a very good history to understand the compliance. Also, there could be cause of persistent increase in the thyrotropin levels combined with normal or free T4. And physiological adaptation to aging is one of them because there is a change in the set point, assay interference, obesity, adrenal insufficiency. These are all of the causes that needs to be looked into before classifying this as subclinical hypothyroid. Now, progression to overt hypothyroid, this is one concern that we always have. And there is very high rates of conversion from subclinical hypothyroid to overt hypothyroid, and the progression rate is anywhere between 2 to 6%. And the risk is even more in females, individuals with higher levels of TSH and presence of anti-TPO antibody. What about the cardiovascular risk in subclinical hypothyroid? So we see that cardiac function in subclinical hypothyroid, and this is the most consistent cardiac abnormality reported in patients with subclinical hypothyroid, and that is the left ventricular diastolic dysfunction. And results concerning systolic function at rest are not very consistent. Subclinical hypothyroid has been associated with an increased risk of fatal and non-fatal chronic heart disease, and meta-analysis of the cardiovascular morbidity and mortality had shown that there are high chances of chronic heart disease in those with subclinical hypothyroid. The risk of heart failure events were also increased in both higher as well as lower TSH levels. So those who have very high TSH levels can have higher risk of heart failure. Similarly, in the very low brackets also, there are high risks of heart failure. Subclinical hypothyroid is also associated with adverse prognosis when it comes to heart failure patients. So all-cause mortality, and there is a very high increase in the cardiac event rate as well. Okay, so this is a meta-analysis of 16 observational studies showing high total cholesterol values. So one of the reasons to treat in subclinical hypothyroid is to address the cholesterol, address the cardiac issues. As we said, there are high incidences of heart failure, diastolic dysfunction, and lipid disorders. So these are the ones that can drive you to treat subclinical hypothyroid, if at all. Carotid intima media thickness and metabolic parameters, a reduction with LT4. So when you're treating subclinical hypothyroid with thyroxine, we do see that there is a reduction in the carotid intima medial thickness. Also, increased all-cause mortality in subclinical hypothyroid is seen, and that is again a driver to treat subclinical hypothyroid. Long-term untreated subclinical hypothyroid can result in hypertension, cardiovascular abnormalities, endothelial dysfunction, increased arterial stiffness, and dyslipidemia. And all of these would be increasing the cardiovascular morbidity and mortality, resulting in coronary heart disease, heart failure, and atherosclerosis. Now coming to another very sensitive issue regarding subclinical hypothyroid in elderly individuals, whether to treat or not treat. So there is a change in the set point when it comes to TSH in the elderly individuals, and there's definitely the thyroid function does change with age, and as you can see in here, with advancing age, the TSH set point is increased. So this suggests that TSH increase arises from age-related alterations in the TSH set point or reduction in the TSH bioactivity rather than occult thyroid disease. Now, thyroid hormone therapy for older adults with subclinical hypothyroid, when is it relevant? So if we divide them into two brackets, one who are less than 70 years and those who are more than 70 years, and we will try and show you the evidence for and against treating hypothyroid in these age brackets. So the question is, treat or not treat in elderly individuals with subclinical hypothyroid. So new subclinical hypothyroid patients were identified, and in this particular study from UK, around 4,700 odd patients more than 40 years with TSH between 5 and 10, and normal free T4 were chosen, and obviously excluded individuals will be those on treatment with thyroxine, ATDs and previous thyroid disorders, previous IHD, stroke and vascular disease. So it was shown that there were fewer cardiovascular events in those patients between 40 years and 70 years who were treated with levothyroxine. There were also decreased all-cause mortality in this particular age bracket between 40 and 70 years when they were being treated with levothyroxine. However, when you are talking about those individuals who are more than 70 years with subclinical hypothyroid, there seems to be an increased cardiovascular events in this particular age bracket, and hence treatment with levothyroxine is not recommended in any individual more than 70 years. So you have to justify to treat anybody with subclinical hypothyroid when it comes to any elderly individual more than 70 years. So again, increased all-cause mortality in those individuals more than 70 years being treated with levothyroxine. Now, decreased total cholesterol levels with LT4 or levothyroxine in mild subclinical hypothyroid patients was also seen. General therapeutic approach to management of subclinical hypothyroid in non-pregnant adults. So anyone with more than 10, even asymptomatic, needs to be treated. Anyone who is planning to conceive in females, you need to treat subclinical hypothyroid. Factors favoring levothyroxine treatment in patients with TSH levels less than 10 will be therapeutic trial for clinical symptoms like goiter, degree of TSH that is raised if it is more than 8 with positive anti-TPO antibody, progressive TSH increase. Again, one thing to be considered is patient's preference, young age of the patient, and obviously if you have cardiovascular risk factors like dyslipidemia, if somebody is suffering from diabetes and subclinical thyroid with dyslipidemia, again, that's a consideration to treat. Anyone who is intending to conceive in females, obviously you need to treat subclinical hypothyroid. So anyone who is having a TSH level between 0.4 and 4.4, this is the normal TSH reference range. Anyone who is having a TSH range between 4.5 and 6.9, if they're aged more than 65 or 70 years, treatment is not recommended. If they're less than 65, if they're having multiple symptoms, if they're having positive anti-TPO antibody, if they have progressively increasing TSH levels in females planning to conceive, or they are having goiter, these are the reasons to treat in this particular TSH bracket. Anyone between 7 and 9.9 TSH, if they're less than 65 years, treat with levothyroxine to reduce the risk of fatal stroke and coronary heart disease. And also, in those individuals more than 65 years, you have to take a call whether you want to treat it. And if you feel that that's going to benefit them in terms of preventing a future cardiovascular event, then you might consider treating them. If the TSH is more than 10, then it's better to treat with levothyroxine to reduce progression to overt hypothyroid, and also because to prevent heart failure, coronary heart disease, and increased mortality. So this is the general guideline that has been given by ITS. So if there's increased TSH, you confirm, repeat after 3 months. If the TSH between 4 to 5, then you need to see whether there are positive anti-TPO antibodies. And if there is symptoms of hypothyroidism, cardiovascular history, goiter, then you need to treat. If they're asymptomatic, anti-TPO antibody is negative, age is say less than 70, then you can repeat TSH after 6 weeks, and then 24 weeks, and then annually. This is the screening protocol. And if the TSH is more than 10, then you need to treat. If the person is intending to conceive, then you need to treat, of course. Subclinical hypothyroid, and this is the European Thyroid Association guideline. This is very, very similar in terms of what we had already mentioned. So if the person has symptoms, then you need to sort of give a 3-month trial of levothyroxine and assess the response to treatment. If they don't have any symptoms, then just observe and repeat the TFT after 6 months or so. If they're aged more than 70 years with a TSH less than 10, observe and repeat TFT after 6 months. And if they have clear symptoms of hypothyroid or have very high risk of a future cardiovascular event, then you need to treat. So I'm not going to go into the details of this. These are more or less in the same lines, whether we are talking about the American College or the ATA. They usually talk about in the same lines. Now, coming to the treatment recommendations, oral levothyroxine is the treatment of choice. Those who don't have cardiovascular disease, the starting dose is based on the body weight, and it's usually between 25 to 75 micrograms per day. Patients with cardiac disease, you need to start low and go slow. So you can start even with 12.5 micrograms or 25 micrograms and gradually increase the dose. Elderly patients, again, you start low and go slow. You can start as low as 12.5 or 25 and gradually go up. So the take-home messages from my today's talk will be thyroid hormones do regulate the cardiovascular system to meet the body's energy consumption, and it's a very important hormone for the body. Subclinical hypothyroidism leads to alterations in the cardiac contractility, vascular function, lipid profiles, and also lipoprotein metabolism. Levothyroxine treatment reverts several of these alterations and may benefit those with subclinical hypothyroid if they're aged below 70 years. Treatment of subclinical hypothyroid improves cardiovascular risk factors and symptoms and may improve cardiovascular risk in younger individuals. So we need to be very proactive when it comes to the younger individuals in treating subclinical hypothyroid or those who are intending to conceive. So with this, thank you so much for your kind and patient hearing.
Thank you for an excellent disposition on subclinical hypothyroidism. Diagnosing itself is difficult, and then the various intricacies, when to treat, how to treat, and then the subgroups of elderly population, pregnancy are very important. You've highlighted it very crystal clear. If there are any questions, we invite brief questions. Yeah, please, sir.
I think he has a question. We'll take the mic and we'll take the question.
Supratik, it was a wonderful talk. I enjoyed the whole session regarding subclinical. Supratik, in a routine clinical scenario, if you see any case like SCH or any overt hypothyroidism, certain patients are still, they feel unsympathetic and dismissive. So in this case, what is our take home over there? Because there are certain
Just repeat the last part of your question, please. I didn't
unsympathetic, unimpressive, dismissive symptoms they will have. They will have the skin rashes, dry skin, then hair fall like that. Is there any category of like tissue hypothyroidism or cellular hypothyroidism should be treated, should be diagnosed properly for resistant cases?
So you need to say that a person has come in with subclinical hypothyroid, but symptomatic.
Even though we are given the total treatment for subclinical hypothyroidism, her TSH is normal, but patients still feel the hypothyroidism symptoms. Clinical finding will be there. So is there any category of tissue hypothyroidism or cellular hypothyroidism like that should be considered?
It could be, but treatment protocol-wise, we need to either show that they have a very high anti-TPO antibody, they are symptomatic, or their TSH levels are either in the subclinical hypothyroid zone or overt TSH. So we cannot treat with levothyroxine just based on the symptoms if biochemically they are euthyroid, or if the anti-TPO antibody is negative. None of the guidelines actually say that you need to treat a biochemically euthyroid person even if they're symptomatic. So any treatment is in the subclinical hypothyroid bracket or overt hypothyroid bracket with symptoms or with positive anti-TPO antibody.
Thank you. I think if he also was asking if after treatment, the biochemically normal, but symptoms persist, but the symptoms may take time to come down even after biochemically being normal. Probably that is the point.
Correct.
Similarly,
we'll have questions after Raghu Ramlu sir at the end of the session. Sir.
After treating the patient with subclinical hypothyroidism, still they are complaining of dry skin and rough skin, and that will not be changing even after 6 months of this therapy. So is there any other ways and means to improve?
So we need to investigate if there are any other reasons for dry skin in particular. We need to moisturize the skin, of course. If we need to find out whether they're moisturizing properly or not, and if there are any other precipitating causes for dry skin. Hypothyroid is probably one of the causes, but there might be a number of other causes as well. Please take the microphone. We will just take this last question because I need a flight to catch, so we'll finish this.
Yeah.
Sorry, sir. So you told me we start with the low dose of 12.5 microgram. How you will increase the dose depending on the reinvestigations of the TSH levels? In what duration we have to go for the reinvestigation to increase the dose or decrease the dose?
So usually whatever dose you change, that takes about 6 weeks to reflect onto your blood report. So I
Investigation. After the how much period we have to go for the other investigations like T3, T4, TSH?
Yeah, so
The
I do a
duration,
free
because
T3.
most of the patients will be asking what duration we have to go for the T.
So we said that if it's a younger individual, you need to give full replacement. So usually between 50 micrograms or 100 micrograms based on the body weight. And then you call them back, usually after 6 weeks. Yeah. So this is the first follow-up. And then if they're stable, you can call them back after 3 months or 6 months.
Yeah, Dr. Bhattacharya, thank you. Will not hold you for long. It was a wonderful presentation and good discussion happened. Thank you very much for being here.
Thank you so much. Thank you. Thanks a lot.
So after diabetes and thyroid, now I think we have the liver in the more focus in the coming days. Non-alcoholic fatty liver disease. Is it an hidden epidemic or what? We have one senior consultant talking on this, Dr. Vinod Mittal. Dr. Vinod Mittal is the head Center for Diabetes and Metabolic Diseases, Delhi Heart and Lung Institute. Also, he is the director, Delhi Diabetes Care Center, and he was the past chairman and secretary for the RSSDI Delhi chapter, and also the national faculty for the CCE-BDM. And he has got a vast clinical experience for 33 years in the field of diabetes. His honors are he's got a national award for excellence in diabetes care in 2018 by the RSSDI, Diabetes Awareness Initiative Award in 2017 at Diabetes India, and also he's honored with the Dr. Sarita Bajaj Oration in 2019. He's also a principal investigator in many research and projects, trial, national and international, and has got several publications in peer-reviewed journals and chapters in various books. Dr. Vinod Mittal, welcome you. Please take over.
Yeah. Very good morning, everyone. It's my proud privilege to be here to share my knowledge on NAFLD. It's taken as, a very, very mild or a negligible problem, but it's a very significant problem. So it's a hidden epidemic. We've had, epidemic of obesity, diabetes, CVD, hypertension, and I think this is the next upcoming. There are conferences, which are for 2 to 3 days only on NAFLD. Try to understand. So it's parallel to, and NAFLD is not only the risk factor for future chronic liver disease, more than that, it is a future risk factor for CVD. So if a patient comes to us with NAFLD, no other, try to find out other cardiovascular risk factors and treat. So before patient develops CLD, patient may have CVD and may have mortality or CV event. So that point is, one we have to understand, and we have to be very, very, we have to be alarmed, and we have to be ready to deal with the NAFLD right, from day one. So basically, it's a hidden epidemic, and everything, all this is insulin resistance syndrome, common soil, whether it is CVD, NAFLD, obesity, hypertension, or diabetes. General population, we have almost 1/3 of people who have NAFLD, and diabetic hypertensive obesity, it's almost 70 to 80%. Don't imagine that patient has to be obese, even central obesity, so-called thin fat, typical Indian phenotype, NAFLD is very common. So type 2 diabetic patients, almost 70% have NAFLD. So that point has to be well understood by all of us. And as I mentioned, it is more often a cause for CAD or CVD than CLD. CLD will take years to occur. There are many studies which have been done in India and abroad. And one thing is very clear, that the severity of diabetes also is associated with the severity of NAFLD and vice versa. Higher the NAFLD risk score, higher would be the severity of diabetes. So both go parallel. And this is the basic spectrum we can see here. The first one, we start with steatosis, which is just, accumulation of abnormal quality and quantity of fat, both. So that is basically steatosis. Then there is a NASH, steatohepatitis, and ultimately CLD, cirrhosis of liver, and hepatocellular carcinoma is also very common in these people. World over, the commonest cause for cirrhosis of liver is NAFLD, not alcohol now. You must be knowing all this. So this is basically, a multiple hit story, hypothesis that when there is a energy dense calorie is taken, which is rich in carbs, which is mainly rich in carbs and then of fat, and total calories are more, this excess calories get stored inside the liver and in the form of glycogen, and extra will then spill over as free fatty acids in the blood, insulin resistance. So this cycle keeps on repeating, and then there is an accumulation of fat, there's a central obesity initially, there's a bright liver on ultrasound, the initial stage. It may not having, fibroscan may be normal, and then ultimately, there's very slight, if a patient has NAFLD, liver function test may not be abnormal. Only the upper border, maybe, SGOT-PT around 45, 50, that should be taken as significant. Upper borderline values of liver enzymes are important. And then ultimately, if once there is cirrhosis, like we know, decompensated liver disease, everything is there. So basically, we can say that NAFLD is a hepatic manifestation of insulin resistance. Simple, very simple. And there is accumulation which is abnormal in terms of quality, more of triglycerides, and quantity. Both are abnormal. And that leads to inflammation and necrosis. There's a twin cycle hypothesis which is going on whenever there's a, energy dense calories, or more diet is taken. So one cycle I've already told you is liver. There's accumulation of fat in the liver, here we can see. And then this is the liver cycle, and this, leads to accumulation, of free fatty acid release in the blood, increased VLDL in the blood. Now, this increased free fatty acid, even 1 gram of free fatty acid, 1 gram is taken up by the pancreas. Accumulation of only 1 gram of this abnormal fat, it leads to apoptosis of beta cells. Beta cell deficiency starts the same day. Okay, so just 1 gram, try to understand. So there's so much of spillover going on. Pancreas also takes up this, and that leads to basically insulin suppression of beta cell function. So one side, liver cycle, there is an insulin resistance going on, and other side there's an insulin deficiency, and there's a vicious cycle goes on, and there's, development of diabetes and other risk factors. Now, NAFLD, there is again, a common, it's just as I told you, it's in the center. So adiposity, diabetes, and cardiovascular, it's a very, very common thing. So never neglect NAFLD. Normally people say, Dr. Sabai had gone to, get an ultrasound done, it showed some fatty liver, and so which is just passed as normal. Take that as serious as CVD. Patient might be having CVD or subclinical cardiovascular disease. So this is, basically, as we say, CVD is a continuum, diabetes is a continuum. So NAFLD is also continuum. It starts with a very small problem, just on the accumulation, and then it goes on. So it is a continuum like diabetes, metabolic syndrome, and say insulin resistance. And, basically there is increased resistance in the liver, and other side, there's atherogenic dyslipidemia, diabetes, so everything combined, and ultimately there's so CVD, so it's a complex, it's a kind of a crosstalk going on between different cells and leading to multiple inflammatory processes, leading to many diseases. Now the key mechanisms are at molecular level. There's adiponectin, is as such low in Indian patients, thin fat Indians. We have low. That is why there's more of diabetes. And similarly, other adipocytokines are high. IL-6, TNF alpha, mitochondrial dysfunction, gut microbiota dysbiosis. This is another thing, that patients who are obese, they have dysbiosis. Which again leads to, because now the latest hypothesis is the gut microbiota controls brain, not brain controlling. Normally we think brain controls everything. So now the gut microbiota is playing the most important role in having diseases, not only for insulin resistance, even for autism, even for psychological disorders, many disorders, cancers. Now this is an incoming thing. In future we'll have specific prebiotic for specific diseases. NAFLD, CVD, they are correlated well, and we can see basically this is again CVD. We already know Indians are genetically predisposed. It's occurring a decade earlier. Multiple vessels are involved, poor outcome despite of best of the treatment, inflammation, and basically PAI1 also is high. Atherosclerosis again is an inflammatory process, and it starts even before the development of diabetes. We already know it. In a stage of IGT, patient is at a risk of cardiovascular disease, and that is because basically atherosclerosis has already set in. So what I want to convey that we have to act much before the clinical development when the symptoms appear in a stage of adiposity or pre-adiposity or central obesity. Now, so basically overall pathophysiological mechanisms are there's a systemic insulin resistance, endothelial dysfunction, altered lipid metabolism, systemic inflammation, plaque formation, and then oxidative. Everything is going parallel. So that has to be seen, and we have to target all these abnormalities at the same time. NAFLD, again, like we had just a talk, on subclinical hypothyroidism. Similarly in NAFLD, it is not only CAD, it is even, we can see hypertrophy, heart failure, aortic valve stenosis, atrial fibrillation. They are more common. Similarly, in subclinical hypothyroidism, this point again you must see atrial fibrillation is commonly associated with subclinical because thyroid is involved in our heart functioning also. So some people have, and there we have to act immediately. So basically today millions of livers, we used to say heart every time, now it is liver, which are suffering in silence. They are having a problem which we are not knowing because of our ignorance. And I want to make this basically awareness kind of a thing that we should be well aware. This is an incoming epidemic and we have to be very, very serious on this. Diagnosis basically, is now depending on a couple of parameters. One is the clinical, FAB score, you must be knowing, I'll be talking about this. FIB-4 index is the most important, and then EST-ALT ratio, and then, fibro test, and fatty liver index. And then we have imaging studies. Ultrasound is a very small test, but then, the best is either CT or magnetic resonance elastography is the most sensitive test for, and if you want a diagnosis, then obviously it is a liver biopsy. And the number of biomarkers are also under, study, which are hyaluronic acid, and ELF score, and basically PROC3. So this is the most important score which we have to understand. There's a formula, but what we need is, like we always calculate albuminuria, EGFR calculation, we need age, serum creatinine, and other things put in an app, and you get EGFR. So similarly, we need only age of the patient, EST, ALT, and platelet count. Platelet count is very, very important. All cirrhotic patients have low platelets. Take my words, start doing their platelets, 60,000, 70,000. Similarly, early stages of NAFLD, it may start decreasing. A decrease in a platelet is an important parameter to diagnose NAFLD onset and increase upper borderline SGOT-PT. So we don't need many parameters, just platelet count and SGOT-PT, because sometimes ultrasound is not available in the remote area, and but these tests are available, which I'm telling you. And other are important. Our EPRI is a, basically SGOT platelet, ratio index. So this is again, as I mentioned, that liver enzymes go up and platelets go down. so we can find out clinically. This is the best possible test, for liver stiffness, magnetic resonance elastography, but this is only for diagnostic or rather research purposes, not for the routine testing. Now, as I mentioned, there are now, conferences, 3 days conference just happened in US on obesity and NAFLD, drug development. And, so this is the in thing now. Now, other important point is, we always call NAFLD, I think now we should start calling it as MAFLD. It's a metabolic dysfunction associated liver disease, okay? It is not non-alcoholic. It is a non-significant intake of alcohol. That's one point which goes against. It is totally not that non-alcoholic. The other is, even like, viral hepatitis leading to CLD is also not included in NAFLD, which is non-alcoholic. So other causes of liver disease also have to be ruled out. Okay. So basically, it is not just, so it is metabolic dysfunction associated liver disease, which is, the latest now, the term which we have to use. So basically, evolution of this was like, initially we used to call it as like fatty liver and then, NAFLD. It is metabolic associated liver dysfunction associated. So basically, for this, what we need is for this metabolic, like we know metabolic syndrome, there are IDF has designed 5 parameters. So one is central obesity, and the rest of the 4 as blood pressure, HDL, triglycerides and blood glucose values. So central obesity plus any of the 2, if plus it is a metabolic syndrome. So we have to basically see to that 2 of those parameters, and plus HOMA model, if insulin resistance score is more than 2.5, if it is available. So that's how we basically so basically when patient comes to us with diabetes with other features of central obesity, it is automatically a metabolic syndrome, and if so we should imagine and think there may be NAFLD already there. So basically now management world over as of today, no single drug is been approved only for NAFLD. If patient has diabetes with NAFLD, then we give metformin, pioglitazone, DPP-4 inhibitors, even SGLT2 inhibitors have shown, and GLP-1 analogs. But diabetic patient, not non-diabetic, okay? If patient is obese, NAFLD, maybe we can go even for bariatric surgery. So associated comorbid condition is to be treated, but just NAFLD, it is only weight reduction and low fructose containing diet. As of today, only one drug has been approved, which I'm going to unveil today in January 2023 for NAFLD. So one thing again I will repeat, we people call vitamin E and saroglitazar, yes, that's another molecule, but only DCGI has approved. It's a dual PPAR gamma and alpha agonist. Only DCGI. We don't have large long-term studies, very small studies, not FDA approved. Okay. So as far as the approval goes, we don't have. All these other agents which we use are only there in the trials, but not in the guidelines. So basically when we have to address NAFLD, it is one is lipid metabolism, other is inflammation, and third is fibrosis. Even anti-fibrotic agents are under trial. I'll be telling you one of those. So now things have moved much ahead, and a lot of molecules are under trial, and maybe in future we may have better molecules. So basically potential therapeutic targets for NAFLD if patient is diabetic is biguanides. I have already told this. And then this is the first molecule which has been approved is resmetirom. Has the potential to be the first medication approved. Don't take it as it's not a sponsored program. It's only a new drug. It is not even available in India. It is available in US only. So, and there also it is not yet available. In a couple of months only it would be available. So it's a Mestero, NAFLD1 study showed clinically, a randomized controlled trial that resmetirom is a good it's approved, it's the first molecule approved for NAFLD, and it is basically a thyroid hormone receptor beta selective agonist. It increases energy expenditure. That's how this molecule is acting. So this is the first molecule approved, and these are the various effects of resmetirom. It acts on different, at the level of cholesterol directly, then lipid droplets, and then even at mitochondrial level. So multiple levels it is acting.
So another 5 minutes.
Yeah, I'll do. So potential therapeutics, now we have, the latest are GLP-1 analogs. They are also being tried for NAFLD. And we have a dual GLP-1 and GIP agonist, which is tirzepatide. It is not again available in India. It is available in US. It is one of the best, GLP-1 and GIP co-agonist. So multiple, agents have been tried. Then saroglitazar is a PPAR, gamma, alpha, and beta. So as I mentioned, saroglitazar is approved by DCGI. These are studies, evidences, 1 to 4, but small studies, short-term studies. Then in glitazons, pioglitazone is very good, but not for non-diabetic patients. Again, I'll repeatedly will tell you, non-diabetic patients, we don't have this medication, and we have another molecule, lobeglitazole, which has recently been launched, but we don't have any experience with this in NAFLD. But it may be, on the same lines. This is one molecule which is a farnesoid X receptor agonist. It is an antifibrotic agent, obeticholic acid. This is basically given in primary biliary cirrhosis, but this molecule can be used. Again, we don't have any recommendation as of today, but trials have shown that this is a good molecule. So guidelines, like these are different guidelines, American Gastroenterologists Association, American Association for Study of Liver Disease, like EASD, then American College of Cardiology, Gastroenterology, Indian International Association for Study of Liver Disease, European. So there are many, but just see, only lifestyle and, basically lifestyle pharmacological. So pioglitazone, vitamin E, in a diabetic, proven case, then it may be given. And reserved for, controlled studies. So see, most of the agents are reserved for controlled studies. We don't have RCT trials with other agents, like vitamin E and bio. So basically, this is my last but one slide. NAFLD affects, it's very, very common. That's one thing. Oftenly missed or, neglected, complication or comorbidity associated with insulin resistance syndrome affects nearly 1/3 of general population, 2/3 of type 2 diabetes and obesity, and it's a hidden epidemic, overlooked complication, silent killer. But the important thing is it is reversible. It is preventable, not beyond a certain stage, but in early stages, and it is an emerging cause of CLD, but more than that, an emerging cause of CVD, which is the killer for, the maximum, the highest mortality among NICD. So weight reduction and basically low fructose diet and modification of cardiometabolic risk factors. Yes, we have one molecule, resmetirom. Let's wait till it is available. And with this, I conclude and convey my thanks to all of you.
Thank you.
I think it was in time.
Yes, sir. Thank you. It was a wonderful session. I think many would have much enlightened with your brief, the complete discussion about the NAFLD. If any questions are there from the audience, we'll take 1 or 2 questions.
See, those NAFLD is No. See, I told one thing that comorbid, co-associated other clinical conditions. So dyslipidemia. Statins are for type 2 diabetics more than 45 years of age, less than 75 years of age, all type 2. Try to understand. So there are specific indications of statin, not NAFLD. So if NAFLD patient has dyslipidemia or type 2 diabetes between 45 and less than 75, then we give. Why not? But not just NAFLD. And aspirin, I think, everybody knows it should be used very cautiously. It gives more complications, more risk of, because risk-benefit ratio has to be in the benefit of the patient. So we have to use a molecule which gives benefit more than the risk. So aspirin is, secondary, yes, prevention, it's okay. Primary prevention, it has to be a moderate to high risk, not in a low to intermediate risk, no.
So in AFLD without IRS, without a hypertension,
Yes.
you can go for the statins and
No.
But alcohol is the inciting factor, no?
No. Alcohol, see, not everybody, no. It is metabolic associated. So patient may not be taking even any alcohol. So don't say alcohol is one of the, and if non-significant amount of alcohol is taken, then how can it be a risk factor? Yeah.
Thank you, sir. And no more questions. We shall be moving on to the next session.
Thank you, sir, for a wonderful talk. Now I have much pleasure in inviting Dr. K.N. Manohar, who is a consultant physician and diabetologist from Sharda Medical Center and Manipal Hospital. He has been a principal investigator, clinic-surg, and chairman-elect of Karnataka Research Society of Diabetes. Medical director of GT Foundation. He's authored many textbook chapters and original papers. To his credit, he's got Excellence in Diabetes Care Award from RSDI 2018, Kempegowda Award for Highest Civilian Award for Bangalore, Rising Star in Diabetology from Times of India Award, Diabetes Awareness Initiative Award at Diabetes India 2017, and Investigator of the Year Award at Indian Society of Hypertension. So I invite Dr. K.N. Manohar, welcome sir, and then please present your talk on sarcopenic obesity. Thank you.
Thank you, everyone. It's nice to be back in the physical mode. So, thanks for us for inviting me from Bangalore to talk on this, something interesting, something different. Obesity was considered just as a risk factor. Then we moved to call it as a disease, disorder. Now we are various types. There was a lot of body mass index and other things. Then they said no, Asians need a different cutoff. So we are making a lot of progress, are trying to know more and more about obesity. So one entity which looks at is sarcopenic obesity. What is it? We'll try and learn something. So this will be my mode of going about this presentation. Sarcopenic obesity, as the name suggests, sarcopenia, that we know means low skeletal muscle mass or its function. Associated with the obesity, various guidelines, diagnosis we know about obesity. So when both put together, it creates a new entity, so-called sarcopenic obesity. When it starts coming up, we say, what is this? Or it may be nothing much, but as NAFLD, we are making progress. Here also is one entity, especially very, very important to our Indian context, which we should all know. So we know the diagnosis of obesity in the Indian cutoff or Asian Pacific guidelines says 25 BMI should be the cutoff, or waist circumference 90 for men and 80 for women in centimeters. Or what we don't routinely look at, body fat percentage of more than 25 in men and about more than 30% in men. So what is the prevalence? Difficult to tell about it. About 12 to 33% men and women globally could have this, or maybe more. So it is just a permutation and combination of having muscle mass being low, classifying into sarcopenia, and associated with fat mass high, it becomes sarcopenic obesity. So why is it more important? Because it is one of the triggers for all of these non-communicable disease or metabolic syndromes, what we call it as, and their complications. It is an important event to address. So we have been making new insights into the endocrinology. Like we started saying that adipose tissue is an endocrine organ. Now the latest is to also know that skeletal muscle also is an endocrine organ. So it secretes a lot of cytokines. Interleukin-6 is one of the most important of the lot, which helps in metabolism and also has a big say in the body fat. So myokines are the new terminology, which includes interleukin-6, myokines, and various other parameters, which has an effect on the muscle and also on the fat tissue creating this entity. So is muscle so important? Yes, it's very, very important. Muscle influences energy and protein metabolism throughout the body. As you lose lean body mass, after a certain cutoff point of age, we lose EGFR. It keeps coming down by 1 unit or so after 60. Similarly, the muscle mass also comes down. So loss of lean body mass, even if someone has lost 10% of his body mass, muscle mass, he will have a higher risk of having reduced immunity and increased risk of infection. And when it reaches about 40%, even mortality can be predicted because of the loss of muscle. So muscle doesn't mean just for a mechanical motor involvement. It is an endocrine organ, what I'm trying to tell you. And if you preserve the muscle mass, you can reduce the risk of infection, improve wound healing, and also reduce the mortality, especially true with age being added as a factor. So muscle is not just a mechanical force or mechanical requirement for mobility. It influences everything from immunity to mortality. So that is one of the take-home messages what we should know. Muscle is an endocrine organ and it can influence immunity to mortality. So what is the cause of this sarcopenic obesity? Could be a loss of skeletal muscle, or muscle could be preserved but function could be lesser. Or obesity, the fat can infiltrate, how it infiltrated the liver, it infiltrates the muscle and makes it weak. Of course, the sedentary lifestyle and pattern of weight cycling, someone who is into serious efforts into weight loss, we know that they lose and they gain and they gain and they lose. That is weight cycling. But in the process, what could happen if you don't take care of your nutrition and the type of exercise you do? Then you may lose muscle and gain fat. So even then, you may, two people can look similar, but if you count on them with the BMI, the classical thin fat Indian paradox, what we call it as, we always talked about fat being higher in Indian, visceral obesity. Now the muscle being lower and fat being higher, both are equally important, is what the message I'm trying to give you. So we should invest in skeletal muscle strength. If you look at the guidelines, even for diabetes management, few years back, nobody talked about strength training. Now we know even in the national, international guidelines, 2 days of strength training should be included to reduce insulin resistance and improve the muscle function. Muscle is an endocrine organ. It is not just about aerobic or flexibility. Strength training becomes very important. So pathogenesis, again, as we say, a new terminology could be called like barocrinology, weight-related endocrinology. So where both the muscle and adipose tissue, the two endocrine organs which are involved in this, have various effects from reducing the metabolic rate to reduction in the hormones, especially testosterone with age can cause these problems. And of course, adipose tissue, we all know adiponectin and ghrelin and other things are very, very important to maintain the appetite and also the weight and fat mass. All of this interplay reduces mitochondrial dysfunction. And of course, we always say about oxidative stress, even though no antioxidant has been proven to be useful in any disease individually, and leads to sarcopenic obesity. So this is the barocrinological angle where you look at the muscle and also the adipose tissue as an important agent. So how does this happen? It causes various parameters: adipose tissue dysfunction, inflammation of the adipose tissue, leading to insulin resistance or worsening of it. You all know about the lipotoxicity, and low-grade inflammation in the muscles can cause weakness, loss of power, loss of function of the muscle, and then all confluence together to cause this sarcopenic obesity. So this is a vicious cycle where you lose muscle, sarcopenia, it causes muscle fatigue, disability, you are less mobile, you don't exercise, and even if you exercise, you can't do the strength part or to bring back the muscles, and that leads to obesity. Obesity causes excess adipose tissue accumulation everywhere, including in the muscles, and then cause worsening of this entity. So this would be the future where we look at not just obesity and fat, but also the muscle component to it. So what happens when this cycle gets going and causes complication? There will be loss of skeletal muscle mass, decline in the strength, and also the function. So all these parameters, especially the grip strength, is important. Again, we are in the early stages of coining this disease, how to evaluate and how to go forward. But then one of the things which we should start using in our day-to-day clinical practice is to measure the grip strength, on which I will come about it later. And again, obesity-related cardiometabolic disorders, all of us know, and then osteoporotic fractures and excess falls in elderly. One of the causes of excess falls, apart from various other parameters which can cause, is sarcopenia in the elderly. So diagnostic criteria, again, lot of bodies are there. If you look at the Asian, hand grip strength, again, we need to get that going and start doing on ourselves. When I tried my hand grip strength, after all the monkeying I do about the exercise, still I was falling short of it. Again, we need to relook at it, and hand grip strength, if it is less than 26 kg for males and 16 kg for women, and gait speed tests, again, we need to, if you want to look at it seriously, we need to make some adjustments in our clinical practice and set up something to look at the gait speed. And this is another entity called appendicular lean mass to height square ratio, like the BMI. Appendicular lean mass is the calculation or measurement of the lean mass in the limbs, and postulating it to how it works like the height square, like the BMI. So these are the three components which we talk about. There is a SWAG-SARCO consensus document, South Asian Working Action Group on Sarcopenia. If you look at it, muscle mass, again, anthropometry, body mass index, waist circumferences, and various areas like calf, mid-arm, mid-thigh circumferences can be taken. And hand grip strength, it should be held at 90 degree and then give it one good jerk and do it. And then muscle function testing by looking at the walking speed, sit to stand, chair stand. We can allow the person to sit and stand on the chair for 30 seconds and see the count. Again, what are the normals? What are the normal entity? It could be different for different people. As I said, it's just an evolving science. But are we seeing all these things to keep it in our mind? We may not do everything to get to the diagnosis, but at least we should keep this entity in our minds when we talk about it. So screening, as I said, risk of sarcopenia, you look at it, elderly, frail looking, and nowadays we don't use so much of BMD for looking at the fat percentage and other things. But if you look at, if some places they do that, and looking at obesity as a diagnosis based on the fat percentage also becomes important, because someone with a high muscular strength or the mass can have a higher BMI by classified into obesity category, but he could be actually having a higher BMI due to muscle weight, which is important and good for him. So the diagnosis, step one, you take the altered skeletal muscle function, and step two is altered body composition. So again, we are a bit far. DEXA scans and MRI, if required, can be done. And again, it is in the theoretical level now. And the strength parameters, sit, stand, stretch on the chair, or the hand grip strength has to be measured. And then you classify the patient into stage one. He may have sarcopenic obesity, but he may not have any complications. Or stage two, where they have one or more metabolic disorders, NCD, as complications to him. So what are the complications? Of course, metabolic diseases, depression, mortality higher. As I showed you, as you lose muscle mass, you can increase your risk of mortality, frailty, falls, disability, and another terminology what comes is moan. It also looks for the pain, groan and moan, but the muscle osteoarthroneuropathic syndrome is what is one of the complications, where they have multiple aches and pains, what we now label just as fibromyalgia, but it could be related to sarcopenia actually. So treatment, lifestyle intervention should be the cornerstone.
5 minutes.
5 minutes. 5 minutes is quite a lot. Thank you. I'll finish in that. Lifestyle intervention is the cornerstone of therapy, like in any other non-communicable diseases. And diet and exercise, I won't get into the details of it. Pharmacotherapy, weight loss medications. Actually, most of the weight loss medications have not done so very well in the Indian context, at least. So they are the one, and newer things are anamorilin is a ghrelin analog, and SERMs, selective androgen receptor modulators. Because when you use testosterone, it can increase the risk of prostatic cancer and BPH. So SERMs are sometimes preferred. And I told you, one of the myokine inhibitors, a myostatin inhibitor, which is anti-muscle building function in the body. That inhibitors are also in the fray. And of course, vitamin K and mesenchymal cells. And of course, bariatric surgery can be counterproductive sometimes and can cause worsening of the muscle mass if you don't correct it nutritionally and re-emphasize the lifestyle modification. So we all talk about flexibility, balance, aerobics, but resistance band exercises for our patients, simple exercises should come back in a way at least twice a week if you're doing 5 to 6 days exercise. So pharmacotherapy, as I said, a lot of agents are there. Even lorcaserin, which is a highly selective 5-HT2C receptor agonist, it causes reduction of truncal obesity, but how much effect it has on the muscle mass is not known. Similarly, none of them are having any great effect with respect to the muscle component. Yes, weight, tirzepatide and liraglutide are the molecules which are doing well with respect to the weight component. Testosterone, as I said, adding testosterone, or if there is a deficiency, it improves muscle adaptation and the growth, but it can cause risk of the prostatic cancer. So we look at SERMs, or selective androgen receptor modulators. Again, early stages into this trials with these drugs, and we should wait for time. This is one exciting molecule called anemoreline, which is an oral ghrelin analog. It improves appetite, it has some anti-inflammatory and anabolic effect. And animal studies are going on, in human trials also are going on with respect to improvement of the muscle mass with respect to this. So myostatin inhibitor, which is, as I said, myostatin is a negative regulator of skeletal muscle growth and development. So you inhibit it, you may get good effects. And in vitro trials have shown some effect with respect to the improvement of muscle mass and strength. And it also suppresses irisin. Irisin, we all know that it brownifies the adipose tissue. We know BAT, or brown adipose tissue, is better, which improves the metabolic rate. So it has various actions. As I said, it's still in the early stage of development of these molecules. Bariatric surgery could be helpful in reducing the overall weight and also the fat content. But if you don't put too much emphasis on the nutrients and the exercise, it could be counterproductive in this case. So an ounce of prevention is better than tons of treatment. That is the message. We always looked at the fat, but we need to look at the muscle also as an entity, is what we're saying. From primordial prevention, where to look at and address the occurrence of risk factor, to quaternary or quinary prevention, we need to keep that in mind and emphasize lifestyle changes as most important parameter for all of us. So I have been a runner most of the time, and off late, looking at all the guidelines and other things, I advocate some strength training also. So include everything. Yoga is good, flexibility is good, Tai Chi is good, strength training is good, aerobics is good, yes, but we need to have a mix of all. So invest in muscle health for maximum mileage. You invest in your skeletal muscle strength. To conclude, sarcopenic obesity, as the word says, there is sarcopenia and obesity. We are looking only at obesity and forgetting the sarcopenia. So we need to identify the individuals. Identification and diagnosis is a bit more cumbersome as of now, because we are in the early stages, and with time we'll get there, is what I feel. Lifestyle measures are the cornerstone of treatment. If you have initially more muscle, as age happens, we will lose less of it. So keep working out. And nowadays, what is it? Soleus push-up also has come up as another important entity which can be done by all of us even when we are sitting and watching. Thanks for the patient listening.
Thank you, Dr. Manohar, for an excellent talk on probably an unknown or often known but neglected part of muscle, which is there as an endocrine organ. And you rightly emphasized the need for having a muscle training there to have so many complications being avoided. If there are any questions, 2 quick questions, no conversations. Any 2 questions? Bhargav, sir.
Yes. Yeah, right from how you walks and comes and sits on your chair itself is many times gives us a hint towards whether he has weakness or not. Yeah, not yet recommended, because we have to, again, as the previous speaker also emphasized, risk-benefit ratio is what you need to look at it. Testosterone deficiencies, indication just only for the muscle may not be the case, but overall other things, if there is erectile dysfunction or hypogonadism, and then we can think of implementing or adding on to the testosterone, but not just for improving the muscle strength.
Thank you, sir. Giving a big hand. Thank you, Dr. Manohar, for wonderful.
May I now call upon Dr. Malik Merchant. Dr. Malik Merchant has done his DPM psychiatry from Nayan Hospital and DMA psychiatry. He is a consultant at Wockhardt Hospital, Mumbai. He is also consultant at Masina Hospital and Vishwas Hospital. I would like to say that we share a common thing. Just now I found out I worked in Masina as a resident for 13 days and he worked for 14 days. I too absconded. I got an MD seat and absconded. He is director at Mind Care Institute and Aga Khan Health Services, India. He is trustee in Prince Ali Khan Hospital and Vishwas Foundation, and he has various presentations at various national and international conferences. He will talk about anxiety and depression and how to manage them. Dr. Malik Merchant. Thank you.
First of all, I would like to thank the sponsor, the organizers for allowing me to speak on this topic, where I will be talking about non-pharmacological approaches in a scientific meeting where the whole day the discussion will go on about medications and management of diseases. Why am I doing this after 2 decades of Thank you. I am doing this after 2 decades of practice in psychiatry because we all know that only medications is not the solution to managing any diseases, more so in psychiatric disorders also. Of course, medications are a mainstay of managing psychiatric illnesses, but we also need to look beyond that. We all know that, I think this is the old slide set. No, the new one I had sent in the morning. I have it at night. sorry for the delay. So, one thing that we all would agree that anxiety and depression are one of the most common medical conditions in any specialty of practice, and it has increased in the recent times. Even the WHO says that post-COVID, there has been around 20 to 25% increase in patients suffering from anxiety and depression. What do we do when we come across such patients? Usually in our practice, when we come across such patients, we write medications. We psychiatrists are at a very delicate kind of a situation. Whenever we pick up our pen to write prescriptions, the neurotic patient gets scared. He becomes fearful, and the even more neurotic relatives even become more scared. Okay, doctor is writing the medications. I realized after so many years, everybody is scared of the psychiatrist except the psychiatrist's wives. I can say that because mine is not here. So generally there's a lot of fear about medication use in psychiatry, which is mostly a myth. But we should not restrict ourselves to use of medications only. Generally we've been trained to look at every symptom and try to treat every symptom with the medications. But we need to look beyond this. Why? There has been a lot of evidence that forces us, and even in our day-to-day practice we would see that it is very important to look beyond medications for other interventions to manage anxiety and depression. This is a very large trial, STAR-D. It's a very famous trial which was done in the United States. What it did was that any patient, real-world patient suffering from depression, they started him or her on one antidepressant. If the first one did not work, they went on to the second one, the third one, with multimodal actions and the fourth line of treatment also. What they found was that with the first line treatment, the remission rate, I'm not talking about response, remission rate was only 35%. And as they moved from one failed trial to another one, when they reached to the fourth step, the remission rate only came down to 13 to 14%. So only 13 to 14% had depression which was treated, which had remitted. And the story doesn't end here. Abhi picture baki hai. What happened after 1 year? When these people who had remitted, they were in remission of their illnesses, 1 year down the line, only 60 to 70% of those people who responded to the first line treatment were in remission. Around 30 to 40% again relapsed. And those who were 13 to 14% who had achieved remission with the fourth trial, only 2 or 3% of them maintained the remission. Most of them again relapsed. So sustainability of remission usually deteriorates with time when you are treating only with medications. Another trial, which was a very large study conducted in Netherlands, around 900 patients, 2 years of treatment, and what they found was that 50% achieved remission and only 20% had chronic depression. That means their depression lasted for more than 2 years. What happens 6 years later when the same population is seen? It flips exactly in the opposite direction. 50% of these individuals had chronic depression and only 20% had sustained recovery. So over a period of time, only with medications, there is a higher chance that the remission will not be sustained. And greater the depression, the greater the impairment of functioning. So it is, as William Osler says, that it is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. We need to look at non-pharmacological causes also for non-response. There are some studies which have found that there are a lot of non-pharmacological aspects which would determine the outcome of treatment of depression. For example, people who have early life adversities or trauma or abuse usually don't respond well to antidepressants. Loneliness increases the risk of depression, and that is what we saw in COVID. There was a study where they treated people with depression for 6 to 8 weeks, and what they found was that people who had satisfaction with their marriages, I don't know how they found people who were satisfied with their marriages, that is a separate question altogether, But people who were satisfied in their marriages had increased response rate and remission by around 100%. So these are non-pharmacological factors which determined the outcome of treatment of depression. I'm going to speak about certain studies or certain research papers which I came across when I was looking at things that could be used beyond medications for management of anxiety and depression. This is a wonderful paper which I came across. The title of the paper is "Wandering Mind is an Unhappy Mind." In 2010, in the prestigious journal called Science, Killingworth and Gilbert published this paper. What did they do was that they enrolled participants in these studies and put an app on their iPhone, and intermittently the iPhone would contact these people who had volunteered to be in the study. What did this app do? So basically the entire premise was that unlike other animals, human beings spend a lot of time thinking about what is not around them, contemplating events that have happened in the past, that might happen in the future, or will never happen at all. And this ability of human beings to be able to think about what is not happening in the present moment has its evolutionarily benefits also. It has helped us to learn, reason, plan. But has it come with an emotional cost? Most of the philosophical and religious traditions encourage people to be in the present moment, to remain happy. Are they right? This is what these scientists were asking. So they did this experiment where they, as I told you, they installed an app in people's phones, the volunteers' phones. And what did the app ask? The questions intermittently that were thrown to participants were three kinds of questions. One was a happiness question. So how are you feeling right now? And they would score from 0 to 100. 0 would be very bad, 100 would be very good. There was an activity question, that what are you doing right now? So there was a list, drop down menu of what are you actually doing now, and a mind wandering question. Are you thinking about something other than what you are doing currently now? And there were 4 options. No, I'm not thinking about anything. I'm completely focused on the activity that I'm doing. Yes, I'm thinking about something. And what is it? So there were 2 options. Something pleasant, something neutral. There are 3 options actually. Something unpleasant. And they had to select from these questions, these answers. What were the analysis, So the analysis was that people's mind wandered frequently. They found that 50% of the samples had mind wandering in almost all the activities except while making love. Surprisingly, the nature of people's activities had only a modest impact on whether their minds wandered or not. That means if you're doing an activity that you like or don't like, it has an equal probability of the mind wandering here and there, and had almost no impact on the pleasantness of the topics to which the mind wandered to. What they found was that people were less happy when their minds wandered than when they did not wander. And it was not related to any activity. So they found that the happiness index was definitely lesser when their minds wandered here and there than when they were focused on the activity. And they also found that even if the mind wandered to happy topics, not just to unpleasant things, even to pleasant things or neutral things, even then they were less happier than people who could remain focused on the activity that they were doing. Of course, when the mind wandered to unpleasant topics, the level of unhappiness was higher. So, anything that you're doing, but if your mind is wandering, it will not make you happy. So, if you want a happy Sunday, just completely focus on what I am saying. So, generally, what we feel is that, and there are schools of thought which say that if you are emotionally disturbed, your mind will wander. But here what they are saying is that mind wandering in their sample was generally a cause and not a consequence of unhappiness. It was actually a cause of unhappiness rather than a consequence of unhappiness. So in conclusion, what they concluded is that human mind is a wandering mind and wandering mind is an unhappy mind. And the ability to think of what is not happening is a cognitive achievement, but it comes at an emotional cost. Therefore, certain practices of mindfulness and meditation definitely helps. Mindfulness is nothing but being in the present moment in a non-judgmental way. It has originated in Buddhist traditions, but can be practiced in a meditative form, or it can be integrated into daily activities also. Like when you're eating mindfully, you're walking mindfully, you're washing dishes mindfully, listening to me mindfully. All these can be integrated into your lifestyle practices. And it definitely helps in reducing anxiety, it helps in improving depression, in other disorders also like eating disorder, PTSD and substance abuse. There has been research. There are a lot of papers that have been published. I will not go into all these papers, but they are all available and one can go through them. The effectiveness of mindfulness and meditation on improving physical health and mental health. Most of the times when we advocate meditation or mindfulness, people say we don't have time. This scientist called Wendy Suzuki came up with a paper where they studied two groups of people. One, they trained them into meditative practices. Exactly, they needed to practice this meditative practices for 13 minutes a day, only 13 minutes a day, and the other group were asked to listen to a podcast for 13 minutes a day. After 8 weeks, when they compared these groups, they found that people who were engaged in meditative practices had better emotional regulation, had better cognitive performance. So even short periods of meditative practices have helped people to deal with their emotional problems. Second important thing that I thought I should talk about is circadian rhythm. We all know we have a biological clock in our body which regulates the entire functioning of our body, our sleep, the cortisol release, the temperature regulation in our body. This clock is basically, this biological clock is located in the hypothalamus in the brain, and we are all aware of this. And we know that these circadian rhythms play a very important role in regulating our emotional health and our physical health. There is this scientist from Pittsburgh who came out with this entire premises and a kind of a therapy where this scientist Elaine Frank talks about that many of the mood disorders, especially bipolar disorder, is basically because of dysregulation of your circadian rhythms. And what she came out with is something called as a social rhythm therapy, where people who have mood disorders were asked to do routines and social activities at particular times, exactly at the same time every day, so that their circadian rhythm would be well maintained. Okay? And they found that these people who did this, their improvement was better, relapse rates were much lesser. Of course, in association, they were also given medications, but these brought about very good results in these patients. So, the social rhythm therapy, maintaining your circadian rhythm, also helps. So, sleeping on time, waking up on time, and maintaining a routine helps a lot in patients who have been suffering from anxiety and depression. Sleep. Sleep is one of the most important functions, but one of the most neglected functions. We all get patients who complain that, we have a sleeping problem, and immediately we pick up our pen, and most of the times we write alprazolam or zolpidem or something like that. Of course, in our heart of hearts, we are anxious when we are writing because we know that this might get the patient addicted, might cause cognitive problems in future. We need to go a little bit detailed into history of sleep-related issues. Many a times patients come to me and say, comes to us and say that they're not getting sleep, but when we ask them, actually they're sleeping much more than what we are sleeping. It's only a delayed phase. And in COVID, we've seen that people have started sleeping at 3 and 4 and getting up at 11 and 12. So the number of hours is adequate, but there is a delayed phase. We need to look at other causes of sleep-related problems, whether there's an obstructive apnea problem, whether there's a restless leg syndrome, and even if there is primary insomnia, giving medications is not now recommended as the first line option. What we recommend, and now at my clinic also what we practice, is cognitive behavior therapy for insomnia. This is a therapy which people benefit from who are suffering from insomnia. Usually we've designed it in a manner in our clinic where it's an 8-session therapy. The components include sleep hygiene, sleep restriction, improving sleep efficiency, behavior modification, certain relaxation techniques which they are taught, like yoga nidra or non-sleep deep relaxation therapy. So we use this cognitive behavior therapy and try to help patients who have insomnia and avoid giving these benzodiazepines or non-benzodiazepines, which in a very long run may cause relapses in insomnia and cause dependency on them. So one should look at these options when one is treating a person with insomnia. As effective as sleeping medications, there have been research studies that are found. Diet, exercise and weight, you all are all diabetologists, endocrinologists. I don't want to speak a lot about this. But this one study which stood out when I was going through certain research papers was by Jacka et al. These people advocated a diet which was more like a Mediterranean diet. Okay? And what they found, people who were depressed and followed these diets showed significant improvement, 2 standard deviations improvement. This is remarkable, for any study in treatment of depression. This much of an improvement in depression just with dietary control is just remarkable. Of course, these need to be replicated, but diet plays a very, very important role. What they recommend is, in this study, they had recommended a Mediterranean style diet. So this study is called as the SMILES trial. It is available on the net. One can go through this. Exercise, I will not go into details. Doctor before me has already spoken about exercise. Certain things that we need to understand is that, sometimes people come to us with anxiety disorders and panic disorders, and suddenly, people come to our clinics with hyperventilation and ghabrat, and they come in a panic kind of a situation, and they complain that these things keep happening to them intermittently. What I found was that certain breathing techniques, certain breathing exercises can definitely help one reduce his or her anxiety. We know that anxiety, there's an interplay of sympathetic and the parasympathetic nervous system. When we are anxious, the sympathetic nervous system is active, and it causes all the physical symptoms from the eye to the toe to happen, which the patient suffering from it feels very frightened when these things happen. Certain breathing techniques definitely help. One technique is called as box breathing, where we tell them to breathe in and breathe out to the count of 4, hold to the count of 4. This is an entire mechanism of breathing. This is another very interesting thing that I came across, which has helped a few patients of mine. It's called as the physiological sigh. Now, this was something which was very, very interesting to me. And what is this physiological sigh? There have been studies that have been done where a person is, when he or her is anxious, I did that before I walked onto the stage, practices this for 2 to 3 times, and it relaxes one immediately. The method to do this is you take a long inhale, usually through your nose, and then fill in more air into your lungs by another short inhale. So it is 2 inhales, one long and one short, and a slow exhale through your pursed lips. So you exhale slow and completely empty out your lungs. 2 to 3 times practicing this reduces your anxiety quite a lot. We know that breathing helps, and that is how the pranayama practices in yoga have been advocated. Even when one is anxious, a particular style of breathing where the exhales are longer than the inhales will reduce the heart rate automatically. This is physiological basis. When we are breathing in and there's a long inhale, the blood flows slowly through the heart. The SA node sends a signal to the brain that the blood is flowing slow, pump up the heart, so heart starts pumping. But exactly opposite happens when we are exhaling. The heart rate usually slows down. So when you are very anxious, when the patient is very, very anxious and complains of palpitation, longer exhales and shorter inhales usually help people to reduce their heart rate. 2 minutes, done. You know, psychiatrists can never stop when they are given opportunity to say. So I already spoke about box breathing and physiological style. We also need to look at cognitive behavioral therapy. Medication is not the panacea for treatment. Basically, the premise of cognitive behavioral therapy originated with Epictetus, where he said that people are not disturbed by things, but by the view they take of them. So it is not the people, it is not the situation, it is not the circumstances that make you feel the way you feel, it is the way you think that makes you feel the way you feel. So if you change the way you think, it will change the way you feel. This is entirely the premises of cognitive behavior therapy. Generally, in all our clinics, we have psychologists, some psychiatrists also practice cognitive behavior therapy. Very effective tool in management of anxiety and depression. So this is what one needs to look at. Genetics. People say that these mental illnesses are running in my family, I have been genetically predisposed. Here is a very large study involving 300,000 individuals whose polygenic risk scores were calculated. You know that there is not a single gene for depression or for anxiety. What we calculate is there are risk genes that are there, and we calculate the polygenic risk scores. So what they found was that people who had very high polygenic risk scores for depression, they divided them into two groups. One group actually followed these four things: moderate alcohol use, that is only 1 glass of wine or beer a day; BMI of less than 30; they had healthy diet and had physical activity. What they found was that people, even if they had very high polygenetic risk scores, if they engaged in these activities, they had 10-fold less risk of developing depression as compared to people who did not follow these lifestyle changes. So even if one is genetically predisposed to developing anxiety or depression, with these lifestyle modifications, one can bring down their rates of anxiety and depression. That's it. Thank you. Look beyond medications. If there are any questions, I would be most happy to answer them.
Thank you, Dr. Malik. To conclude, mindfulness, changing your rhythm, day-night or sleep cycle, using some techniques like cognitive behavior therapy, relaxation exercises, all these help in reducing stress, which in turn helps in reducing anxiety. So any questions from audience? Sat wants to ask something.
What do you mean by sleep hygiene? It is often talked, but you can explain to the audience.
So there are certain behaviors which we recommend, which increases the likelihood of reducing insomnia and increasing your ability to sleep. One is what is there in our pockets. There are certain steps that we tell people. So not using your screen at least an hour before you sleep, because there is blue light emission from the screens which disturbs the sleep because it hits our eyes, it sends the signal to the suprachiasmatic nucleus that it is daytime and one becomes awake. If one has to use blue light blocking glasses, which are available in US, I don't know, good quality ones are not available in India. Sleeping at a regular time, waking up at a regular time, regulating the temperature, lowering the temperature of your bedroom increases the likelihood of you sleeping better. A warm water bath before you sleep. The room needs to be completely dark, no night lamps, no those LED lights and things like that. Lowering the temperature, lowering the light exposure late in the evening also helps one to sleep. Very interestingly, we don't realize that coffee is one thing. I would not say coffee. Caffeine is one thing which we consume mindlessly. You know what is the half-life of caffeine? It is almost 7 to 10 hours. So if you've taken coffee 7 to 10 hours before you slept, half-life. By the time you're sleeping, it still is swimming around somewhere in your system and keeping you awake. So people who have difficulties in sleeping, we tell them that at least 10 hours before you sleep, you don't have coffee, or if you have to have decaffeinated coffee. So these are certain behaviors which one can use to promote for one to sleep better.
Thank you. So your message is clear that when your wife is talking to you, don't wander your minds.
Sorry?
Meditation is not coming out of scientific question.
It is allopathy.
Because there's evidence for it. There is ample. We need to look beyond that. We cannot restrict ourselves just to our pill and our prescription. We need to look beyond that for people to manage their diseases. You know, so that is why it is recommended, and there is an entire neurological basis. Sorry, I don't know whose proprietorship one has, whether allopathy, homeopathy, Unani, or meditation. But it is.
Sorry to interrupt, but it is like saying that physical exercise is not part of controlling diabetes, or it is physiotherapy is not part of orthopedics. So it is, physiotherapy is also allopathy, doing exercise is also allopathy, meditation is also a scientific thing.
Basically, lifestyle
Yeah.
management. And there is a science behind it.
There is a science and evidence behind it.
Yes.
So this is a part of cognitive behavior therapy. I will not go a lot of details in detail into that. We calculate the sleep efficiency. So total time spent in bed versus total time slept. You know, if we need to calculate that. If it is less than 80%, you know, so we restrict.
Dr. K.N. Manohar sir to please come on the dais. Dr. Malik Merchant sir to please come on the dais. I request Dr. P. Seerat sir to please felicitate our speakers. Dr. Supratik Bhattacharya sir. Dr. Vinod Mittal sir. Dr. K.N. Manohar sir. Dr. Malik Marchand sir. Now it's the time to felicitate our panel members. I request Dr. Venkat Raman Kola sir to please come on the dais and felicitate our panel members. I request the panel members to please come on the dais. Dr. Vijay Kumar sir. Dr. Vijay Kumar sir. Dr. Ashish Dengro sir. Dr. Srinivas sir. Dr. Minhaj Zafar sir. And Dr. Srirang Abakari sir. Thank you so much. I request all the speakers and the panel members to be on the dais and have a photo shoot.
Okay, clear, smile.
Now it's the time for the lighting of the lamp. I invite the dignitaries Dr. Raj Bhandari sir, the member of National Technical Advisor to the Government of India, to please come on the dais. Dr. Raj Bhandari sir. Dr. P. Seerat sir, the President of Cardio Society of India. Dr. P. K. Jabbar sir, the President of ESI. And I request Dr. Shaista ma'am, the President of FDARS, to please come on the dais. Dr. J.V. Farishta sir, the Chairman of FDARS, please come on the dais. Dr. Bhargava sir, Senior Consultant Physician at Apollo Hospitals, Hyderabad. Dr. P. Raghumulu sir, Senior Consultant Physician, to please come on the dais. And I also request the Organizing Secretary of FDARS to please come on the dais. Now is the time for lighting of the lamp. I request all the organizing committee of FDARS to please come on the dais for the lighting of the lamp.
Okay, ready, look here. Smile.
Thank you so much. Now is the time for the announcement of awards. I request Dr. Faraz Farishta sir, the organizing secretary of Frontier Diabetes Awareness and Research Society, to please come on the dais and announce the awards. Dr. Faraz Farishta sir.
A very good afternoon all. It gives me indeed a lot of pleasure, and I will take this opportunity with a lot of humiliation. Thank you so much of all my seniors coming from Parent India. So we've been blessed today to have faculties from North, South, East, West, and a big applause of thanks to two presidents of India today. We have the Cardiology Society of India President Dr. P. with us. We have Endocrine Society of India President-elect with us, Dr. P.A. Jabbar Sahab. May I request him to please come on the stage, Dr. P.A. Jabbar Sahab. So, we all have gone through the peak of, we have gone through the peak of COVID. I think one team which has really made a lot of difference in the lives of people, in the lives of doctors. There were so many doctors which were, I would say, being treated by this critical care team. So that is the Sparsh Critical Care Team, one of the biggest critical care team in India now. They are handling more than 16 major causes. Dr. Pawan Kumar Reddy. So these are the entire team. These are the directors of critical care which are managing major hospitals. Dr. Madhusudan, Dr. Masood Mohammed, Dr. K.C. Mishra, Dr. Shivakumar, Dr. Kaladar, Dr. Ranjan Kumar, Dr. Mahati, Dr. Dilshad, Dr. Shweta Ram, Dr. Supriya, Dr. C. Dinesh Reddy, Dr. Gautam. Dr. Shashidhar. Dr. Vishnu Vardhana Raju. Dr. Saurabh. Dr. Tiwari. Dr. Hanumant Rao. Dr. Anudeep Kumar. Dr. Srinivas, GPVM. Dr. Hemant, Dr. Srikant Atula, Dr. Dipti, and last but not the least, Dr. A. Hari Prasad. Dr. Sri Charan. May I request all of you to just come a little ahead so that we can have a good photograph? Yeah, that's a nice idea. The youngsters can sit down, yes. Maybe they can stand as well.
Okay, madam, come closer. Okay, ready? Smile, smile, smile. Smile. One second, video is recording. Done, thank you.
రూఫ్లో తీసారు కదా అది అక్కడ ఇస్తే ప్రింట్ ఇచ్చి ఇంతే అందుకు ఇస్తాను ఇప్పుడే ఇస్తాను ఇప్పుడే ఇక్కడ మూడు ఫోటో ఇస్తాను అక్కడ దీప వెలిగించాను అది కూడా ఓకే
So today they are launching their website also. So that is Sparsh Critical Care Team, the India's largest critical care team. So this is the entire critical care Sparsh team, which I think I will give just 1 minute to one of their directors to speak on it. Just 1 minute, Venkat.
Yeah, actually, I thank FDRS, Dr. Faraz, and the whole team to give us this opportunity and this platform. It happens to many of us, including Dr. Faraz and many families, where few of our known families or relatives were a part of the same pandemic effect, and they were with us in many intensive care units. So Dr. Faraz and we felt it is a time where some of the occasions we need to appreciate, and today we thank the whole team to give us this opportunity and giving the felicitation to the whole team. Thank you all.
Insulin, discovered by Banting and Best, has completed its 100 years of the journey. As you all must have guessed right, yes, it's the time for the Century Symposium. Here I invite Dr. J. Srikanth on the dais.
Dr. J. Srikanth sir is the Senior Consultant Physician at Apollo Hospitals. Dr. J. Srikanth sir is the Senior Consultant Physician at Apollo Hospitals, Jubilee Hills, Hyderabad. Distinction in the field of biochemistry, pharmacology and medicine, graduation ranked first during MD. Associated with bone marrow transplant program at Apollo Hospitals and principal investigator trial for the AZIP case SR. In community acquired pneumonia, coordinator for the preventive health care program. Dr. J. Srikanth sir.
Good afternoon, everybody. And at the outset, my sincere thanks to good friend Dr. Faraz. True, I think it's 101 years of the discovery of insulins, and we have come up a long way. We are still traveling for a better insulin. To take all these things into consideration and add some more interesting points and tuning our wandering minds, as Dr. Malik Marchant has already stressed upon. We now will be more focused on few interesting topics. We have a galaxy of speakers, and equally the panelists who are going to be along with me. It's indeed a privilege because most of them are my mentors. I'll first open up the topics and then I would invite the panelists. The topics are obesity, weight loss, and associated cardiovascular risk. This is the first topic, which Dr. Venkataraman is going to talk upon. The second topic is an extremely interesting topic, rather the buzzword, something about the new molecule that is imiglanin, which Dr. Mani Deepti is going to talk. Novel insulins in diabetes, evolution over time. Dr. Shanmugha Velu is going to deal. And 20 years of the basal insulin research. This is something which I personally feel, because I belong to that particular era where there was a transition from the so-called you try to give the insulins, monitor the things 4 times and still end upon having fluctuating blood sugar values. Basal insulins definitely has revolutionized. And to elaborate this, we have Dr. P.K. Jabbar, and non-steroidal MRAs have they improved the renal outcomes, especially in CKD patients. This topic would be dealt by Dr. Rajana. And I would now invite my panelist mentors, Dr. P. Sirat sir, to come onto the dais. Dr. Bhargava sir, Dr. Pinjala Ramakrishna sir. It's a real privilege because all the 3 members whom I have mentioned are my mentors at Apollo Health City. Dr. Malhotra, Dr. P. Srinivasulu, Dr. A. Kannan, and Dr. Manjusha, if she's around. Dr. Manjusha? I don't think that she's okay. I would now invite the first speaker, Dr. Venkatraman, to open the session. Welcome, sir. Dr. Venkatraman doesn't need any introduction, but I think you have a slide of the organizers. I request Dr. Srinivasulu sir to kindly introduce the speaker.
We have with us Dr. S. Venkatraman,
He is Senior Consultant Diabetologist, Apollo Hospital, Chennai, and also with Apollo Sugar Clinics. He is our Senior Consultant. He is a diabetologist at also Surya Hospital, Chennai, with 37 years of experience. Professor Diabetology in Madurai Medical College and Government Rajaji General Hospital, Madurai, 1998. He has presented various papers on few of them are related to autonomic neuropathy and also pregnancy. He has written various books and contributed various chapters in diabetes and vascular disease and also pregnancy and diabetes. Over to you, sir, Dr. Venkata.
Good afternoon. Slide is connected. So thanks, Dr. Faraz and the organizers for asking me to go to be here. And thanks the IMA Hyderabad co-partner for this program, and for this program especially, the pioneers in insulin in the industry, Novo Nordisk. Thank you so much. I thank the organizers not only for the opportunity given to me to be here to talk about a very important aspect in the obesity, about which Srikanth has made a nice introduction. So, Dr. Srikanth and respected members, some great friends are there, Harpal, Kannan from Chennai, and other members in the panel. Thank you so much. Now, this particular meeting, I really enjoyed for a simple reason. The concept behind is a holistic approach to the human health rather than specific disease entities. And for us, thank you so much. Whoever has designed the program, I feel Velu and other friends will agree that it gives an opportunity to listen to a lot of other people and topics which have not often dwelt in such fora. Before I talk about this subject, the time given I understand is 20 minutes. Is it extra or 20 minutes? Thank you. So before I dwell on it, I think in the management of diabetes, we have shifted from adopting a glucose-centric approach to multifactorial intervention, which means you just have to go away from just being glucose-centric or focusing only on hyperglycemia. Try to identify the comorbid conditions: hypertension, the dyslipidemia, cessation of smoking, antiplatelet, and body weight. Now, the importance of body weight as a contributor for the comorbid conditions has been realized, and the various guidelines have advocated the urge the clinicians to identify them and then achieve the target. Now, in the present scenario, in the present era, and probably we'll have much more in the future, there's a paradigm shift with respect to obesity. When we talk about obesity, so far I think we have been addressing obesity in the context of diabetes and metabolic diseases as an entity or a parameter, which we call it as a downstream intervention. There's a beautiful paper in the Lancet, really appreciated that. I would suggest that people interested can go through that. Now, what we are talking is about the upstream intervention for obesity, which means in the early part of diabetes, or even before the advent of clinical diabetes, in the pre-diabetic stage, when they are vulnerable for the metabolic complications, if you interfere, then it gives so much of a cushion to the clinicians to subsequently handle these patients with respect to the metabolic aberrations, be it hyperglycemia, hypertension, the dyslipidemia, and with its profound effect on the endpoints for which we are treating the diabetic population, especially the vascular complications. So with this brief introduction, I would once again thank Novo Nordisk for asking me to go over and make this presentation. I've been contracted by Novo to make this presentation. Otherwise, I do not have any conflict of interest. So first, I'll run through some of the data, I think just to emphasize the association of obesity with respect to the diabetes and the cardiovascular disease. I'm sure the August audience will be very much aware of that. Just to make the context setting, I'll just run through some of the data. And then probably what is the link? So in science, what happens is you have the epidemiology. So when you for example, you take smoking and cancer. So when you take smoking and cancer, right, it is an etiological association. I'm just quoting one of the famous examples. And then you have the mechanistic link to explain how we do it. Then you interfere. You stop, then the hypothesis is complete. This happens for diabetes, hypertension, etc., with respect to various endpoints. So we'll talk about the obesity and the prevalence and the complications, the mechanistic link, and the hypothesis is complete if the intervention is going to pay the dividends or have a favorable impact on the endpoints that we are discussing. Gone are the days, I think Dr. Shrikant was mentioning about years. I think I've been fortunate enough to be in this specialty right from 1984, thanks to my mentor, Professor Seshia, and of course, Velu and I are there in the specialty, close to be classmates. We are in this specialty probably just about less than 4 decades. So we have previously, when we went through the literature or addressed the students, we always used to say, obesity is a problem of the West. Maybe 2/3 or 3/4 of the Western population are obese, whereas in our country it is 1/3. Subsequently, we realized that number one, BMI probably does not reflect. The disease endpoints occur at a lower BMI cutoff in the Asian and the Indian population, and it is the distribution of the fat rather than the true BMI that is responsible. So these are some of the aspects of obesity which we have realized in the past, which has got a telltale effect on the pathophysiology of diabetes and the atherosclerotic process, etc. And if you look at the figures, look at it. From 2 crores, probably in then 20 years, even in India, which is a very, I would say, a soft estimate, it will be about 2 or 6 crores in 20 years. Maybe it will be much more than that. I think, I'm sure senior clinicians are here in the dais as well as in the audience will agree with me that whenever you point out to your patient that, are you aware that you are obese? Yes, I am. Do you think it is abnormal? Yes. Can I do something? No. Don't interfere. I will. Leave it to me. Yes, I am obese. I know I am suffering. I have got osteoarthritis. The knee pain is there. The back pain is there. I am snoring. And doctor told me that there is a fatty liver. So on and so forth. But when it comes to intervention, you treat my diabetes, you treat my hypertension. When it comes to obesity, let me take care of myself. I think this is the perception or the perception by the patient that there are not quality medicines available with respect to addressing the obesity in the present scenario, or probably not much of education is percolated down the line. And then when you talk about the other aspects, about 50% in this particular analysis, the Action Apex study, have spoken to the health care providers with respect to their obesity, and maybe about 1/3 they said they do have an appointment if it is a sophisticated setup wherein you have. But I think we clinicians practicing here combine everything. You don't have to run through the various specialty clinics. I think we clinicians are indebted. We are committed to addressing this particular component of the metabolic diseases, as I told you, upstream, right from the time probably when you treat your diabetic patient, whether son or the daughter is obese. I think that is the point. You initiate the discussion that this is going to be a future patient and something can be done at this point of time. Obesity mathematically is a very, very simple disease to understand, but clinically it's so frustrating and so difficult to interfere. Why I say it is simple? It's an imbalance between the energy intake and energy output. The extra energy is stored. Yes, simple mathematics. But how do you address it? I'll spend some time because I've learned something about obesity. All of us have learned something with respect to some of the nuances of obesity. I'll just take a minute or two. I think I started about 12:50. I'll finish about 1:10. About another 15 minutes because I see that a lot of interesting topics are lined up and lunch is also there. I do not want to exceed. Just before about 2 or 3 minutes before the time limit, please tell me that my time is about to be over and I'll finish. Now coming back to this, why it is difficult to lose weight? Somebody has been, say, having about 1,800 calories. You advise them, your BMI is so much, height is so much, ideal body weight should be this, come to 1,500. Yes, he comes to 1,500. You expect a negative balance of 300 calories to translate into weight loss. It doesn't happen. Even if it happens, it's not sustained. Why? Your brain is so intelligent. See, this person has been used to having 800 calories. There is a 300 calorie, so spend less of energy. Number one. Number two, the CNS also says probably his appetite is diminished, so the ghrelin is secreted. So the central nervous system acts counterproductive because the basic purpose of metabolism is to see the homeostasis. Somebody has been used to taking so much of calories, you do something to cut down the calories, the body reacts by spending less amount of energy and urging the patient to eat more. These are probably two reasons why most of well-intentional and even followed exercise protocols have not been attended or witnessed the weight loss that has to be seen. That is number one. Number two, there are two components of obesity. One is the metabolic obesity. The other is my favorite component, the hedonic obesity. Now, what is this hedonic? See, somebody has, in the South Indian context, I'll say about 4 idlis, 3 dosa, 3 chapatis, about 1 cup of rice in the afternoon, maybe in the same thing in the night, with some snacks in between, wherein you can always play a role. So, this is set. Now, he enters the IT job. His working time is, say, from 9 to 5. Extra time, so 4 o'clock, you have a samosa or a cutlet or a cake. So, his appetite is not there. He works till 8 o'clock, 9 o'clock. The second day, third day, at 3:30, he anticipates this. That is the pleasure of eating. So one is the eating purpose, survival purpose. The second is the pleasure of eating. You can combine both, but the hedonic component becomes an added component. So when the metabolic obesity is there, the brain point is set up in such a way that probably if you shift from 1500 to 1800, it gets shifted. More energy is spent. When the hedonic component is there, I think there is not much of a scope because he or she craves for, this is what's happening in our adolescents as well as the youngsters. So, in the future, if molecules like, for example, now we have the GLP receptor agonist, I'm not going to say that is a panacea, but molecules like that, which act at the level of your brain center, to cut off this craving for this hedonic eating, to suppress your appetite, and more than the regular consumption of food, especially if the effort is there to cut off this hedonic component, probably that will be a good way to interact. Of course, molecules are available, and of course, this is the tissues that have the ramifications of the excess adipose tissue. I will not go into that. All of us are too familiar. There are medical conditions, there are psychosomatic conditions, there are other metabolic conditions. As I told you, when you talk about a patient with obesity, diabetes, hypertension, dyslipidemia, and right from the head to foot you can start. You have obstructive sleep apnea, fatty liver, you have metabolic bone disease, osteoarthritis, etc., etc. These are all diseases. But for today's discussion, we are going to talk only about the CV risk factors and type 2 diabetes mellitus. So now we'll quickly run through the mechanics. So far we have seen the background of the obesity. Yes, this is what I was trying to see. The link between the obesity and diabetes risk is, if you're going to reduce, so obese people have got an increased risk of diabetes. If you interfere, for every 1 unit decrement in the BMI, it gets translated into 1.5%. So the hypothesis is complete. So there is an association. The disease is more. You interfere, do something to bring down, there is a less of prevalence. So the link for obesity and diabetes positively as etiologically is well appreciated, and maybe a very, very fundamental information. I thought I will run through that. Now, this is very, very important. This is the Nurses Health Registry, if I remember right, yes. The BMI that is attained at the age of 14 and beyond, if you look at it, there is a gradual rise with respect to the type 2 diabetes mellitus. So, when it comes to the BMI and diabetes, the lower the better. The lower the better. Now, I'll run through the slides because all of us are too familiar with this. What are the scenarios that are happening metabolically, the pre-diabetic stage with respect to the aspects of insulin sensitivity, the beta cell function, and of course, the metabolic parameters, fasting and the plasma glucose, etc. You see here, as the insulin resistance comes down, there is compensatory hyperinsulinemia, etc., etc. Now, what is the link? What is the mechanistic factor that obesity is contributing to the metabolic diseases? The lean adipocyte becomes hypertrophic adipocytes with nutrition, a lot of free fatty acid. This triggers inflammation. The inflammatory markers are elaborated and they worsen the insulin resistance. They initiate the endothelial dysfunction, they initiate the atherosclerotic process, of course, with the participation by other comorbid conditions like hypertension, dyslipidemia. So, the association of obesity with diseases is there. The mechanistic, the intervention pays dividends, and the mechanistic link is probably through inflammation facilitated by participation from other comorbid conditions. So this is with respect to the middle-aged men and women. We saw the National Health data. As the BMI increases, the risk for, we saw prior to that the diabetes, now the CVD increases. Now, before I finish in the next 8 minutes, what about weight loss? When you talk about the weight loss, now we have realized that the more the better. I would like to, in a lighter vein, say that this is in contrast to what Dr. Marchand presented. One bottle of beer gives you a good amount of benefits. So you cannot, 10 times the improvement is there. 3 bottles of beer is not going to give you 30% benefit. Whereas here, 5% reduction of weight is associated with improvement in metabolic parameters, enables you to de-escalate the dose of anti-diabetic medication. Some people call it as a relative remission, which I don't agree, that's different. Second thing is, if you can achieve a higher weight loss, 10%, 15%, you have a definite effect on entities like your obstructive sleep apnea, the fatty liver, and remission of diabetes mellitus. And this is probably going to be the focus in the next maybe few years. And you may turn around and ask, is it possible? You said about the limitations of achieving the weight loss. Is it possible to achieve 10%, 15% weight loss? Yes, it is. Molecules are there, data is there. That's why I think we are going to talk about obesity. It's not the theoretical exercise alone. The problem is that it is there in front of you. The disease manifestations are there, and intervention has been studied to pay the dividends. So let's quickly go through this. This is what I was referring to. With great difficulty you achieve some weight loss, then there is a regain of the weight. So our endeavor should be to prevent this regain as much as possible and sustain it so that it reduces the cardiovascular risk, the diabetes risk if it is implemented in the pre-diabetic stage, etc. And these are the various guidelines enforcing with respect to the dietary lifestyle modification. And there have been very, very impressive data, including the Look-Ahead trial data. In the Look-Ahead trial, what happened was they envisaged 7% weight loss. But of course, the primary endpoint was not met with. But in a post-hoc analysis, please listen to this, in the post-hoc analysis, such of those who had more than 10% weight loss had a 20% reduction in the cardiovascular events. Even though it's a post-hoc analysis, exploratory analysis, I think for clinicians, it is an excellent message. And then you look at the ADA guidelines with respect to, I'm sure all of us have gone through this and just running through this. So the importance of weight reduction in type 2 diabetes management. And as I told you, this is quantified. For you to have a tangible effect on metabolic parameters, 5% reduction, much more, does a lot of good, So these are the diabetic prevention data, DPP, the Chinese data, the BACWING, and the direct trial with respect to diabetes remission. The data are there, it's there, I mean in the literature, I'm not going to go through these things. Just tell you, intervention with respect to the lifestyle modification, if it is successful for the various degree, it is associated with favorable endpoints, be in the pre-diabetic or in the diabetic stage. And it's more difficult to achieve in diabetic because somebody comes with a catabolic state, blood sugar of say HbA1c of 9.3, you treat them, HbA1c comes about 6.8, they regain the weight. The catabolic state has become anabolic state, so that is good. You want them to get back their good health. In the process, I mean, attempting a weight loss at this point of time may not be associated, and also because of the complications and the elderly nature of these individuals, the lifestyle, the sedentary lifestyle, and other some drug-induced aspects as well can give rise to a lot of problems. These are some of the drugs that have been available in the literature, and of course, orlistat is there for us. Lira in the dosage of 3 mg is not yet approved in India, whereas Sama is approved. Maybe it's not available for the clinical use soon, I'm sure. Somebody from the Novo can tell you. So Sama 2.4 in the parenteral form, and I understand that even the oral Sama, maybe 1 to 1.5 years down the line, can be available. These have been found to have a tangible effect on the weight loss. Look at the effect on the HbA1c as well as the percentage of patients with 5% weight loss. 5% is a dictum for the simple reason for metabolic physicians to have a meaningful effect on the glycemia and the de-escalation of the dose of the medications. This is just a comparison with respect to the weight loss. with respect to LIRA-3, SEMA 2.4. This is not the diabetic dosages, these are the weight-reducing dosages. The trials have been completed. The data are very, very impressive. As I told you in this Frontiers conference, they sensitize the clinicians to the aspect of obesity, the components of obesity, the importance of obesity in the Indian context, and how intervention helps, and the scope for intervention is exemplified by some impressive molecules being available probably in the near future or in the distant future. I'll end my topic with this one study. I would like to say this is a beautiful study for the step 2 for the simple reason. What they did was, there are two molecules given in this trial, either SEMA 1 milligram or placebo 2.4, or in the other arm, SEMA 2.4 and placebo 1 milligram, and in the placebo arm, both the placebos. So all the patients had 2 tablets. So this is what you call it as double dummy, double blind. So we are aware of the RCTs with respect to double blind. This is double dummy, double blind. And what are the results? Yes, look at it. There is a good amount of weight loss. And what I want you to appreciate is the weight loss can occur as early as 8 to 10 weeks after initiation of therapy and sustained over a period of continuation of the trial as evidenced here. And people with good amount of weight loss as depicted at the end of 68 weeks. And then the HbA1c, yes, from the diabetologist point of view, we always would like to have the additional benefit, a robust HbA1c reduction. And if you look at this composite of percentage of subjects where 10% weight loss in HbA1c less than 7%, look at it with SEMA, and also such of those who had 15% weight loss, as I told you, beyond 5%, whatever you achieve is going to have a favorable impact on the other components of the metabolic syndrome or your obesity related problems like the NAFLD, obstructive sleep apnea, etc., etc. So, and again, as I told you, as the weight loss happens, you see the improvement in the insulin sensitivity as exemplified here. Look at the HOMA, IR, as well as at about 8 or 10 weeks, the fasting serum insulin, which is a surrogate for your insulin sensitivity, comes down, telling you that the metabolism has taken to a path of good directions with respect to preserving the beta cells, etc., etc. Blood pressure effects, systolic and the diastolic. Lipids, you do not expect much in the cholesterol, but certainly the triglycerides and the uric acid comes down. Yes. So, to end, the molecules probably which have had a major effect in the diabetic scenario, even though they might fit into the purse of a limited number of patients at this point of time for obvious reasons, are associated with benefits with respect to the MACE, the cardiovascular mortality, and some of the other endpoints. And these are the tissues by which they impact the brain, the GI tract, the heart, the kidneys, etc. And with respect to the brain, it's interesting to say that bigger molecules like your semaglutide and albiglutide may not probably enter the brain, but they do affect or impact the signals which is relayed from the dilated gut through the vagal afferents to the hypothalamus, modifying the hunger as well as probably the energy expenditure. So, ladies and gentlemen, I made an attempt to confine myself to 20 minutes, maybe a couple of minutes extra. Thank the panelists and Dr. Srikanth for permitting me. The idea was to give an effect, to give an account on obesity. Obesity, not in the regular parlance that we are used to talk about with respect to intervention, is one of the parameters downstream. It is in the upstream, so that you catch them properly even before the stage of diabetes mellitus. It can have a meaningful effect, so that down the line the patient as a whole can be managed in a much more healthier way. So with this, I would like to conclude, and thanks once again for the organizers for giving this opportunity.
Thank you, sir. I think it was 21 minutes. But anyway, thank you very much. Next topic is more of a research-oriented one. Emiclomine. Probably, I think it would be interesting to the postgraduates. It's a Japanese molecule, has undergone the phase 3 trials. And to highlight this molecule, the buzz which is creating, we have Dr. Mani Deepti. I request Dr. Kannan sir to introduce the speaker.
Dear friends, we know that we are in the era of modern medications. We are using a lot of modern technology also. Now we have the mitochondrial modulator, which acts both as insulinotropic as well as insulin sensitizing effect.
So to enlighten more on this, we have the eminent speaker, Dr. Manidipti Dasari. She is a consultant endocrinologist from Chinmaya Mission Hospital, Bengaluru. She is the best outgoing student in MBBS, has secured multiple gold medals, anatomy, physiology, biochemistry, and general medicine also. It's a great pleasure and privilege to invite you, madam. Welcome to the dais.
Thank you for the nice introduction, sir. As we all know, diabetes in India is like 7.42 crores are living with diabetes according to latest Atlas 10th edition. More than 30 years age, 1 in 7 of all adults are living with diabetes worldwide. It is a challenging disorder. Why? It is highlighted by poor glycemic control secondary to a complex interplay between both insulin resistance in the peripheral organs and decreased beta cell function. Progression of diabetes can be linked to associated pathology in multiple organ systems. Nowadays there are multiple pathophysiological mechanisms. Previously we used to treat only decreased insulin secretion and insulin resistance are the mechanism. Nowadays there is increased glucagon secretion can be a pathogenesis, and there can be a neurotransmitter dysfunction is one of the pathophysiology in diabetes, and recent concept is mitochondrial biogenetics. So the progression of diabetes can be linked to multiple pathophysiologies. One is increased beta cell apoptosis, second thing is increased hepatic glucose production, third one is decreased uptake of glucose into the peripheral tissues. So effective management and treatment of this condition can be a challenging task. None of the present drugs which are available has the multiple effects. For example, if you take metformin, it decreases the insulin sensitivity. If you take sulfonylureas, they will increase the beta cell production of insulin. So addressing these different aspects of the disease would be meaningful. So that's why there is a need for the new treatment options. Having therapies appropriate for use in different conditions is important for making true progress. Previously, when you take in 1960s, there are only 2 drugs which are available, only metformin and sulfonylureas. Nowadays, from 1970 till these 5 decades, if you consider, there are almost around 10 to 12 diabetic molecules have came. Imiclimin is the first glymin, a new class of glycemic control drugs. It seems to have a potential to be a solution to several disadvantages which are associated with the current therapies. So basically the mechanism of action is, it is dual action. It acts both on by decreasing insulin resistance and increasing the insulin secretion. So it is a mitochondrial bioenergetizer. It improves mitochondrial energetics in the liver. So that what is the effect? It decreases the glucose production and increases the glucose utilization in the liver. In the muscle, it increases the glucose utilization. In the pancreas, by reducing the beta cell apoptosis, it increases the insulin secretion. So as we all know, this is mitochondria, outer membrane, inner membrane, and in between that intermembranous matrix, intermembranous space. The inner membrane is folded, it is called cristae. The inner space is called matrix. So as we all know, the electron transport chain, there will be complex 1, 2, 3, 4 and ATP synthase. This ATP synthase is responsible for the production of ATP. So whenever there is an increased production of ATP, for example, it causes increased insulin secretion. So mitochondrial dysfunction nowadays has become a prominent feature of type 2 diabetes pathology that contributes to both beta cell defects and insulin resistance. So there is a deficient oxidative phosphorylation, excessive reactive oxygen species formation, mitochondrial permeability transition pore opening and leading to apoptosis of cells including beta cells and insulin resistance. So what happens when there is a deficient oxidative phosphorylation? There will be reduced ATP generation. What will be the effect? In beta cells, reduced insulin secretion can happen. If the insulin secretion is reduced, then it can lead to diabetes. So what does imiglamin do? So imiglamin, as you all know, the oxidative phosphorylation cycle has to be gone from complex 1 to 3 and ATP synthesis. It should not get reversed. So if it is get reversed, there is excessive formation of reactive oxygen species. So it leads to cell apoptosis and death. So what this imiglamin exactly does is, it inhibits the complex 1. It reduces the reverse transport from complex 2 from the complex 2 to complex 1, and thus reduces the formation of reactive oxygen species, may also lead to increase in AMPK. And restoration of complex 3. It prevents mitochondrial permeability transition pore and lessens the apoptosis of beta cells. It increases ATP generation in the beta cell. So, another thing is, it acts through salvage pathway at the complex 2 and 3. It acts through the salvage pathway and increases the NAD plus levels. This increase in NAD plus level leads to increased calcium mobilization. This increased calcium mobilization will cause increased insulin secretion. So, in the mitochondria, it partially inhibits the complex 1, leading to reduces reactive oxygen species formation. It restores complex 3 and it prevents MPT opening, and it increases the ATP generation. Finally, when the ATP generation increases, there is an increased production of insulin. So ultimately, it helps to reduce the apoptosis of the beta cell. So it improves the beta cell function and it causes beta cell protection. It increases glucose-dependent insulin secretion. That's why the hypoglycemia chance is very less. It prevents beta cell death and it increases the functional beta cell mass. Other effects are, it enhances the insulin action in the liver, it reduces the excessive gluconeogenesis and decreases the steatosis. In the muscle, it increases the insulin signaling and it leads to, it stimulates the glucose uptake. Finally, the glucose levels in the body gets reduced. So, this is a quick review what happens exactly. Mitochondrial dysfunction, as I told, it's contribute to both beta cell defects and insulin resistance. There is a defective oxidative phosphorylation and reduced ATP generation. There is an excessive reactive oxygen species formation. Mitochondrial permeability transition pore opening and release of pro-apoptotic proteins leading to apoptosis of cells and including the beta cells. And another thing is insulin resistance. How at every step this imiglamin acts is, it improves the ATP generation. In beta cells, it amplifies the insulin secretion. It reduces reactive oxygen species formation, prevents MPTV opening, prevents apoptosis of beta cells and improves beta cell mass. It improves insulin sensitivity. This is the same slide. Ultimately, it prevents the apoptosis of the beta cells and improves the insulin sensitivity. So, when compared to imiglamin, metformin and sulfonylureas, action at electron transport chain, this imiglamin mainly inhibits complex 1 and restores the complex 3, but metformin has only action at, it inhibits complex 1 only. Sulfonylureas has no effect. Reduced reactive oxygen species, it is seen both with imiglamin and metformin. It improves insulin sensitivity, which is seen with both imiglamin and metformin. NAD salvage pathway, only imiglamin helps in. So, as we are clinicians, we should have some clinical evidence. So, it has been although the molecule has been studied from 2007, only the trials have started from 2015. In 2015, the phase 1 studies were done. In 2016, phase 2B studies were done. In 2018, there are 3 studies, times 1, times 2, times 3, which are clinical studies. And this is the times program, which is scheduled times 1. In this 1000 milligrams imiglamin BD versus placebo, the treatment period is 24 weeks. The primary endpoint which they have considered is change in mean HbA1c from baseline to week 24, and secondary endpoint is percentage of responders. Times 2, in this 2 week, after running of placebo 2 weeks, the 1000 milligram imiglamin BD in combination with other anti-diabetic agents. The treatment period they have taken is 52 weeks. In this, they have assessed both safety of imiglamin as monotherapy and combination therapy. Secondary endpoint is change in HbA1c from baseline in at week 52 and number of and percentage of responders. And time 3, this study is combined with the insulin. One arm there has been insulin with imiglamin, and in another arm insulin compared with placebo. So the trial, this is also around 52 weeks it was done, and it included around 108 patients placebo and 106 with imiglamin. So change in HbA1c from baseline in or at week 16, and secondary endpoint is the how much percentage of responders. So times 1 monotherapy trial. This, as I already told, first after screening and ruling out other factors, 1 to 2 weeks, and giving a washout period for the previous OHS or any drug, the placebo run-in for 4 weeks. It is a double-end treatment study. In one arm, they have given imiglamin 1000 milligrams, and in another arm, they have given placebo. So there is a statistically significant HbA1c reduction with demonstrated efficacy and an observed safety and tolerability profile similar to placebo. So you can see the change in HbA1c is 0.87%. Any drug reducing HbA1c more than 0.5 is a good drug. So this is reducing the HbA1c by 0.87%. So in times 2 study, they have combined with other anti-diabetic agents. They have included around 714 patients, and they have included with multiple drugs like dipeptidyl peptidase 4 inhibitors, thiazidines, and alpha glucosidase inhibitors, glinide, metformin, SGLT2 inhibitors, sulfonylureas, and imiglamin as a monotherapy, and imiglamin combined with GLP-1 receptor agonist. So out of them, when combined with DPP-4 inhibitors, they found there is a maximum reduction in HbA1c of 0.92%. When with thiazolidine only 0.88% reduction is there. Alpha glucosidase inhibitors 0.85. With glinides, there is a 0.7 reduction. With metformin, 0.67 reduction of HbA1c. With SGLT2 inhibitors, 0.57 reduction. With sulfonylureas, 0.56 reduction. Lowest is with glucagon-like peptide receptor agonist. So times 3 study is with adding with insulin therapy. So with adding insulin therapy, those who are not well controlled with insulin, so they have included with insulin with imiglamin and insulin with placebo. 107 in 2 arms, patients in 2 arms. Results is primary endpoint of reduction in HbA1c. The safety and tolerability profile observed are similar to the placebo. So it has shown 0.6 when compared to the placebo. This imiglamin, when combined with insulin, has shown 0.6% reduction in HbA1c. So after 36 weeks of treatment, there is a 0.64 reduction. After 52 weeks of treatment with 1000 milligrams BD in 208 patients, they have observed 0.54% reduction. So when compared to times 1, time 2, time 3, times 1 placebo there is a 0.15 increase, but 0.72% increase as a monotherapy. In times 2, on an average, when combined with other oral anti-hypoglycemic drugs, there is a reduction of 0.46%. And in times 3, when combined with insulin, there is a 0.63% reduction. So imiglamin monotherapy, there is a significant. What are the proportion of patients who have?
You have 2 more minutes.
How many?
You have 2 more minutes.
Yes, I'm finishing. Significantly higher proportion of patients with type 2 diabetes attain target A1C of less than 7%. So with imiglamin, there is 35%, 35.8% is the response percentage. So this is the same with in times 1 and times 2, times 3 studies. Effect of age. When they have in less than 65 years and more than 65 years, they have separated in 2 arms. In both the conditions, it is quite effective. In CKD, they have studied in stage 1, stage 2, stage 3 CKD. It is effective. 0.33 reduction in times 1 and in times 2 around 0.48 and in times 3 0.72% reduction is there even in chronic kidney disease patients. Review and I will have a quick review with this. These are all phase 2 studies. Phase 3 studies are times 1, times 2, times 3. Almost around 0.7 to 0.8 reduction of HbA1c is there. So it is a promising agent for the treatment of type 2 diabetes. It lowers HbA1c effectively both in monotherapy as well as in combination with other oral anti-hyperglycemic drugs. Longest study is 52 weeks of duration with a very quite acceptable tolerability profile. So what are the pharmacokinetics is? The therapeutic dose is 1000 milligrams BD, initial dose is 500 milligrams BD. The half-life is 13 hours. It is not metabolized and eliminated unchanged in the urine, so it can be quite used in the kidney disease. There is no dose adjustment in moderate hepatic impairment, but there are no studies in severe hepatic impairment. What are the adverse effects is nasopharyngitis and most common are gastrointestinal symptoms. So when and where and how of imiglumin now we should use. So contraindications are pregnancy, lactation, preconception. In childhood it's not indicated. And excessive alcohol intake, EGFR less than 45, we have to reduce the dose. Significant hepatic dysfunction we should not use. Dose is 500 milligrams if the EGFR is 15 to 45 BD. If EGFR is less than 50, it is 500 milligrams OD. There is no significant drug interaction or drug-food interaction. It can be given after food. So initiation, they are contraindicated or considered to have a risk-benefit ratio in elderly and renal insufficiency. When it is mostly indicated if the drugs are not well tolerated. For example, with metformin, we will see in clinical practice 10 to 15% of the patients will have gastrointestinal effect. In those conditions, this imiglumin is the best therapy. So, for example, there is a risk of lactic acidosis and there is a weight gain or hypoglycemia. This imiglumin can be chosen as a better option. Intensification, if other drugs are insufficient, then achieving euglycemia. Summary, to conclude, imiglumin, it decreases the beta cell apoptosis, decreases the hepatic gluconeogenesis, improves the skeletal muscle glucose uptake. It targets pathophysiology in 3 of the primary organ systems affected by the type 2 diabetic physiology. With potential for use as a monotherapy or combination therapy with other agents, it shows promise in significantly improving the treatment course in many for whom previous therapies are failed or contraindicated. Thank you.
Thank you, Dr. The next topic would be novel insulins in type 2 diabetes management, the evolution. We don't have an ideal insulin, but we do have a novel insulin. To highlight this, we have Dr. Shanmuga Velu, and to introduce, I would request Dr. Srinivasan, sir.
Yeah, it's a very pleasure to introduce Dr. Shanmuga Velu, MD, FSCP, FRCP. Sir is the chairman of Trichy Diabetes Center in Trichy, and then he had many awards, out of which the important ones are honored with the Professor Sam G.P. Moses Oration Award, and then he has published many articles, and is a regional faculty and is past president of Policies Day Tamil Nadu chapter. Over to you, sir.
Respected chairpersons, guest speakers, senior doctors, my doctor friends, and members of the IFDARS, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on novel insulins in type 2 diabetes management to evolution over time. This is a corporate symposium sponsored by Novo Nordisk. I thank Novo Nordisk for their kind invitations. So I'm sure most of you will agree that in patients with the diabetes, intensive glucose control initiated immediately after the onset is well known to be associated in preventing diabetes-related complications. Recent literature on diabetes in aging, the legacy effect in patients with the type 2 diabetes, confirms that strict glycemic control in first year significantly reduces the risk of macrovascular events as well as mortality. However, intensive glucose control increases the risk of hypoglycemia, and severe hypoglycemia has been recognized as an important risk factor for adverse events, cardiovascular disease, as well as mortality. Therefore, achieving favorable glycemic control and minimizing the risk of hypoglycemia should be regarded as a measure for the treatment of patients with the type 2 diabetes. So I'll go through the agenda includes genesis, evolution of basal insulin, evolution of bolus insulin, as well as evolution of premix insulin. So genesis, the fantastic form of insulin discovery, most cherished moment in one's life, that is published in New York Herald under magazine section, informing that Dr. Banting hard work won the Nobel Prize. So fantastic form. Banting, Best, Collett and MacLeod. So it was through a series of experiments by Banting and his assistant Best, they were able to unlock the mystery for the world, the discovery of insulin, lifelong discovery, and it's a great innovation, especially patients who are suffering from diabetes. Next is, they introduced the new insulin formulation, thick brown muck, what we call it Banting's and Best extract. There are limitations with reference to their short duration of action. That results in evolution of basal insulin. The first breakthrough, 1936, H. Thorne, the founding member of Novo Nordisk, he came out with the addition of strongly basic proteins like protein could prolong the effects of the injected insulin, but that was found to be chemically unstable. Longer acting insulin formulations or of zinc insulin discovered. Discovery of lenti insulins with the extent of homorphos, that is semi-lenti, lenti and ultra-lenti, determining the duration of activity. So we know with reference to the duration of action, but there are several strategies that have been employed to prolong the duration of action of insulin. Addition of basic protein, we have the NPH, reducing the solubility at physiological pH, glargine, 100 IU, 300 IU. Next is adding, that is addition of a short chain fatty acid of variable length to the insulin molecule, which can bind with the albumin, remains in the circulation as a circulating depot, from where the insulin molecule is released into the circulation. And of course, we have the human immunoglobulin FC fusion technology, which enables the insulin to enter recycling into the circulation. Right. NPH insulin became available in 1946. The first crystalline NPH insulin was produced by H. Thorne, and this was found to be chemically stable and could pre-mixed with the regular insulin. Originally animal sourced, today NPH insulin is made with human regular insulin. Despite the availability of longer duration, the basal insulin coverage was insufficient, needed to be administered twice daily, and more of it is available as a cloudy solution. There's a need for resuspension, failure to which it can result in variability with reference to day-to-day in the same individual as well as with reference to inter-individual. And the peak concentration offered by this particular insulin may increase the risk of hyperglycemia. Next is the limitations with reference to the first NPH insulin. That is, certain modifications have been made in the primary structure of the insulin molecule, and we get the first generation analog, namely insulin glargine, modification made in the A chain as well as B chain. So subcutaneous injection of an acidic solution that forms a precipitation in the subcutaneous tissue, which ensures slow dissociation of free glargine hexamer, thereby ensuring longer duration of action. Next is insulin detumer. Up to 30th position, detumer is removed, 309 is removed, and fatty acid chain is attached to the L29, that is lysine, and that forms a subcutaneous depot by binding with the albumin and enters into the circulation. Again, it binds to the albumin, thereby it prolongs the duration of action. And even in the interstitial fluid, there is no binding at all. And if you look into this particular study, conducted in patients with the type 1, patients were randomized to receive glargine, NPH insulin as well as detomate. You can see the 4 different doses given on 4 different study periods. So we have the panel on the left side and bar diagram on the right side. This panel on the left side clearly shows high day-to-day glucose variability with reference to NPH compared to the first generation basal insulin, namely the glargine as well as insulin detumer. If you focus your attention on bar diagram, the coefficient of variability, the ultimate pharmacodynamic endpoint, that is lower with the glargine and lowest with reference to the insulin detumer. Next is, we have the first generation analog. It also suffers certain disadvantages. Not truly once daily, that means sometimes we need to give it twice daily. And next is associated with the high variability with reference to the glucose lowering effect. Next is fixed time dosing. So this results in lack of flexibility with reference to time of administration. Not truly peakless. Next is higher nocturnal hypoglycemia. We get the insulin degludec. It is available as a dihexamer and it is attached to a long fatty acid chain, and when it is injected in the subcutaneous tissue, payload is released. That causes the multi-hexamer formation within the subcutaneous tissue, forming a subcutaneous depot. Zinc diffuses slowly, causing individual hexamer to disassemble, releasing the dimer and monomer. Monomers are absorbed into the circulation, and very important thing is it also binds with the albumin, which offers protection of the duration of action. Right. Next is we have the Glorgine 300IU. 3-fold concentrated version of insulin Glorgine. We know insulin Glorgine 100IU. It is a concentrated form. So same amount in terms of unit, but smaller volume of injection. If you look into the subcutaneous tissue, it forms a compact subcutaneous depot with a smaller surface area, which allows more gradual and slow release from the depot surface. And if you look into the right side, you can see the pharmacokinetic profile of insulin Glorgine 100IU as well as 300IU. Steady state is reached over 2 to 3 days. Once steady state is reached, it remains constant and the fluctuation with reference to plasma concentration is less. Insulin degludec. The efficacy and safety is well established with reference to various RCTs as well as real-world studies comparing Glorgine 100IU, Glorgine 300IU and other comparators in terms of APG reduction, PPG reduction, A1C reduction as well as the risk of hypoglycemia as well as dose change. Next is evolution of bolus insulin. We know insulin is secreted under basal condition between the meals and during sleep. We call it basal insulin. Following a meal, the rise in the plasma glucose concentration stimulates the pancreatic beta cells to secrete insulin. We call it prandial insulin secretion. So we have the insulin that is secreted in response to rise in the plasma glucose concentration. That is physiological. Several attempts have been made to mimic the physiological time action profile of the insulin. Right. So what we want immediate concentration in the postprandial period. Just like 1 to 2 minutes of insulin, the first phase of the insulin that is secreted by the beta cells. So the goal of insulin development. So approach endogenous insulin secretion by healthy pancreatic beta cells. We get the biosynthetic human insulin, we get the rapid acting insulin analog, and we get the insulin that is administered as inhaler. Right. Next is we get the ultra fast acting insulin, namely the phosphoaspart, as well as several other insulin molecules. So insulin aspart, that is the modification made at position 28, replacing the proline with aspart, and this substituted with aspart reduces the monomer-monomer interaction, so the molecule to undergo self-association is very limited and that is very much reduced, allowing more number of monomer to regenerate. Not only that, this altered structure ensures quick absorption into the endothelial cell. So it reaches very quickly in the immediate postprandial period. So greater early insulin exposure with insulin aspart compared with human insulin. And if you look into this particular slide, the serum insulin concentration achieved after subcutaneous administration of insulin aspart, there is a quick absorption and reaches a maximum Tmax, that is maximum concentration of insulin within a short period of time immediately after the subcutaneous tissue compared to the regular human insulin. So the clinical and pharmacological improvements with insulin aspart compared with human insulin, it differs from regular human insulin in terms of improvement in postprandial glycemic control, can be dosed immediately before a meal or can be given soon after a meal when necessary. So it goes flexibility which can improve the patient compliance as well as the quality of life of individual. And moreover, the reaches a quick concentration within a short period of time. It stays in the blood only for a short period of time, thereby minimizing the risk of hypoglycemia, what most of our patients we come across once they take regular human insulin. So designing an ultra-fast insulin. The approach is to bring about physiologically secreted time action profile. There are ways, that is, the change with reference to route of administration, spectral needle or pulmonary, or changes with reference to formulation by adding magnesium bichaperone or niacinamide and others, or changing the injection site by application of the or hyaluronidase. So we get the changing the formulation. First inspart, that is first aspart is insulin aspart in a new formulation. Niacinamide, it increases the monomer formation, number one.
raises the monomer concentration, number 2, also enhances the absorption across the endothelial cells. Next is we have the L-arginine, order for stability, that is the next occurring, generally recognized as safe, that is GRAS. So the dissociation of insulin and summer, increasing LA monomer form fraction after detection. So following human insulin aspart, and faster aspart, ultra fast acting insulin aspart, where the monomer gets released within a shorter period of time, thereby able to achieve maximum concentration within a short period of time. Compared to insulin aspart, fast aspart has 75% greater insulin action within the first 30 minutes and 147% greater insulin action within the first 30 minutes in patient with the type 2 diabetes compared to insulin fast aspart. Twice as fast onset of appearance in bloodstream. That is, onset occurs much earlier. Almost 2-fold higher insulin exposure within the first 30 minutes. So comparing the primary insulin, regular insulin, insulin aspart fast onset, they differ in terms of the time, the glucose lowering efficacy, as well as dosing, as well as availability in reference to delivery device. Next is evolution of premix insulin. So most of us are using premix insulin while managing patient with the type 2 diabetes. We are comfortable. So we have the recombinant human insulin, biphasic human insulin, and we have the analog premix, and we have the co-formulation. They have their own advantages and disadvantages with reference to control on fasting, postprandial A1C, and next is with reference to the dose once daily or twice daily, and also the limitations with reference to the regular human insulin, biphasic human insulin, as well as the insulin analogs. There are pharmacological differences between insulin co-formulation and premix insulin. So co-formulation involves mixing two biologically active solutions together in a fixed ratio. That is, we have 30% aspart and 70% the ultra long-acting basal insulin analog, namely insulin degludec. Premix insulin, on the other hand, involves the suspension of one biologically active solution with an insoluble biologically inactive precipitate. The differences mimics physiological insulin secretion with reference to co-formulation, no shoulder effect at all. The proteminated component can interact with the pharmacokinetic and dynamic profiles of the regular insulin. Regular insulin in turn can also interact with the pharmacokinetic and dynamic profile of the intermediate acting insulin. And the co-formulation simplifies the insulin regimen without requiring suspension. It is available as a solution, right? So I take aspart, world's only co-formulation insulin, ultra long acting 70% and rapid acting insulin 30%. The two insulin in single delivery device, they do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. That is, individual pharmacokinetic and dynamic profiles are retained. There is no interaction, no shoulder effect. And this particular glucose infusion rate study, conducted in patient with the type 1 and a euglycemic clamps situation, clearly shows the distinct prandial, that is the rapid onset of action, and a distinct peak mediated by insulin aspart, followed by a stable, flat, and a separate glucose lowering effect mediated by the long-acting component, namely the ITEC. So RSSDA is a clinical practice guidance. That is recommended, ITEC aspart is recommended as a choice of insulin initiation. So the distinct prandial and basal component makes it a prudent choice for once daily initiation. The same insulin can be continued. Same insulin can be used for intensification as twice daily. Evaluating the efficacy and safety of ITEC aspart versus once daily basal insulin in insulin-naive patients with type 2 diabetes, immunologically controlled on oral anti-diabetic drugs. This provided superior long-term glycemic control compared to Aglair U100 with lower risk of hypoglycemia. Next is basal bolus therapy. Yes, impact on quality of life and treatment preference. Reduction in the number of injection sites, flexibility, simplicity of dosing with the ITEC aspart translate into better quality of life, and reduction in pill burden. The reduction in pill burden, that is 70% of the patients on 3 OADs could be shifted to 1 or 2 OADs, and 50% on 2 OADs a day were shifted to 1 OAD a day. So reduced pill burden improves quality of life and adherence to treatment in individuals with diabetes. So cost effectiveness, we are very sure it is costly compared to the human insulin, no doubt at all. But we need to consider the risk of hypoxia. There is of resources, source utilization. So ITEC aspart is cost-effective treatment for patients with the type 2 not achieving glycemic targets on other therapies in routine clinical practice. So a prudent choice for Indian scenario associated with the low risk of hypoglycemia offers milk and flexibility, simplified the regimen, convenience of device, better quality of life, cost effectiveness, and in addition, it achieves effective glycemic control in terms of reduction in APG, PPG, and A1C. Thank you very much for the time.
Thank you, sir. It's just like a jugalbandi, a musical jugalbandi.
Pardon, sir?
It would be a musical jugalbandi now.
Thank you, sir.
You had elaborated on premix insulins and you went through the rapid insulins, insulin analogs. You will be followed by
So the thing is,
PK
sir, I have my flight. I need to go right now. If I have any questions, I'll clarify.
Yeah. Any questions from the panelists, eminent panelists? Because I want of time, I think I'm going to leave. Any questions from the audience, please? Thank you, sir.
Thank you so much, sir.
We have Dr. P.K. Jabbar taking over this Jugalbandi program. 20 years of basal insulins, and to introduce the speaker, I entrust the responsibility to Dr. P.C. Nelson.
It's my pleasure to introduce Dr. P.K. Jabbar. He is President Professor and Head of the Department of Endocrinology in Trivandrum Medical College and Director and CEO of Indian Institute of Diabetes at Trivandrum. Very impressive CV. He did his MBBS and DMD from Thrissur Medical College and DM from KEM Hospital, Bombay, and also did his DNP from DNP Cardiology and Nutrition.
Only 2 points for today. See, what is your comment regarding the prescriptions? Absolutely, there is no scientific basis for that. Please take a message. Do not do not combine two secretococcus. You are pushing the patient for beta cell death. Right? That's number one. So question number two, when do you start insulin for our patients? For that, you should know what is Starling law of beta cells. Starling law of beta cell, for students sitting over here, if you are giving sulfonylurea, that will fuse the beta cells, right? When the blood glucose, that is fasting blood sugar, exceeds more than 180 milligrams per deciliter, after that there is no significant amount of insulin retained in the beta cell, and eventually your beta cell fail. So that's an indirect statement that if fasting blood sugar exceeds more than 180 milligrams per deciliter, probably insulin has to be started. So this was a parameter you can see here. It's a totally uncontrolled diabetes mellitus as evidenced by self-monitoring of blood glucose and glycosylated hemoglobin. Now, let us look at the ICMR data. ICMR data shows a part of myself is a part of this entire group, and where most of the patients, around 3/4 of the patients, the type 2 diabetes mellitus, they are not having good control of diabetes. Please remember that. If you work in United States, if you work in United Kingdom, any other country for that matter, scenario is same. This is something like a paradox in diabetes management. Okay. Now, this data, this is published in the recent Landers Endocrinology. I want to concentrate on Andhra Pradesh and Kerala. So what is happening is the glycosylated hemoglobin is pretty high, BP is not under control, both systolic as well as diastolic, total cholesterol, LDL cholesterol, HDL cholesterol, everything was totally out of gear. That's what is happening in all states for that matter. So where are we now? See, are we not really treating this patient? Of course, we are taking an earnest effort to get a good control, but something is hidden, something is obstructing, something is wrong, and eventually you are all getting very bad metabolic profile. That's a message I want to give. And others says that, see, your control is not good, and it's a high time to act from the government level. Even you have Ayushman Bharat scheme to effectively implement to get a good control on diabetes and other metabolic problems. Practically speaking, those things are not happening. So when you start, you see what's happening here. It's a lean patient, an obese patient. When you cross the normal glucose tolerance to IGT, sizable beta cell number has come down. Apoptosis has happened. And eventually, the moment you get diabetes mellitus, your beta cell capacity is very minimal. So that's what is happening. So at least, if you are getting a glycosylated hemoglobin of more than 9%, or for that matter, indirectly fasting blood sugar of 180 milligram per deciliter, better start. Don't go for multiple doses of sulfonylurea. That's only take a message for today. Okay. Now, this is the management strategy by American Diabetic Association, European Society. My dear friends, very categorically, authentically, American Diabetic Association says that when you start with the basal insulin, is not the premix insulin. Please, this is not my comment. These are the comments from your classical area recommendation. You see the recommendation by other professional forum also, more or less same. And if the blood sugar is not controlled with basal insulin, what you have to do, you go for, you advance the treatment with the insulin. Let's take a message from this slide. IDF recommendation is also more or less same. Of course, they are giving little emphasis for static premix insulin because of many other reasons. But whatever, by and large, IDF is also supporting the usage of the basal insulin for our patients. This is American College of Endocrinology recommendation. They are also in all phases, maybe mild diabetes, maybe moderate diabetes, maybe a very advanced diabetes, everywhere insulin is indicated. So what does it mean? The professional forum, they wanted to give insulin little early for a good outcome or to maintain your beta cell. What is the motive of giving GLP or C13 based treatment? You want to maintain your beta cell mass. So if you give insulin little early, probably you can maintain your beta cell. European Society also gives the importance. You just see the bottom end. Bottom you can see here the basal insulin is the first slide. So second point for today, first point is do not give multiple doses of sulfonylurea. Second point, professional forum supports the usage of basal insulin as a treatment of initial treatment of choice, and subsequently you can change the medication. Now, what is the recommendation by RSST recommendation? RSST also gives importance for giving something wrong with the projection. Look into that. Okay, RSST also giving a recommendation that you can go for basal insulin. Yet another interesting phenomenon is do not start basal insulin only. You just go for the combination. See what is written here is around 79% of the patient using only insulin are not meeting the target figure of magic figure of 7. Why? See, there are many mechanisms, but what you should remember is just go for combinations of treatment, insulin and other drugs, which is well accepted and probably most accepted treatment at least in the initial phases of diabetes mellitus. Otherwise, this is a progressive disease, lot of comorbidities can come up and necessitate insulin treatment in majority of the patients with the type 2 diabetes mellitus. My dear friends, please try to look into all this data. Now, how to choose insulin? It's a very basic slide, very basic slide. You can look into your blood sugar, fasting blood sugar, you look into your glycosylated hemoglobin, or if you want to go for an intensive control, always multiple doses of insulin, is not the basal insulin alone. Whereas, if the patient is like, you can call it as mild diabetes mellitus, such a situation, you can start a simple jab, probably at one shot of insulin at that time. Classical regimen is known as BIDS regime, BIDS, bedtime insulin sulfonylurea. Good number of patients will get control on that, and if the patient is not improving, look into the fasting blood sugar as well as postprandial blood sugar. If both are high, glycosylated hemoglobin is also high. Such a situation, at least in the initial phases, you can go for 2 doses of pre-mixed insulin. Now, very important testimonial or advice. Start with, these are the recommendations by Professional Forum. Fix fasting first. 3F, fix fasting first. How do you do that? You just go for 1 shot of insulin. And we'll discuss what are the basic characteristics of basal insulin. Long duration, preferably long as more than 24 hours, and flat. There is nothing like a peaks and troughs, and all those things are not advisable. And low intra-patient variability is also a good character of a basal insulin. Easy to administer. 1 shot is good. I am traveling from Toronto to Hyderabad to Mumbai. Such a situation is difficult to take multiple doses of insulin. So your compliance is also very important. So for that, a single jab is good, and safety profile very important for any patient with diabetes, and if you are using insulin, I'll be discussing that. Now, what is the basic basis of giving your basal insulin? So what is happening here? A patient has got blood sugar, postprandial hyperglycemia in 3 phases: before breakfast, before lunch, and before dinner. And patient has got an elevated fasting blood sugar also. Eventually, your pot is full. So what you have to do now? Just reduce the level of fasting blood sugar. How do you reduce it? By simply giving a short or long-acting insulin in the form of Lantus. So what will happen? This will be like this. So you are reducing the fasting blood sugar, glucotoxicity is coming down, lipotoxicity is coming down. Eventually, you are giving other drugs also, oral drugs that will act very efficiently, and you can get control on other blood sugar as shown in this picture. So very important third message is try to control fasting blood sugar first, or fix fasting blood sugar. Now, this esteemed audience, you won't accept anything unless I discuss evidence-based medicine. At least you can see approximately 7 or 8 studies you can see. The Bladin insulin was started, this was the basal, it's around 9%, and within 24 weeks that came down to your magic figure of 7%. That is a study from Inside, TTT, there are multiple studies. So what I want to tell you that very convenient regime, you just give 1 shot of insulin, that will reduce the glycosylated hemoglobin. Probably it's not applicable for all patients, but majority of the patients, you'll get a good control. This is another landmark paper. They also showed fasting as well as postprandial hyperglycemia significantly reduced with the 1 single dose of 1 jab. That's more than enough for a good control. This is landmark, and Now you will ask me, is it IDAC or Dicludac, or you can use Lantus insulin? It's possible. You can use both. But mind you, this data published on one of the journal, which showed a significant reduction of fasting blood sugar with the Lantus. These are the observation, and the glycosylated hemoglobin was comparable. That's a message from this slide. So what I want to tell you that you can use any molecule for that matter. This data showed the fasting control is very powerful with the glargine insulin. Now coming to the mixer insulin, so another fellow is asking, why don't you go for a mixer insulin? Possible, you can choose any molecule for. So I want to use basal insulin because of the simple data. Simple data shows there is no significant difference at all. You are taking 2 injections and glycosylated hemoglobin, you say, okay, fasting is okay, phosphorylated is okay, so why should I go for 2 doses of insulin? Probably I don't want, probably my friends won't accept that. So single insulin is okay, and this is another study which showed reduction of glycosylated hemoglobin was good with basal insulin only. These are the data, Jangas data you can see here. Now, there are other data, especially unique data for Indian patients also. What you can see, after 6 months of treatment with the basal insulin, glycosylated hemoglobin dropped. You can see in the p-value, what's the p-value there? 0.0001. So this very powerful data, and fasting blood sugar is also significantly reduced with the basal insulin. What more you want? So at least in the initial or average patients with the type 2 diabetes mellitus, 1 single dose is enough. Now let us look at the patient perspective also. What is shown here, and see that satisfaction score. That is most important, because what is happening in a clinical profile or clinical practice, people doesn't want to go for multiple doses of insulin. You want to go for single, probably painless injection, which is not possible for the time being. So what is shown here, the satisfaction from pre-mixed insulin to say long-acting insulin. It's also very encouraging for our patients. So basal insulin, very simple, acceptance is very good, and chance for complications also, my dear friends. As a physician, average physician, my worry is hypoglycemia. I don't want to produce even a single episode of hypoglycemia in my patients with type 2, even though it's not possible, because we have sufficient data to show that if you want to get a good control on diabetes mellitus, hypoglycemia is the rule. What people are thinking, researchers are thinking, scientists are thinking to reduce the number of hypoglycemic episodes. Whereas on the other side, premixed insulin, the hypoglycemic episodes are more, and yet another complication of insulin treatment, that is weight gain, and mostly what is happening in clinical practice, you have to give probably significantly higher levels of insulin dosage for that. Now another question, for doctor, you think so 1 dosage is okay? Yes, that's okay, but titration is also important. Every few days you should titrate the dose of insulin, then only you will get good control. So these are the various guidelines for adjusting the dosage, or you can call it this for titration. That's very good, and very importantly, titration will reduce the glycosylated hemoglobin, and effective titration is very important for reducing your glycosylated hemoglobin. And need of titration, what is shown here as a glycosylated hemoglobin, the blue line, this was showing a 9.3%, and coming down to significant reduction. Both the dosage of insulin was not very high compared to the premixed insulin, and phosphorylated glycemic control is also very good. Now, very important, fifth point is the complications or demerits of insulin treatment. Demerits are there for insulin, not only for basal insulin, premixed insulin. What are the most important complications? One is hypoglycemia. Second is weight gain. And third, lack of controversial point, which I am not discussing for our August audience. Yet another important observation, this one study which showed, why don't you go for insulin? You will ask the patient, no doctor, I don't want. I'll go to another doctor. They will give you another sulfonylurea. Or I'll go to a non-allopathic doctor or Unani treatment. So that's okay. No, that's not okay. Okay, please remember that. So one day, suppose a patient comes to you with good, very totally uncontrolled, on point in the morning, my blood sugar is okay. You know, I took some Ayurveda powder. You know what had happened? His liver, kidney is gone. Right? It's very common. At least in Kerala it's common. I don't know what's happening here. Why the resistance from patient side and the physician side? There are many reasons. For if you ask a physician like senior teachers are sitting here, they are much worried about hypoglycemia. That's the most important. It's not the pain. Much worried about the insulin or insulin-induced hypoglycemia. There are other reasons also, and even patients think that, say after starting insulin, my molecule of the Azrael is coming. You understood? So that's the way the people are thinking that I'm likely to die within few years. I have patients like that from Arab countries. So hypoglycemia is the most threatened complication. Now, what is shown the data? Data showed, this paper showed 87 percentage higher rate with the combination or formulation, and I will see glargine was not showing significant weight gain also in this data. Now, this is another data regarding the hypoglycemia, overall hypoglycememia, nocturnal hypoglycemia. What is shown here is a prevalence or incidence of nocturnal overall, and weight gain was significantly less with one jab of insulin or one injection of insulin, glargine insulin. So here what is shown, the comparison between premix insulin versus basal insulin, which showed hypoglycemia significantly reduced. Both overall hypoglycemia and nocturnal hypoglycemia was significantly reduced. Now coming to my patient. For my patient, what I did was I started multiple doses of insulin because the patient was in hospital, acceptance is good, and subsequently at the time of discharge, I thought I will give one dose of insulin, and with that, so you can see the data here, and patient glycosylated hemoglobin subsequently not on the second day, subsequently we got a good glycosylated hemoglobin. As a physician, average physician, I'm very happy, patient is happy, probably pharmaceutical company is not very happy, which I'm not bothered. So my dear friends, whatever we discussed, your aim is to maintain good glycosylated hemoglobin. You can follow any recommendation for that. You can go for Mayo Clinic recommendation, you can go for Accord guidelines, or you can go for ACE recommendation. But mind you, at least 7% of the glycosylated hemoglobin, which is very, very difficult to maintain in our patients, but still that is our aim. For that, this type of molecules are good, and probably they are coming with the good molecules also. We will get a good control. My dear friends and ladies and gentlemen, let me give the take-home messages. Basal insulin is recommended. It's the most convenient accepted method by physicians and to patients. Even very high levels of glycosylated hemoglobin, you can see what's happening, just like a melting of glycosylated hemoglobin with your single dose with other drugs. And glargine offers benefit of minimal or no episodes of hyperglycemia, and when you compare with the premix insulin. My dear friends, let me stop here. This molecule or basal insulin treatment should be first line of management. It's not the weights of mine, it's the weights of American Diabetic Association. Let me close it. Thank you very much for the kind attention.
Thank you, sir. The last topic for this session would be
Association of India Karnataka chapter, Dr. N.C. Talwarkar, Orishon Nephrology Association of Karnataka. He is the author of more than 75 peer-reviewed journal articles and abstracts in kidney, American Journal of Kidney Diseases, Journal of American Society of Nephrology, and other journals. In fact, he is the last speaker, but perhaps in the field of diabetes, when you follow the diabetic patients, organ dysfunction is the
the very bad combination. Now, what is even more important? Mortality in patients with or without diabetes. Now, this is a very interesting slide. If you look at the graph shows the decline, average decline in GFR and major studies in CKD. DCCT trial came, told us about the need for HbA1c 7%. Renal and IDNT study came in 2001, which said ARBs are useful in decreasing the risk of kidney disease. Of course, Captopril study was earlier in type 1 diabetes in 1993. But between 2001 and recently, that is for almost 15 to 20 years, there were no major developments in kidney disease. Unfortunately, it was the dark era that there were no new drugs at all. We were doing the same thing over and over again with no additional benefits. So now, in addition, of course, you all know the importance of urine albumin creatinine ratio. It is strongly associated with the risk of cardiovascular and kidney outcomes. And these are the various UACR values and cardiovascular and kidney outcomes. Now, I told you that kidney disease triples the risk of cardiovascular mortality in patients with and without diabetes. Chronic kidney disease progression is driven by three factors: hemodynamic factor, metabolic factor, inflammation and fibrosis. Now, we have been attempting to control the hemodynamic factors by ACE and ARBs, diuretics, SGLT2 inhibitors more recently, and metabolic factors by insulin, anti-hypoglycemics, and SGLT2 inhibitors, GLP-1 RAs, etc. However, for a long time, we have not had any agent which actually interfered with the inflammation and fibrosis. That is where there is an unmet need to target this inflammation and fibrosis to prevent the progression of kidney disease. Now, again, in the renal study, even though losartan decreased the risk of progression of kidney disease, there was still significant residual risk. Likewise, in a meta-analysis of ARBs versus placebo, we see that there is a significant residual risk of progression of kidney disease. And even with canagliflozin and dapagliflozin, there is significant risk of kidney disease as well as heart disease, despite being given ACE-ARB and SGLT2 inhibitors. So, that is where finerenone, a non-steroidal MRA, is hypothesized to slow kidney disease progression by directly targeting inflammation and fibrosis. And in fact, what I am going to discuss over the next 10 minutes or so will be to highlight the data that has come in the last 2 to 3 years about the utility of finerenone in progression or in mitigating the progression of kidney disease and heart protection. Now, these are the pillars of a multifactorial approach, pillars of treatment in diabetes: glycemic control, blood pressure control, lipid control, and agents with cardiovascular and kidney benefit. That is ROS inhibitors, SGLT2 inhibitors, and now the new third pillar will be MRAs. So these three have specific cardiovascular and kidney protection in diabetic patients. Now, MRA, that is mineralocorticoid receptor antagonism for kidney and heart protection. Aldactone was shown to have cardiovascular benefit in 1999 in the Rawls trial. Subsequently, we know that eplerenone also had cardiovascular benefit. And we know that MRAs, that is aldactone, lower proteinuria in patients with CKD, but the problem was significant hyperkalemia and other anti-androgenic side effects. So because of this problem, although we knew it was good, we could not use it. And that is where the newer molecules come into play. Now, with respect to mineralocorticoid receptor, it's a nuclear hormone receptor expressed in heart, kidney, vasculature, brain, gut and myoid cells, activated by ligands such as aldosterone and cortisol, and non-ligands such as RAC1, oxidative stress, etc. The gene, MR gene, was cloned in 87. So, initially it was felt to be important in volume homeostasis, but more recently, its role in inflammation and fibrosis has been well elucidated. So, the MR gene diabetes may alter the function of the MR gene in kidney, triggering inflammation and fibrosis. That is, diabetes, why there is kidney disease is because the MR overactivation. In healthy individuals, there may be one MR, whereas in diabetic individuals, there are more MR expression and hence inflammation and fibrosis. So like I said previously, MR overactivation happens through multiple mechanisms, and the MR overactivation causes kidney damage, vascular damage and heart damage, and hence therefore intervention or intervening MR is a major pathway in achieving better health outcomes. Spironolactone and eplerenone, I told you already, decreases cardiovascular morbidity and mortality in patients with heart failure and reduces ejection fraction. Spironolactone improves endothelial dysfunction and increases nitric oxide bioavailability in patients with heart failure. However, steroidal MRAs are not commonly used in patients with CKD and type 2 diabetes because of risk of hyperkalemia, anti-androgenic side effects, and an increase in cortisol and HbA1c in patients receiving spironolactone. So, finerenone is a novel, non-steroidal, highly selective MR antagonist. It's a bulky molecule with a very short half-life, about 2 hours, compared to more than 20 hours for aldactone. Its unique structure results in a selective and potent interaction with MR receptor and its gene expression, and it exhibits significant anti-fibrotic and anti-inflammatory effects. Now, in phase 2 studies, safety and tolerability of this molecule finerenone was tested in patients with chronic heart failure and mild to moderate kidney disease. It was shown to be as effective as spironolactone with a significantly lower risk of hyperkalemia and worsening renal function. That means it provided the benefit, it took away the side effects of aldactone. And in addition, finerenone caused a dose-dependent reduction in albuminuria in patients with CKD and T2D in this phase 2b study. So, what I'm going to discuss is going to be large phase 3 trials which have been published in the past 2 years. There were actually 2 studies, Fidelio DKD and Figaro DKD, and a pooled analysis, a pre-specified pooled analysis called Fidelity pooled analysis. So these papers have been published in the last 2 years, like I said. Initially in 2020, we had the effect of finerenone on chronic kidney disease in type 2 diabetes, Fidelio DKD. And in 2021, cardiovascular events with finerenone, Figaro DKD. And 2022, we had cardiovascular and kidney outcomes, the pooled analysis. Now, please note that in the Fidelio and Figaro studies, there was a running period of 4 to 16 weeks where the patients received maximally tolerated ACE or ARB. 99% of the patients in these studies received maximally tolerated ACE and ARB. They were given either 10 or 20 milligrams of finerenone versus placebo. Figaro DKD study had 7,437 patients and Fidelio DKD had 5,734 patients. In the Fidelio study, the primary endpoint was a composite kidney endpoint and the secondary endpoint was a cardiac endpoint. Whereas in the Figaro study, primary endpoint was a cardiac endpoint and secondary endpoint was a kidney endpoint. And in the combined pooled analysis, both kidney and cardiac outcomes were studied. Now, like I said, patients' inclusion criteria: type 2 diabetes more than 18 years, diabetic retinopathy or albuminuria, maximally tolerated dose of ACE or ARB, potassium less than 4.8. Key exclusion criteria were heart failure with reduced ejection fraction, uncontrolled blood pressure, HbA1c more than 12%, non-diabetic kidney disease, stroke, TIA or hospitalization for heart failure, and USCR more than 5,000. So that means these studies included significant CKD patients. That is, in the Fidelio DKD, this was the heat map of CKD heat map, whereas in the Figaro, patients had less degree of kidney disease than in Fidelio, and in the pooled analysis, obviously they had both patients together. So the most important thing is, in the Fidelio DKD study, after 3 years, there was an absolute risk reduction of 3.4%. That means number needed to treat is 29. Please note, in any clinical trial, a single number which is of most importance is number needed to treat. If you treated 29 patients for 3 years, you prevented one primary endpoint event, which is composite kidney endpoint here. So 29 is an excellent number. To have this beneficial effect on top of ACE or ARB and excellent blood glucose control, it is very impressive. And the secondary endpoint in the Fidelio was cardiac endpoint. Again, number needed to treat was 42. Hazard ratio was 0.86. And impressively, there was a 31% reduction in albuminuria when these patients were given finerenone. That means finerenone decreased albuminuria, it decreased cardiac endpoint, it decreased kidney endpoint. All were met. And in the Figaro, it's a primary cardiac study. The time to cardiovascular death, non-fatal MI, non-fatal stroke or hospitalization for heart failure decreased by about 13%. Number needed to treat was 47. And the kidney endpoint decreased greater than 57% decline in GFR, that is doubling of creatinine, decreased by about 23%, also significant finding. So, most important, in the renal study, I told you in 2001, there are only 1,500 patients. In the IDNT, about 1,600 patients. Whereas in the Fidelio and Figaro studies, there were 13,000 patients. So even EMPA study or DAPA study had about 4,000 to 6,000 patients. So finerenone studies are the largest studies in CKD patients, 13,000. So a very impressive number, followed for about 3 years and showing beneficial cardiovascular and kidney outcomes. So in the Fidelity pooled analysis, there was a 14% risk reduction of cardiovascular morbidity and mortality and 23% risk reduction in CKD progression. So finerenone, therefore, dear colleagues, is an effective treatment option for cardiovascular and kidney protection in patients with CKD stages 1 to 4. So the major risk of using an MRA is hyperkalemia. If you see altitude study where there was aliskiren and ACE or ARB, 4.8% risk of hyperkalemia. In VA nephron D study where it was ACE, ARB, ACE plus ARB, 9.9% risk of hyperkalemia, whereas in the finerenone studies, hyperkalemia was only seen in 1.7%. Huge reduction in hyperkalemia compared to other dual RAS inhibition therapies. So, based on these tremendous data, American Heart Association, AACE, American Diabetic Association, KDIGO, all have now recommended the use of finerenone along with standard of care to reduce CKD progression and to decrease cardiovascular events. So some more studies will be published in the near future where additional data will be generated. So my take-home message this afternoon is finerenone, a non-steroidal MRA, further improves cardiovascular and kidney outcomes on top of standard therapy in type 2 diabetic patients with CKD. Consider finerenone in patients with residual albuminuria and normal serum potassium who are already receiving first-line therapies. And the renoprotective effects of SGLT2 inhibitors and finerenone are complementary, independent, additive, and makes the treatment more tolerable. For example, hyperkalemia, I told you about 1.7%, but if you combine with the SGLT2, hyperkalemia is even less. So therefore, the combination of SGLT2 and finerenone actually makes the treatment even more tolerable. So I'm going to stop here, and if there are any questions, I would be willing to take.
Thank you, sir. It was a wonderful session, and I would request the panel members, esteemed panel members, to share their clinical experiences. Dr. and Professor Pinjala sir, I am sure that there are few topics which I am sure that you would like to give your opinion.
Yeah, we vascular specialists are interested more in the angiograms and nephropathy, contrast-induced nephropathy. Can this drug finerenone protect the patients from contrast-induced nephropathy?
Contrast-induced nephropathy is an acute kidney injury due to damage to the tubular cells from the contrast taken. So finerenone unlikely to cause any benefit in that situation. It is more of a antifibrotic and anti-inflammatory in the long run. I don't think it will be of any value in the acute kidney injury due to contrast.
So the role of finerenone in patients who have a normal albumin, I think this is not one. Only for patients with residual albumin is indicated.
Yeah, if let us say you are giving ACE or ARB and the albuminuria is still 300, 400, 500, you are given maximal doses of ACE or ARB, then you can add finerenone because residual albuminuria. Obviously, if the albuminuria is there is no albuminuria at all, whether at least based on the data, we can say we should not use it. Maybe in the future we will have data for that also. That it actually is a primary prevention. Let's say in diabetic patients, given finerenone, you may actually decrease the onset of albuminuria. It is possible. Yeah. Right now there is no such thing.
Thank you.
What are the basic differences and advantages of eplerenone versus finerenone?
See, eplerenone is a weak MR antagonist compared to finerenone. Finerenone is more potent, and risk of hyperkalemia is obviously, like I said, it is much less. So, in terms of the selectivity to the MR receptor, eplerenone is a weak agent compared to spironolactone or finerenone, because finerenone is a very potent interaction with the MR.
SGLT2 inhibitors have shown wonderful results for as DAPA-CKD and AMPA. So you talk about hyperkalemia. Does the additional benefit is also for this for SGLT2 with the drug?
Yes, like I said, in the Fidelio studies, about 6% of patients also received SGLT2, and definitely the use of SGLT2 inhibitor does not decrease the benefit of finerenone. So it can be used in combination, like all the guidelines are now saying finerenone should be added to standard of care. That means ACE, ARB, SGLT2 inhibitor and finerenone, all three. That's what I showed you. Drugs with proven cardiovascular and kidney benefit are now the pillars of treatment in diabetic CKD.
What about using in patients with heart failure alone?
Yes, at the time these studies were conceptualized, heart failure with reduced ejection fraction less than 40% EF was excluded because it would be unethical to take such patients for the study and give a placebo. Therefore, currently such patients were excluded from the study. However, a study is currently ongoing comparing aldactone to finerenone. So what I would say is that, let us say a patient with heart failure requires aldactone, but does not get it because of side effects, hyperkalemia or anti-androgenic side effects, then definitely finerenone can be used in such patients because it has equal cardiovascular benefit in heart failure. It is just that in the studies they were excluded because of ethical issues.
In heart failure patients, when you are using all these new drugs, worry is always hyperkalemia. So don't.
Yes, yes.
So I think this will be a good addition.
Right.
With all the benefits.
The average potassium rise was only 0.2 milligrams. 0.2 milligrams. Therefore, if you start somebody, FDA has approved the use of finerenone up to potassium of 5, even though study was 4.85. So even if the level goes from 5 to 5.2 or 5.3, it is still okay. So therefore, the rise in potassium is not very high. Obviously, when the patients have advanced CKD, you have to be extra careful. Therefore, when you start the drug finerenone, within 3 to 4 weeks, you should check a potassium level to make sure that the level is not greater than 5.3. Yes, sir. In the studies, it is more than 25, but you can continue to use it till the EGFR falls to 50 if you already started.
I have a question. I'm in agreement with Dr. Nath because he was the one who started off with this Arni, sacubitril and valsartan combination. Do you think that this would be in addition to?
Yeah. Like I said, the heart failure studies are currently ongoing. In addition, benefit definitely on top of ARB, it is already shown. Arni not studied per se, but I don't see any reason why it should not be.
See, it's a more conserved Arni. So with Arni, we are reluctant to start aldactone.
Yes.
So
this will be better.
This is the drug, I think, and because we always think that patient will develop hyperkalemia and all that. So
I mean, that is a major advantage. You have all the benefits minus the side effects. That's the. That is why this is uniquely positioned.
Sure, there's a trial, I think, going on. Patients with heart failure, both above 40, below 50.
Yes,
it is ejection fraction.
Dr. Kannan.
Thank you, sir. It was a wonderful presentation, sir. We had 3 major trials with the FINI. You know, the artist type we have Fidelio, then we have Figaro, sir. Fidelio is mainly for this one kidney outcome, and Figaro for a cardiac outcome. Regarding the, in the placebo arm, the incidence of hyperkalemia is more with FINI, but it's more with finerenone. But if you see the finerenone comparing this spironolactone is somewhat less. The recovery from the hyperkalemia is somewhat rapid with FINI on comparing with spironolactone and FB. This is my message about finerenone, sir.
See, the reason hyperkalemia is less with finerenone is believed to be due to its short half-life. Its half-life is only like 2 hours, whereas aldactone has a half-life of more than 20 hours. And in fact, if you take 1 dose of aldactone today, even 1 week later, you will still see the drug in the body. So, remember, in the kidney, the filtration is a continuous process. So, even if you are giving an MR antagonist, that may actually increase the potassium, but it's going to increase the potassium only for 2 hours instead of 20 hours. Then the risk of hyperkalemia is less. That is the mechanism believed to be involved in less hyperkalemia with finerenone. So I think so the duration of action is very important. Whereas the anti-fibrotic effect is not dependent on the half-life per se, but other mechanisms. Therefore, even though half-life is less, in fact yesterday we had another session, somebody was asking, should you actually therefore give it more frequently? Not necessarily so. Because even at once a day dose, the anti-fibrotic, actually of course in humans we cannot do show the effect of fibrosis, but in animal trials they have already done that there is a significant decrease in both cardiac fibrosis and kidney fibrosis in animal trials when finerenone was used. The reason I said this is a novel molecule, more than 1 million molecules actually were searched to develop this finerenone, and it was modified so that to make it more tolerable. So a lot of work has gone into this for the last 20 years. And like I said, 13,000 patients is the most, all nephrology trials put together don't have 13,000 patients. So this is steady. And in Fidelio and Figaro, the method was almost the same. The protocol was exactly the same. Inclusion criteria, slight differences.
Outcome also there are differences.
Obviously, the primary outcome was cardiac in Figaro, kidney in Fidelio, but they were opposite. So complementary outcomes.
I would request the Pitama of medicine, Dr. Bhargava sir, my mentor, to share his experiences, because if it is 100 years for insulins, here I see a person in life, 80, still going strong. Let's all wish him.
Srikant, I've just stopped attending emergencies. It was an interesting session. In fact, I have attended all the sessions conducted by Dr. Faraz. In all the this is the 5th time I'm attending his conferences, and he should be complimented for having something remarkable and renewed every time. And today, whenever we attend such sessions, we come for 2 reasons. First reason is meet people whom we have not missed for a long time, and then second is learn, because learning is a continuous process. And in fact, today I would compliment the last speaker, because I came specifically for this session. And as I said, diabetes is a fantastic disease. When I was a student in 1965, I was given the thesis Diabetes and Cardiovascular Complications by my professor. And he says, Vinod, you will remember me throughout your life, because it will ensure your life. So with that, from the past, from 1965 onwards, I've been always fascinated by what is happening in diabetes. In fact, somebody from Apollo Madras, Chennai has come. Shesaya was a good friend of mine. So, I can say that with this disease, we learn everything new every time. The disease has been said to be present from antiquity. It is perhaps the first known disease in the world, in humanity, and there have been constant attempts every time to understand it, detect it, treat it, and prevent complications from the patients. But every time it surprises us by new means of happenings. So with this, I can say that many of my colleagues might be feeling hypoglycemic, so I should end. Let us go and have a good meal.
Thank you, sir. I think we'll close the session for the want of time, and then I request the organizers to take over the proceedings.
Hello. Thank you so much. It was a very interesting session. Now, I request Dr. V.K. Bhargava sir to please felicitate our speakers. I request the speakers to please come on the dais. Dr. S. Venkataraman sir, Dr. Mani Deepti Desari ma'am, Dr. P.K. Jabbar sir, and Dr. Rajanna Sridhara sir. So I request Dr. V.K. Bhargava sir to please felicitate our speakers. Dr. S. Venkataraman sir. Dr. Mani Deepthi Dasari ma'am. Dr. P.K. Jabbar sir. Dr. P.K. Jabbar sir. And finally Dr. Rajanna Sridhar sir. Now, to felicitate our panel members, I request Dr. P. Raghuramulu sir to please come on the dais. I invite the Dr. P. Raghuramulu sir is felicitating Dr. J. Srikant sir. Dr. J. Srikant sir. Dr. P. C. Raj sir. Dr. V. K. Bhargava sir. Dr. Harpal Singh sir. Dr. Pri Srinivasulu sir. Dr. N. Kannan sir. I request all the speakers and panel members to come ahead for a group photo.
Madam, come please. Okay? Sir, sir. Smile, smile, look here. Thank you.
Thank you so much sir. Now it's the time for lunch. I request all the dignitaries and doctors to please visit the hall at the first floor, which is above the reception. The lunch timing will be till 3 o'clock, and soon after the lunch we will be starting with a third symposium, that is diabetes and lifestyle. So meet you soon after lunch at the first floor. Thank you so much.
You say percent of the patients in this who are losing overall arms. Study design we are conducting in our site. It is ongoing. It will be probably close. And this is the time to be but primary answer. Up to respect instead of care medication. All patients see look at you can fight it when 1 hour and 10 in our scope we use in our and the is the right way with see that fluid benefit profile of the patient improves. The triglyceride for this, and there is a scoring. Also, it reduces the HCR, the lipid, the histolipid. Of course, start over less than 1 year old. Plus more than 5% out of 10 achieve this target with 10 G. The best part, you should. Okay. So the early initiation just for every disease, but this is the evidence we are showing in the look at when impact the frequent diabetic complications and usually they can cause because of reduction. Clearly, large base, know there are 5,000 patients.
rest. 30 st and 120 minutes, and the 30 minutes got rest. Another most of us to do
where hard work should ketosis, because insulin is needed to prevent ketone formation. So definitely the insulin should be very meticulously reduced and with frequent monitoring, and never more than 20% reduction should be done. Similarly, titration of oral hypoglycemic drugs. If the patient is already receiving ACE or ARB, we can continue the same thing, because it's a blessing in disguise. ACE inhibitors increase the potassium levels, whereas dapagliflozin has a calorific effect, which promotes the loss of potassium, and they all work synonymously. Similarly, RNAs can also be given, but particularly MRAs can also be given. And very important point, what we should do is education of the patient. Two things should be told to the patient. One is about the sick day counseling. Because all the SGLT inhibitors cause osmotic diuresis and volume loss, patient should be told that in the event of patient experiencing vomiting, slow stools or any other sickness, and the patient should stop these drugs immediately and report to the treating doctor. Similarly, if a planned elective surgery is being done, dapagliflozin or any SGLT2 inhibitor should be stopped before 3 days an elective surgery, and can be restarted 2 days after, basing on the patient's status. Another patient counseling fact we should all tell is about the genital hygiene, particularly in diabetics. If you are starting this, many of the patients, males will be having prostatic hypertrophy and bladder outlet, and females may be having diabetic cystopathy. In these patients, we should inquire before starting whether they have any obstructive urinary symptoms. Similarly, patients with renal stones. When you know that confidently these are not there, you can start them, and also along with the maintenance of genital hygiene. If the patient has a history of genital mycotic infections already, you should consider on a case basis of giving prophylaxis before starting this thing. So this is very important, because we have seen one patient with obstruction, urinary tract obstruction, who was not being treated for the obstruction for a long period. thereby reducing the oxygen consumption into the kidney, which allows more oxygen into the renal medulla. So as such, kidney has more oxygen when patient is on dapagliflozin, and most of the acute kidney injuries like sepsis or contrast-induced injuries happen because of more of hypoxia in the renal medulla. So this could be one interesting fact. But however, when the patient is in active sepsis, it is better to avoid starting SGLT2 inhibitors irrespective of other things. So finally, this comes to the last part. Are all dapagliflozin same as Forxiga? Because Forxiga was the original molecule that has been studied in all the three trials, DECLARE, TIMI, DAPA-HF, DAPA-CKD. In short, the answer is no. All the dapagliflozins are not Forxiga, like we are all aware. This is because pharmacological equivalence doesn't mean a bioequivalence, and a bioequivalence never means a therapeutic equivalence. Because even if the drug is having the same 10 mg, the bioequivalence could be plus or minus 20%. And similarly, if it is less, the pharmacological effect will be less, and if it is more, the side effect will be more frequent. So Forxiga has been robustly blocked by all the trials like DECLARE, DAPA-HF, DAPA-CKD, while the other molecules have no similar thing. This use of other brands like generics we have seen previously when the patients were taking statins and clopidogrel, generic statins, generic clopidogrel, where they were noticed and thrombosis and etc. With this, I would like to conclude my talk. And the take-home point is SGLT2 inhibitors are the wonder molecules or pleiotropic molecules, just like what was statins and ACE inhibitors earlier, 2 decades earlier. So start SGLT2 inhibitors in all patients with renal failure early and irrespective of diabetic status, and don't forget to patient counseling and sick day counseling. Thank you.
Thank you, Dr. V. Sanachandra, for the excellent presentation and the meticulous methodology and preventing the further progression of the disease per se. Now I would request Dr. V. S. Ramachandra to come on the stage, and his topic will be optimizing approach to diabetic cardiomyopathy, implications from the Emperor Preserve study. This is the second part of the Emperor study which we'll be focusing on. And to introduce her, Senior Intervention Cardiologist, Sri Holistic Hospital DM in Cardiology from Kasturba Medical College, Manipal, well versed in electrophysiology and pacing during his fellowship at St. Vincent's Hospital, Indianapolis, Pediatric Electrophysiology Fellowship, Intervention Cardiology from USA. He has over 2 decades of experience. I'm sure we're going to benefit from that. Vast experience in electrophysiology studies, syncope studies, AV and RT ablations, AV RT ablations, atrial tachycardia ablations, catheter mappings, pacemaker implants, AHCD implants, biventricular device implants, laser lead extractions, and so on. And I just request him to take note.
Thank you, sir, for a very kind introduction. My talk is on heart failure and empagliflozin. 3-4 things before we start the slide presentation. The first thing is that all diabetics are very prone for heart failure. As you can see through the slides that we will show you later, almost more than 50% ultimately have some evidence of heart failure. Okay, it's come up. So this is a cardiovascular risk calculator like thing. You can see here for patients with atherosclerotic vascular disease, you are talking about risk of 10 to 20%. So you're talking on the left side, you can see you're talking about risk of 10 to 20% per year with cardiovascular disease. But when it comes to heart failure, you're having a minimum risk of 10% every year, and if the person gets admitted, it almost goes to 40 to 50%. And if you combine heart failure with atherosclerotic cardiovascular disease, the risk is a whole lot more. So these patients are basically at very high risk for hospitalization as well as myocardial infarctions and deaths. Now in diabetic cardiomyopathy, you have 3 or 4 spectrum. One is a diabetic patient has ischemia, or he has already had a myocardial infarction, in which case you can call it ischemic cardiomyopathy. That's in around 50 to 70%, but there's a good 30% where you will not find ischemia, but the person is having LV dysfunction, either diastolic or systolic, and that's because of so many of these factors that you can see on the slide. Now here we have a theoretical patient, a 63 years old female with long-standing hypertension and diabetes. She's slightly obese and she's complaining of breathlessness on walking. And you can see the creatinine is okay, she has some proteinuria, but she has ECG evidence of left ventricular hypertrophy. So, and the ejection fraction is around 58%. So this comes to, we come to now, what is heart failure? So basically heart failure is a clinical syndrome. A person has symptoms of left heart failure, which means he has breathlessness on exertion, or he has PND orthopnea, or even frank pulmonary edema, and later on he has right heart failure symptoms like a raised JVP, hepatomegaly, or pedal edema. So basically heart failure is a clinical syndrome. Without that you cannot really diagnose heart failure. Next is you should be able to localize his symptoms to the heart. Either the person has frank left ventricular hypertrophy or left atrial enlargement or other evidence of diastolic dysfunction on echocardiography, or he has LV dysfunction, ejection fraction is less. So either one of these. So echocardiogram is very important in diagnosing a structural problem in the heart, and with that you can add the elevated natriuretic peptide levels to localize the symptoms to the heart. And you can have objective evidence of pulmonary congestion or systemic congestion. The one very common test that we use is make the person exercise and look at his pulmonary hypertension. If the pulmonary hypertension is going up, we know that he has left ventricular dysfunction, although it's very incipient. So if you look at this universal definition of heart failure, stage A means a person is at risk for heart failure. This means every person with diabetes, hypertension, obesity is at stage A. Stage B means he has some structural problem, either left ventricular hypertrophy or there is evidence of increased NT-proBNP. Stage C is he has some symptoms. Stage D is he has advanced symptoms. So this is a very important slide, because from this slide you can make out that every patient with diabetes or hypertension is already at stage A of heart failure. Now if you look at what percentage of diabetic patients have heart failure, it's almost, most meta-analysis will show around 50 to 70% of patients have heart failure, which means they have clinical symptoms of heart failure, either decreased ejection fraction on echocardiogram or increased NT-proBNPs. So these are the phenotypes. Usually the difference between preserved and reduced ejection fraction. The reduced ejection fraction people have more myocardial infarctions. The preserved ejection fraction is actually a multisystemic disease where they have lung disease, atrial fibrillation, obesity, some amount of renal failure, and hypertension, and especially old age females. So this is the basic difference, but otherwise they're quite similar in their prognosis. So surprisingly, heart failure with preserved ejection fraction has the same prognosis as heart failure with the reduced ejection fraction. So this is a similar slide that shows that almost 25% of all people with diabetes have heart failure. Now what does SGLT2 inhibition do? It reduces the preload. It's basically a very smart diuretic, which means it produces an increase in free water clearance without stimulating the renin-angiotensin or the sympathetic system, which all diuretics do. As you know, if you give a diuretic, the first thing that happens is the sympathetic system and the renin-angiotensin system are activated, but this does not happen with SGLT2 inhibition. Then it decreases the afterload, which is also very important, and it has direct effects on the myocardium, which I think it must have been discussed in the previous studies. The main way it probably works is increasing the metabolic efficacy as well as decreasing the extracellular volume in the heart. So there is a lot of extracellular volume which includes fibrous tissue as well as other things. So that is decreased by the SGLT2 inhibition. So the first study that came was the EMPIRE-REC outcome. This was in diabetics who already had atherosclerotic cardiovascular disease, which means all patients had cardiovascular disease. And this is the only SGLT2 inhibitor that has been shown to actually decrease cardiovascular mortality, especially if the person has had a myocardial infarction within 2 years. So if a person has myocardial infarction within the last 2 years, we definitely prefer empagliflozin over any other SGLT2 inhibitor, because this is the only drug that actually showed a significant decrease in reduction in the 3-point MACE. And of course, it seems to show a better efficacy with the Asian population. If we come to heart failure, the Emperor Preserved study is a study that actually took in patients with LV ejection fraction more than 40%, because there were already very good studies with ejection fraction less than 40%. And they randomized at the initial onset itself, people with more than 50% were randomized initially itself. So what did it show? That it showed a significant decrease in cardiovascular death and hospitalization, mainly in hospitalization. So basically it is mainly a drug for heart failure rather than a drug to reduce cardiovascular mortality, cardiovascular atherosclerotic death directly. It is mainly a drug that reduces heart failure hospitalizations. So you can see here the number needed to treat increases from 21 to 42 if the ejection fraction increases. And actually if you look at ejection fraction more than 60%, there is very little benefit at that stage. So basically you need some LV dysfunction, some decrease in the ejection fraction, less than 60% at least ejection fraction, these drugs do well. And across all the subsets, whether it is the sex, whether the person has diabetes or not, baseline EGFR, history of atrial fibrillation, in all these subsets, these drugs do very well to prevent heart failure. In fact, they decrease the incidence of atrial fibrillation also. So very commonly we use dapagliflozin in patients with increased BNP to decrease the incidence of heart failure also. If you look at the side effects, difference between placebo and empagliflozin is very less, except for the genital infections. Really no difference here, at least in these studies. So these are the drugs that are available for treatment in heart failure with preserved ejection fraction. As you know, this is very common in India nowadays. There are a lot of people with breathlessness. Their echo seems to be normal, but their BNPs are very high, and they either have diabetes, hypertension, or some other cardiovascular comorbidities. So we have these old trials, ACE inhibitors not very useful. Spironolactone was the only drug that we used to use because Stopcat had some reduction. Then came Paragon MF. It almost reached statistical significance, but it did not finally. And the Emperor Preserved and other DAPA's trials also showed significant reduction in a composite of cardiovascular death and heart failure hospitalizations, mainly by reducing heart failure. This is a nice slide that shows where you can get benefit from these drugs. If you look at the number needed to treat, if you look at atherosclerotic cardiovascular disease without prior events, with prior events, and heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction, as the person has more comorbidities, he is at a greater risk for atherosclerotic cardiovascular disease, and his ejection fraction comes down, the number needed to treat to produce benefit comes down. So basically you can use it across the whole spectrum, but it seems to be more cost effective, more beneficial in patients with atherosclerotic cardiovascular disease and reduced ejection fraction. So these are the recommendations in the AHA 2022 guidelines. They are given a 1A recommendation in all patients with type 2 diabetes if they have other cardiovascular risk factors, whether or not he has heart failure. So it basically means if in all patients with type 2 diabetes, if they have other cardiovascular risk factors, the commonest risk factor is either metabolic syndrome or hypertension, then you should use, 1A means you should use SGLT2 inhibitors to prevent heart failure. And it has a class 2A indication in all patients with heart failure with preserved ejection fraction. In fact, this is the only drug that has such a recommendation. If you look at all the other drugs, they have a 2B indication. So basically, the summary of this presentation is that SGLT2 inhibitors are very important in both preventing and treating heart failure, whether it is of decreased ejection fraction or if it's of a type of preserved ejection fraction. Thank you.
Thank you, Dr. V.S. Ramchandra, for your first presentation. And a lot of many things that we came to know through that, how important it is to approach these patients, because there is a very debilitating problem in decreasing the quality of life of every individual who is suffering from heart failure. So early detection is the main key over here, and I'm sure that during the debate we were having a lot of questions on that front. So now I would request Dr. Biju Govind to come over, and his topic would be tipping point for early intensification with a homogeneous blend of GLP-1 plus sodium glucose co-transporters, and he's going to present that. You have not put the slide here. Okay, right. I think sir needs no further introduction, but nonetheless, to finish the formality, Dr. Biju Govind has a wide experience in coronary and structural heart disease interventions for over 2 decades. Fellowship of American College of Cardiology, USA, Fellowship of Society of Cardiovascular Angiography Interventions, USA, Professor in Cardiology Department in various medical colleges, co-convener of AP Chapter of Cardiological Society of India, held in July, faculty in many international and national conferences in Seoul, South Korea, Euro, PCR Paris, Asia PCR Singapore, and has many international publications, the IECR Heart Journal, International Journal of RS Medicine Science, and Asian Journal of Medical Sciences, etc. Has vast experience of research work and paper presentations at international and national conferences. I would like him to take over.
Thank you, sir, for the kind words. I know it's end of the day talk and a very weary sort of crowd here. I'll make it very short and crisp. No hardcore statistics, no hardcore lecture here. Just to add to the small thing which we have already listened to, the heart failure with preserved ejection fraction is, which we listened to earlier, is slightly different from what I'm going to talk. Is an extremely important entity, because when we talk about heart failure, we always think about a failing heart where the ejection fraction values come low. We see the echo report, we see the ejection fraction values of 20, 25, 30, we get scared. But sometimes patient can have normal ejection fraction of 50, 55, 60, 65 and still have heart failure. So that is an entity which is equivalent bad mortality, short and long-term mortality compared to reduced ejection fraction, with very few therapeutic armamentarium with us, and hence drugs like this, SGLT2 inhibitors, in this particular case we spoke about empagliflozin and Emperor Preserved, makes a huge impact. I will stick to my talk now, and I promise you I'll leave before I'm asked to leave. These are things which are known to all of us, that HbA1c values at various stages. You can see that there is a sweet spot of HbA1c between 6 and 6.9, where the mortality is cardiovascular and all-cause mortality is low. And irrespective of the age, when the HbA1c is more than that, that is more than 7 or below 6, the mortality is more. We also had a short study with my friend Dr. Ravi. We did a short study of around 60 patients in HbA1c in acute decompensated heart failure admitted in a hospital, and we found that the higher quintiles had a higher rehospitalization rate in 1 year post discharge. These are 4 big studies which I am sure most of you have gone through in detail, but they have actually shown us mixed results. UKPDS of course came first. It was there before most of these newer drugs were available. UKPDS showed that early intensive therapy actually decreased CV death and CV mortality, and slightly different results came out of the ACCORD and the VADT. Nevertheless, from HbA1c being the central focus of the discussion so far today, and what we do in our regular practice, we are slightly shifting our focus to protection of the organs as well as controlling the A1C. Delayed intensification of therapy in heart failure does bad. It increases cardiovascular mortality, it increases heart failure risk, it increases the risk of MI, and increases the risk of stroke. This particular case is a hypothetical case, so this is not a true case scenario, but a typical case which most of us see in our day-to-day practice. This lady is a 55-year-old bank employee, a workaholic with multiple risk factors, including diabetes of 5 years duration. She has some breathlessness issues for the last 1 week, we'll find out why. She also complains, though she is only on 3 drugs there, as you can see, she still complains she is finding it very difficult to adhere to the therapy. When she underwent the evaluation, again the values are hypothetical. Here we see that the HbA1c is not in perfect control there. The BMIs are large. The insulin resistant indices are unacceptable. eGFR has fallen below 60. And you can also see that the HDL cholesterol, as is wont in most of the South Asians, are on the lower side. She also went an ECG and an echocardiogram as a part of the evaluation, and she was found to have left ventricular hypertrophy. And on the right side echo, the quad screen, the right upper screen shows left ventricular hypertrophy, and the right lower screen there shows left atrial dilatation. The pictures on the left are for comparison for the normal image for you to understand. So this lady not only has multiple abnormal lab values, including early fallen GFR. She also has target organ damage in the form of left ventricular hypertrophy. She also has a raised urine albumin creatinine ratio. So essentially we have 2 target organs being affected in this case. She has microalbuminuria by definition. She also has left ventricular hypertrophy. So this lady has LVH, left ventricular hypertrophy, an early albuminuria and falling eGFR values with multiple comorbidities. And she also remember, we can't increase her drugs too much because she has a concern with the pill burden, being a busy financial sector employee. These are the various options in front of us. I will stress the talk which we have to, what we are talking on today is essentially the combination therapy of SGLT2 inhibitors and DPP4 inhibitors. In this particular case, a patient of diabetes with cardiovascular or heart failure risk, SGLT2 inhibitors with proven benefits should be used. So in this particular case, probably any of the SGLT2 inhibitors, your dapagliflozins or empagliflozin, Cana or even ertugliflozin, not available with us, so we won't talk about it. Any of them would be equally good. But if heart failure is the only concern, but if you're looking at concerns about the CV mortality and CV benefits, then you look at only at empagliflozin has proven benefits. I'll tell you why in the next slide. DPP4 inhibitors at the same time, again, I have no qualms in using linagliptin or sitagliptin in this scenario because both of these drugs are very safe as far as the CV outcomes are concerned. So this lady with heart failure and uncontrolled diabetes, these are the various 4 trials which we are all aware of, so we won't spend time here. We can see that all the boxes are correctly ticked by empagliflozin, closely followed by Cana and Dapa, which also are okay in most of the scenarios. Cana actually is also good for 3-point MACE reduction. So if you look at empagliflozin has nephropathy benefits, decreases major adverse renal kidney endpoints, it decreases CV death and decreases death from any cause. The next 10 minutes before I conclude, I'll just try to emphasize the point a little bit more with these particular slides, which actually shows empagliflozin with placebo. The time to a cardiovascular death, as found out from the EMPA-REG outcome study, is that at day 59 is when the upper limit of confidence interval crosses the line of unity. So the benefits start at day 59 as far as CV death is concerned with empagliflozin, and the benefits are maintained till the 360 days. So early benefits and sustained benefits with empagliflozin throughout the study trial. If you are looking at heart failure, so first hospitalization for heart failure, here the benefits are seen even earlier. On day 17, you see that the upper limit of confidence interval falls below the line of unity. So day 17 is when the benefits get attained, and if you are combining both time to first hospitalization for heart failure or CV death, you get benefits from day 27. So very early benefits and sustained benefits. So I think this is one situation where you should reap the benefits as soon as possible without the patient really ending up with a hospitalization for heart failure. Remember, this lady already is in stage B heart failure, and Dr. Ramachandra has very clearly put out all the 4 stages. So we have only 3 C and D left, so she's already in stage B. As far as linagliptin is concerned, in this particular case, I already mentioned sitagliptin is equally good to linagliptin in this particular scenario. Saxagliptin unfortunately has an increased hospitalization for heart failure. So probably there's one drug which I would be, as a cardiologist, be a little beware of using that. But Sita and Lina are quite okay with me in this particular case. Lina probably has a little bit more evidence as far as renal outcomes are concerned. But as I told you before, I am quite pally with both in this particular scenario. In this particular lady, for example, SGLT2 inhibitors in this particular case, of course, we know that DAPA-CKD went down with eGFR up to 25 and EMPA kidney studied up to 20. So it is pretty safe to go down up to 20, though the recommendations still don't go that low. But I am quite confident, I'm sure our nephrologists also would be very confident of using these drugs early and for sustained benefits, and even with lower eGFRs. In fact, some one-to-one talks, I had some nephrologists telling that they are happy even using it below 20. That I think is an individual preference, below 20 eGFR. The other quick point I want to stress is microalbuminuria. I think as we go on seeing patients in the clinics, I think we should look at microalbuminuria and UACRs more often. I'm sure the seniors here would be doing it. And microalbuminuria does not have a cutoff there. Every increase, even below the normal, what we call below 30 milligram per gram creatinine, we say is normal, but essentially it's not normal. There is a difference between 10 and 20. So there is actually, it's a scale of events, and the worse the microalbuminuria, the worse is the ischemic stroke. The higher the microalbuminuria, the worse is as far as the ischemic stroke risk, MI risk, and all-cause mortality is concerned. So it's not an innocent bystander sort of finding in the report, in the urine report, urine workup of the patient. Empagliflozin ticks all the right boxes again as far as the heart kidney outcomes go, or softer outcomes like albuminuria or eGFR decline. EMPA ticks all the right boxes. Just to put in perspective, if at all, if you want to really push the envelope further in favor of linagliptin, what I would say is that Carmelina, which was you are aware is a combination of Lina with glimepiride, studied 62% of patients with eGFR of less than 60. The other comparative studies did not have as much patients with low eGFRs. However, these are of course different studies, and we don't compare head to head, putting in a slide just like that. But I was just trying to put my point a little bit more stronger there. I'll skip this slide for paucity of time. Just a couple of slides before I conclude. Empagliflozin plus linagliptin actually has been shown to delay kidney fibrosis. Small study from India with 45 patients, but shown as early as 12 weeks. You know that TGF-beta1 is levels improve, which we know decreases renal fibrosis. So that's one point to be remembered. So the combination of two of empagliflozin and linagliptin decreases HbA1c. The combination decreases 1.2 to 1.8. These are excellent values. I'm sure all of you would agree. We are looking at levels attained by insulin or GLP-1 receptor analogs, as the previous speaker had pointed out. It also has CV evidence, which we already quickly alluded to. We have renal evidence with Carmelina and EMPA-REG outcome, and hepatic evidence. So, except that there is some dose adjustments required in renal failure, there is no dose adjustment required in hepatic failure. I agree that this doesn't match with the beauty of GLP-1 receptor analogs, where we don't have to look at it as the previous speaker pointed out. But when was the last time we saw a drug which did not require any adjustments required, not even a least of adjustment required for absolutely, end-stage renal disease and child puke C hepatic failure? I can only point out 2 or 3 drugs. So that way I think this is an excellent combination. Lina, of course, can be used very conveniently again. So the real world, the RCT evidence, not real world, in India with the combination of SGLT2s and DPP4Is I'll spend a couple of minutes here before I conclude. Empalina combination, which is available in India, Dapa-Saxa, is all BMS, both of them are BMS product. Dapa, of course, is marketed by Abbott in India, Astra in India, sorry. And Removilda. Now, this slide speaks for yourself, for you to see which one would be the preferred drug if you have to use only one. The problem with remogliflozin is you don't have CVOT trials, and it is now an Indian company owned brand, so it's very unlikely that we will ever have any CVOT data at all. Vilda also is out of patent, so no CVOT data is expected from vildagliptin. We had some issues with the LV size being increasing in patients who are on vildagliptin. So we know that increase in the left ventricular dimension is the early sign of heart failure. So though we don't have concrete evidence that this produces increased hospitalizations, there is a subtle evidence that it can increase LV volumes, which I'm not comfortable with as a cardiologist. So Empalina is green everywhere and yellow everywhere, but Dapa-Saxa almost is good for me, except that Savartimi data showing increased HHF risk is a dampener sort of. So this is a sort of the Empalina combination is safe and widely used, and it's a convenient dosage. So this particular lady which we have, she is on the road there. She has reached a point of micro and macrovascular complications, as you can see. The idea is to put a roadblock here so that she doesn't proceed further to end-stage heart disease and death. So that's for that I would a combination of Empalina would be one of the things which can be clearly thought about. Cost, yes, that is always, though we are in a scientific forum and we should not be talking about cost here, but still in India, no prescription, no patient leaves your clinic without that barrier crossing your mind and the patient's mind. Studies from India has clearly shown that diabetes-related treatments, the treatment is only 28% of the cost. Complications, hospitalizations, monitoring for screening of complications, other costs and working days lost form the large chunk. So the treatment costs, though we tend to give it a much, upfront it is high, but over the long term, as you can see, it forms only a fourth of the whole direct and indirect costs on a diabetic patient in India. Sorry, and if you see the other part, if you use a fixed drug combination, in this particular case, as of now, we don't have a generic, approved generics are not there. It is still branded, but still, the FTC cost is lower than individual costs, and we have risk reductions of huge percentage, huge relative risk reduction. Absolute risk reductions are much lesser, but still they are still significant. And with a significant HbA1c reduction, I'm sure it's a win-win situation for all. So this is how this lady goes from the clinic this time. Her DPP-4 metformin FDC has been replaced with Empalina. Of course, metformin never leaves the prescription there. Ramipral doses had to be increased because her blood pressures are not in good control. So we also will also follow the kidney functions for further deterioration. So that slide, of course, missed that the statin dose has been inadequate. So statin doses will also be stepped up. Probably we will change atorvastatin to rosuvastatin in this particular case. Thank you for your patient listening.
Thank you, Dr. Biju Govind, for your excellent presentation. And I would request all the speakers to be on the dais, and I would like to thank Dr. Neval Chandra, Dr. Manshua, and Dr. Swaraj for having graced this occasion today.
Thank you, sir.
Yeah, thank you. I think that was a wonderful session that we had, the symposium of various aspects that involves the management of the complications of diabetes. I think to set the ball rolling, I have a few questions to ask. We have Dr. Srinivas Murthy, who has an extensive experience in lot of trials. So it was wonderful listening to you. So what my question is like, when do you prefer the semaglutide? As we know that this is the era that's going on for the SGLT2 inhibitors because of its pleiotropic effects that we are seeing. When do you prefer that semaglutide has edge over the SGLT2? Are there any particular situations wherein you prefer semaglutide alone? Do you think semaglutide has an equal amount of pleiotropic effects in a line similar to the SGLT2? Being a nephrologist, my question is, we prefer SGLT2s because the GFR has come down. Now with the kidney, the GFR has come down to 20. So, and there are certain case reports as far as the semaglutide is concerned with respect to 1 or 2 case reports. I don't say it's a definitive evidence of a little kidney injury is there, though the benefits are much more in the management of albuminuria. 1 or 2 case reports are there of AKI. So my question is like threefold. When do you prefer semaglutide over SGLT2s? Truly, is there any experience of the SGLT2s over the kidney injury? And is there any? Do you see that the SGLT will be overtaken by the semaglutide as far as the pleiotropic effects is concerned? Over to you, Dr. Murthy.
Thank you, ma'am. I think that's a very practical question. The indication for oral sema or GLP-1s is equal like SGLT2. This is as per recommendations for all the bodies. Remember this. All the bodies says SGLT2 or GLP-1. The GLP-1s, that was the only disadvantage when all these bodies were recommending. Because of injection phobia, we were hesitant to choose that. It was a daily pricks, all that. Then the once a weekly pricks came, the GLP-1s. And now the tablet form has come. And that's the greatest advantage. So, as far as the clinical evidence is concerned, they are equal, including with the pleiotropic benefits. Whereas the SGLT2s are little with the heart failure, which is a class effect. The class effect of heart failure is seen in the SGLT2s. But the GLP-1s have got an equally good amount of pleiotropic effects, especially when it comes to the weight reduction. It has got an upper edge. So it is not a class effect for both these. You cannot compare. It's not apple to apple. It's an apple to orange kind of comparison. But as far as evidence is concerned, it is equal. The only catch with the oral sema currently is the cost. That is a limiting factor for prescriptions, which we were facing with the SGLT2 until recently, until this DAPA came up with the generics. But otherwise, they have gotten the generics. I think one of the slides clearly showed what is the impurities seen and the complications of impure generics that was alluding to. That we need to keep in mind when you are prescribing the innovator molecules versus generic. With due respect, of course, because our patients are benefited with the cost benefit, but at the same time, what is the exact benefit which is translating, which none of us knows, because these are all the evidences which we are seeing from the West. The Mount Sinai, the Singapore ones which they showed, so clearly the statins and the other molecules, they have demonstrated that the pleiotropic benefits of the CV safety is not seen when you use generics versus the innovator molecules. And that we see practical also in our routine clinical practice. When you put an innovator molecule like a pregabalin, I don't want to name the innovator molecule versus the other pregabalin, it does make a difference, including glimepiride, your metformins, etc.
Yeah, I mean, is there any RCT or head-to-head comparison of these SGLT2s vis-a-vis the semaglutide to say authentically that yes?
I got it. It is not vis-a-vis, but it is an add-on to SGLT2s. It has shown the pioneer trials which have showed. Literally, it is there as monotherapy, SGLT2s, the DPP4s, even versus insulin. So, apart from standard of care, you can add on, you can combine. Of course, you shouldn't combine DPP4 and GLP-1s, but SGLT2 and GLP-1s are wonderful combinations for a very high-risk patients. And the primary prevention, there are a lot of studies for your GLP-1s vis-a-vis the SGLT2s.
Do you think these will take a place instead of metformin in that algorithm of management of lifestyle? After that, you start with metformin, then only you think about top-up of the SGLT2s, or do you think are these going to replace in future over the because metformin is a long-standing batsman in the field? So do you foresee that these are going to?
No, it is not forcing. Already the bodies have come up saying that SGLT2s have to be in the high-risk categories, ahead of metformin. But I personally do not agree. All our Indian patients should be on metformin. 99% of our patients should be on metformin. I strongly propose that, but time has come that now SGLT2s or GLP-1s has to be literally for every other diabetic. If not, it's like a crime from our side that we are not giving the pleiotropic benefits. And weight reduction is the main, which I was showing in the slide.
Yes.
And that component, the benefit is more with the GLP-1s versus SGLT2.
So probably I understand that in obese diabetic prefer semaglutide over, maybe, I don't know, it's too early to say, because weight reduction is also an added advantage to semaglutide.
Exactly.
Yeah. So,
Hi, wonderful presentation, Dr. Murthy. I just wanted to ask you in continuation with Dr. Manjusha's questions. What about this GI intolerance or these, because first we have the injectable formulations and now the oral. So comparative, do we have that the incidence of GI intolerance to these molecules have come down, or are they the same? Or because this actually threw a big challenge when we first introduced this molecule. But over time, as we see, it has come down with more and more counseling probably. So are there any such data to show that one is better than the other in terms of GI?
No, there are no head-on trials with respect to the injectable versus oral compared to NASIA. It's all the different trials have been extrapolated and shown. But the tolerance, I said I was part of the SOUL study, which is going on from 3.5 years. Patients are very well tolerated. None of the patients are withdrawn for adverse events. And it was only in the initial 2 to 3 weeks when we escalate the dose, they tend to have this nausea and fullness. That is something which I have seen, the subtlety. It's so good for the patient. They're saying, sir, I used to eat 1 kilo, now I 100 grams, it feels, suddenly 1 idli, half idli, I feel full. And I'm very comfortable with my diet and the weight loss. So the nausea vomiting is initial period it is seen. If you prime the patients about like the SGLT2s and the mycotic or the UTI is what you need to prime. You need to prime our patients when you prescribe these GLP-1s that this is anticipated and do not panic. You come back and fatty meal avoidance, the late night dinners, all these you need to, whenever you swallow this tablet or injection, that is where it will have the lesser incidences. And if you prime them, none of these patients will come back to you.
Yeah. Thank you. I'd like to ask Dr. Sanat Chandra a question. This was pertaining to the pleiotropic effects of SGLT2s you mentioned. So, you've given us quite a bit of data showing the nephro-safety of the molecule, and then with the preserved EF, and then the low EF heart failures. But now a lot of cardiologists, as what we are seeing in their practice also, let it be an acute coronary event, even the patient who is a diabetic, they tend to start SGLT2s, especially DAPA. We are seeing more and more prescription of this going on. You don't need to have a patient in overt heart failure, whether EF preserved or not. But even with acute coronary events and all, we are seeing cardio. So your comments on this? I mean.
Sir, very relevant question, sir. Actually, the place where I am practicing is a full-fledged cardiovascular setup. What you said was 100% correct, sir. Irrespective of patient being in failure or not, most of the cardiologists prefer to start the SGLT2. And as such, there have been no events, at least in my setup, what I have seen is that the creatinine rise or acute fall in GFRs were pretty much in the standard, provided they have titrated the diuretic dose. Most of the things what we see in early heart failure is because the diuretic dose will be initially very high, but once the patient has achieved euvolemia, they tend to over-continue the same amount of loop diuretic dose. At this point, we could see an acute rise in GFR, acute fall in GFR. That is what we should be taking care of.
Can I just add on, Noel? I think the day of discharge, they initiate the drug. And that's where the crux is, that you need to call them for follow-up. You need to be careful when you're prescribing, because in the ICU, they don't start, but on the day of discharge, they just add on this, even in a non-diabetic setup. So the fall in eGFR is expected, like in ACE inhibitors also the same phenomenon is seen. The initial 2 to 4 weeks, there is a follow-up up to 30%, and then it picks up. So you need not have to panic.
I'm Dr. Swaraj. Sir, Murthy sir, excellent deliberation as always. One point I wanted to ask was with respect to what level of HbA1c you would want to start a semaglutide. For example, let me give you a small simple clinical scenario. A patient diabetic newly diagnosed coming in a catabolic state with HbA1c of 11-12. Are oral semaglutide is semaglutide an indication at that stage? Or rather, if you would ask me, I would rather prefer to start on insulin and then probably shift over to semaglutide, or semaglutide is a the first choice that you would rather go? Obese patient who has lost, let us say, around 10, 12 kgs because of hyperglycemia.
I think when these symptoms are there, you should ideally give insulins because our patients are bad. They do not come back. For example, you can work up for ketosis, rule out, and you can initiate the GLP-1s versus SGLT2 is absolute contraindication. You should never start. But the GLP-1s can be started. There are trials which are then inclusion criteria up to 11%, the A1C, as an add-on, of course. But you can initiate, but technically that is correct. But when it comes to practice, most of our patients do not follow our instructions. They do not come back as and when you want. So I don't think it's a wiser decision to start them and send them off so that they don't turn up. So it's ideal to start in that situation is insulin.
With respect to metformin going out of the first line, I think it has already started. 1 in 5 patients, Indian patients, do not tolerate metformin with respect to the kind of diet that we have. So and the ADA guidelines also suggest whenever we see a patient, look for CKD or look for heart failure, and then decide with the kind of drugs that we are going to use. So metformin has already moved away. It is just at the door. If somebody needs to push it so that it will fall. I think that is that stage of metformin we are. Also, with respect to SGLT2 inhibitor, sir, as a cardiologist, sir was talking about how much do you consider the dye-induced nephrotoxicity to initiate or not to initiate with respect to the SGLT2 inhibitors?
Thanks for the question, sir. So, as far as we were discussing about ACS...
sorry, sir. Only with respect to acute current syndrome, where you are planning a PTC.
I understand. So, for myself, and I speak for my team which we work, we don't use SGLT inhibitors in ACS at all. Unless we are absolutely sure we have finished our intervention, we have seen how the creatinine goes up, and if it has gone up, we give it time to come down, because, of course, early initiation is important, but ACS indications are more, coronary-wise, we are more concerned than the heart failure wise. But heart failure is a different scenario, obviously. We look at the diuretic, whether the patient is hypovolemic, euvolemic, and we decrease our torsemide or furosemide and then initiate. We push for SGLT2 inhibitors in that scenario, heart failure scenario. But in ACS, for us, we don't push because we have more pressing concerns of coronary revascularization. As you very rightly pointed out, dye is a very grave area of concern for us. So contrast agent use, washout, we give 7 days at least for the washout, for the creatinine to stabilize and then initiate. I hope I've given the answer.
Yeah, I mean, contrast-induced nephrotoxicity. Actually, for our information, in fact, the Radiology Society of North America says that we need to differentiate between a contrast-induced nephrotoxicity, contrast-induced nephropathy, vis-a-vis a contrast-associated nephropathy. So the team, the clientele of the patients that we generally see, wherein the patients have diabetes or hypertension or a pre-existing kidney disease come under the category of CAN, contrast-associated nephropathy, where probably there might be a little rise in the creatinine, maybe need of dialysis, whereas contrast-induced nephropathy is totally a different entity, where we need to say authentically that this contrast has induced the nephrotoxicity. So that's relatively little different.
Can I ask you, because we will all learn from this, so how do you differentiate? Like if a patient comes de novo to you and you don't have a baseline creatinine, how do you...
Yeah, that's definitely challenging. It happens in every situation of chronic kidney disease and an acute kidney injury, because we do not have the follow-ups as in US, the preceding baseline creatinine. So it's difficult for us, but for our knowledge, in case the patient is a diabetic and you have a pre-existing chronic kidney disease, or you have the patient who is already vulnerable to kidney disease, and you give the contrast and there's a rise in creatinine, plateauing at 72 hours and then coming down by 96, you say that the patient has got contrast-associated nephropathy rather than a contrast-induced nephropathy. So that's a subtle difference, because contrast-associated nephropathy can have a long-term impact. The patient can still go into the chronic kidney disease. A contrast-induced nephropathy, on the other hand, is reversible, the typical graph of, like inverted U or whatever it is called. So that's one. The other thing, just coming back to Dr. Sharat Chandra, you have just commented saying that, obstruction and stones are really, no, that I would like to differ with you, because in the presence of urinary tract infection, there is a contraindication. But then, an obstruction is totally a different algorithm of evaluation. A stone is totally a different algorithm of evaluation, unless they have a superimposed infection. So that is a correction that I just want to suggest. Coming back to Dr. Vijay Govind, what is the best combination that you suggest in diabetics? That's my final question.
So best combination of OHA, madam, you will give me 2 drugs or 3 drugs? See, in ACS, in the ICU, it's always insulin, number one. We try to keep sugars around 200, we are okay, we don't bother much. When the patient goes out, the first drug is SGLT2 inhibitors because we don't have to bother much about metformin and kidney issues, so SGLT2 is the first preferred drug, if it is one. If you have to use a combination, we tend to put whatever I spoke here would be the ideal situation, but we don't work in ideal scenarios. So it would probably be SGLT2 inhibitors with metformin by the time of discharge. That would be the first two which I would pick up, and I think the guidelines also more or less agrees with that. I don't have any experience as a cardiologist using GLP-1 receptor analogs. I know they are great drugs. They are almost equal, if not superior to SGLT2 inhibitors, at least in some stages. But I see because the cardiac patients already have a huge list of drugs, I don't envisage using this drug in the near future till generics come up.
Thank you so much, Doctor. And it's a wonderful debate, and we have been having, and I'm sure people are looking for more for it. But one final question to Dr. Sarath Chandra. See, as a class, SGLT2 inhibitors have generally a favorable benefit to risk profile. And post-mortem surveillance in US, you have seen that these medicines are coming with a box warning of kidney injury. So, looking at this scenario in Indian setting, do you think this will be a deterrent in using and passing on the benefit to the patients?
Definitely, sir. This is a double-edged sword. Like I said, it's not about prescribing. It's about counseling the patient. We have to educate the patient that what hematological effects or what the outcomes can happen if the genital hygiene is not maintained, or like sick day counseling. Patients may be having diarrhea from food poisoning or so many other causes. They'll simply keep on continuing the medication without knowing what is really happening. At this point, this can be detrimental. So I think we should only do a better counseling, and SGLT2 as such, the benefits outweigh any of these things. So we have to do the counseling and we should continue the prescribing, sir.
Thank you so much. It was a wonderful presentation, and we had a wonderful debate, and I'm sure a lot of takeaway points from these presentations. I thank all the doctors who are here, and now for the felicitation part of it, I would request Dr.
So on behalf of the panelists, I would like to thank Dr. Faraz and the Awareness Society, Frontiers Awareness Society, for giving us the opportunity to be a part of this panel.
Thank you so much. Indeed, it was an informative and a wonderful session. Now it's the time for the felicitation. I request Dr. N. Muhammad Ataullah, sir, to please come on the dais and felicitate our speakers. Dr. N. Muhammad Ataullah. I request the speakers, Dr. L. Srinivasa Murthy, sir. Dr. V. Sharath Chandra, sir. Dr. V. S. Ramachandra, sir. Okay. Dr. Biju Govind, sir. Now it's the time to felicitate our panel members. I request Dr. Vasant Kumar, sir, to please come on the dais and felicitate our panel members. Dr. Vasant Kumar, sir. I request Dr. S.J. Muzam, sir, to please be on the dais. Dr. Swaraj, sir. Dr. Naval Chandra, sir. And Dr. Manjusha, Senior Consultant Nephrologist, HOD at Gandhi Medical College. I request all the speakers and panel members to take a photo, please. Kindly take it. Sir, please.
Okay, ready to clear? Smile, smile.
Thank you. Thank you so much, sir.
Many are counting calories, few are counting hormones. As you all know, our body is a walking cocktail of hormones. Over 50 hormones control our body. So good nutrition is must to keep our hormones happy. I invite Dr. Archana Jain ma'am over the dais. Dr. Archana Jain is a consultant gynecologist and obstetrician, infertility specialist in Good Life Medicare Center, Ayush Medical Center in Lakshmi Nagar, East Delhi. She has vast experience in dealing with breastfeeding, hysterectomy, hysteroscopy, IVF treatment, women disease, vaginal discharge, menopausal problems, etc. She is the member of Association of Obstetrician and Gynecologist of Delhi and Indian Society of Assisted Reproduction and Indian Society of Gynecology Endoscopist. She has an experienced IVF specialist who has 10 years of immense experience working as a fertility specialist and IVF specialist. Over to you.
A very good evening to all of you. First of all, I would like to thank the entire FDRS team, Dr. Faraz and Dr. Shahista, for inviting me to this wonderful city of Hyderabad. So now we are going to talk about all hormones and nutrition. So I would like to invite all our panel members on the dais. I would like to invite Dr. B.V. Shobha. She is the President OBGY Society, Hyderabad. Our next panel member is Dr. Prabhavati. She is the President, Menopause Society. Our next panel member is Dr. Jyoti. She is the Associate Professor, Department of Biochemistry, AIIMS, Hyderabad. Dr. Seema. She is Head of Emergency Care Hospital. I would like to invite Dr. Pratima Raj. She is the Professor of Medicine and she is the Medical Superintendent at Nizamabad Medical College. So our first topic for today is impact of endocrine disrupting chemicals in gynecology. And this would be taken by Dr. Manjula Annagani. I would like to invite our first speaker for the day, Dr. Manjula Annagani. Dr. Manjula needs no introduction. She is the Padma Shri Awardee 2015.
Over to you, ma'am. Thank you, Dr. Archana. Finally, right? So when we talk about hormones, I thought I am seeing one menopausal president and one OGSH president sitting there and microbiologist. And when we get hot flashes, we remember hormones. It's boon and a bane. And when a daughter looks up to me like this, and when I ask some question, and I know hormones. So that's where we are in. The most important part, where we cannot live with, where we can live with. Both the things which are very important. Can we have the EDCs, please? The whole topic, when Dr. Faraz asked me what is the topic I would like to talk about, is EDCs. I said in mail, it's not here. You guys never took it out of your mail. Dr. Manjula Annagani, I mailed it. I sent it around 2:30 today afternoon. Yeah. So when we talk, from last 10 years, we've been making noise about these EDCs. In the routine practice, we do see lots of girls coming to us. One, there's increased incidence of, all the physicians agree that there is the increased incidence of thyroid disorders. Yes. There is increased incidence of PCOS. There is increased incidence of endometriosis. Increased incidence of fibroids. Cancers. Yes. So why do we think it is on? And everybody, including the politicians, come onto the stage. Yes, the first slide, please. Okay. Can I not change here? Yeah. So all all the politicians, all the people who make a difference, who think they can make a difference, come on to the stage and talk about plastics, plastics, plastics. Yes? Do you think only those are the things which can cause this thing? And when I talk about plastics, the most important thing for a woman, 50% of the population is something. Can I have one mic like this? Because I'm a very restless person. I cannot stand in one place and talk. So let me just move around, because that at least makes me walk a little bit and have some exercise for my body, which is the most laziest thing on earth. This one, right? Right. So when I keep talking about please use menstrual cups, please use organic sanitary napkins, the main reason I keep talking about is the plastic which is closest to the genital organ is a sanitary napkin. And that plastic is the main reason why there is increased incidence of endometriosis, fibroids, and endometrial cancers. Then we have the rest of the plastics, rest of the whatever we are eating, which causes it. So I took up this topic because I thought this is one thing, one way of me talking to the youngsters, the next generation, about the importance of things which we talk, why the diseases are increasing. Everywhere we talk about preventive gynecology, but when it comes to it, are we actually doing the need of the thing, what is necessary? So we do know that infertility is increasing. Dr. Shweta, that's how we are all surviving. Every lane in Hyderabad has 2 IVF centers because infertility is increasing. Then we have cancers, the oncology. Every corporate hospital now has a separate cancer center which is flourishing. And then we have the industrialization which has made us where we are. And that is because they are mimicking the reproductive organs where we talk. So I would like to take you all through this journey with what are EDCs, why are we even talking about it? Because in our MBBS nobody told about it, and nobody told it is important for us to know about EDCs, and why do they matter, and how do they matter, and gynecology, because I'm a gynecologist, I'm supposed to talk only about gynecology. So impact on fertility, fecundity, pregnancy, PCOS, menstrual irregularities, endometriosis, fibroids, cancer. That means I'm completely covering the whole gynecology. Means whatever we did in our shop is originating from this, and we are getting number of patients which are increasing in number because of this. So we should be thankful to them, right? But unfortunately, we are a part of the ecosystem where we are also going to get affected, and the next, my daughter is going to be affected. So let me just speak out about it. So what are the solutions, recommendations, what I could think of? So EDC is nothing but whatever chemical which is going to affect the body's endocrine system. Means we're not just talking about the HPO axis, we're talking about thyroid, thymus, pancreas, every other thing which happens. So these exogenous agents, they're just not interfering with the synthesis, they're affecting the secretion, transport, metabolism, binding action, elimination. Means the whole of the biochemistry which we talk about, everything is going to change. So finally what is happening? First thing, they're everywhere. There's a thing in Telugu called Indu Galadu Andu Ledan Endendu Vedikina Andande Galadu. Yes? That is what it is. Whenever you search, it's there. I said, it's not just the God who is there everywhere. EDCs are everywhere. So that's where we are talking about. Very low doses also can cause harm because they're going to be absorbed. They're going to stay either in the breast, in the milk, in everywhere in the body. They're there for a long time. They're here to stay. Next, potential delayed effects because they're absorbed and they're going to be transmitted to the next generation. It is a 3 generations which are going to be affected, not just us. It's going to be the next and the next. And irreversible health damage. There's nothing like irreversibility. So prevention is the best thing and better than cure. And largely overlooked because everybody thinks about how to treat. Nobody's talking about how to prevent. Nobody's talking about how to avoid because that's the life we are all leading now. And everything is about business. When I saw a 7-month-old kid having a breast, I had a shock of my life around 7 years ago. And that is just because the mother could not give her milk and she was giving a milk from the buffalo which was given a lot of oxytocins and everything. So we are looking at precocious puberty not at 13 years, 9 years, 8 years. They're looking at months babies having a either a bleeding PV or even a breast development. Because everybody looks at business. Everybody thinks that how I can make more money. Because money has become a norm nowadays, which is where we are all going to do it. So that's where chemical industry sales of all the plastics production has increased and even the sales have increased. In spite of so many countries saying that we are banning that, we are banning this much thick thing we are going to ban. But the reality is the sales have increased everywhere. And it is going to affect the immune system, it's going to affect the thyroid, bone disorders, neurodevelopment disorders in the children. How many of you agree that autism spectrum disease has increased in the last 10 years, decade?
Everything normal, antenatal checkups normal, all multivitamins taken, normal delivery, nowhere the hypoxia has come. Still the autism spectrum disease have raised and has increased. Again, it is because of this, because it is transmitted from the mother to from the womb into the child. So metabolic disorders, hormone-related cancers, and reproductive health. This is where we are. Like I said, it's not related to only gynecology. We are looking at other disorders which are increased, and that's where we are fighting to survive. So how do they affect? They either increase or decrease the normal hormone, or they may mimic that what the normal hormone does, or they may alter the natural body production. So when patient asks me, I tell them, please understand the terminology replacement. Your body is supposed to produce, it's not producing, that's why we are replacing. So same thing the EDC are doing, but only thing is we are not having deficiency, but still it is acting as if it is necessary. So it is like salt in a curry. You have deficiency in the curry, we put salt from outside and eat. But EDCs everywhere are adding more salt, leading to, you know what it can happen. Can lead to CCF, we just heard about it. We can lead to nephrotic and the complete nephropathies, which it can lead to. So what are the common endocrine systems, these things are disruptors? What? Seriously, we are going to ask about it because it's there everywhere, like I said. So we have bisphenols. Where is it? It is there in all the single-use, multiple-use drinking water bottle which is there. What does it do? It increases the estrogenic action. Ultimately, you see what's happening with it. Next, we have benzophenol. It is in sunscreens which we are using. We are supposed to use sunscreen. Nobody wants to become dark. Nobody wants to be affected. And it's also in these containers which we are using the food. And again, weak estrogenic action. So again, estrogen, it's exogenous estrogen which is coming now. Next, we have a bisphthalate. It's there in all the kitchen ware and the cosmetics. We are talking about grooming nowadays because we all want to look good again. That's our Janma Hakku. We all want to look good. So affects the reproduction and fertility. And dioxin, the worst of all is dioxins because we know that is carcinogenic. Dioxins, in the sanitary napkins, what comes out is dioxins. So you have everywhere, sanitary napkins, tampons, everything where it is bleached to increase the absorbing capacity. B is the thing which is there, which is closest to the female genital organ, and it leads to increased endometrial cancers and the PCOS and the endometriosis. So you have DHA, which is again seen in all the food which we are eating, everywhere which we have, and it is again estrogenic. Then you have DBP, it's again organic compound, which is a plasticizer. Whatever said and done, the toys you're giving your kid is plastic. And this is used for every plastic to make it as a plasticizer, and that's what is causing, again, estrogen effect. Now, PFOA is there in drinking water, regular drinking water, then the water goes to something called sterilizing plant or whatever plant where they're supposed to purify it. But what we need to understand is PFOA is resistant to any degradation process. So it's there, it's there. We are drinking, it is going to be accumulated inside our body. So you have propyl gallate. This is an antioxidant. It's a good thing. Good. We take so many antioxidants. Then why are we antioxidants and use it all these chips and everywhere so that it protects it from getting rancid. That is what it is. But it also has estrogen effect. So finally, whatever we are doing, we have all the estrogen effect. But one more thing which happened iatrogenically or by using something for the patient by herself. We do have to understand that. Okay, little thing is that way back in 94 to 97 when I was doing my PG, pager just entered for a short time and went off. But the minute cell phone came, even the beggar has a cell phone. So we are one country where we use everything extremes, no moderation anywhere. So that's where we live in. So when it comes to this, again, thiram is something which is there, is a fungicide and everything, it is thyroid. How do they act all these things? Because whatever is there, we have water bottles, we all want mineral water bottles. We want this, we use this, everything in extremes. And how do they act? Whichever system you talk, everything has different level of action, but finally it is a hormone metabolism, receptors, transporters which are going to be affected by this. So whether you want or no, we know everything, HPO axis, everything comes from pituitary, and this neuroendocrine function is targeted by even chemicals. There was a newspaper item which came where they said the plants, the edible plants which are there on the border of the Musi river is all full of lead. How many of you read about it? About 5-6 years it was there. That means you do not know. You are getting the thing. You think it is coming very fresh because you're going to Raitu Bazaar and buying it. But where is it coming from? It's full of lead. What is it doing? HPO axis is affected by lead. And FSH, LH and ovarian steroid genesis is inhibited by cadmium. When I say that, so everything in the natural, agricultural, industrial, domestic, miscellaneous, name it, everything is going to the plants and we are eating it. Or it is the plants are eaten by animal and again we are eating the animal. Finally, it's goat eats plant and again we are eating the goat. Whatever it is the complete cycle which is happening and it is activating the estrogen receptors. So, is it only the estrogen? No. We do know, gynecologists do know that for progesterone action also we need estrogen priming. So, it is not only affecting the estrogen, it is estrogen and indirectly the whole aberrant progesterone action. It's not the direct good action of it, which is the opposite action. So, estrogen is more aberrantly affecting the progesterone, so it is not stopping the estrogen from working badly. And you have an aryl hydroxylase which is not working properly. So, finally, what you're having is more and more of estrogen. And like I said, I just made one comment before and I said I stopped and waited. That is, whatever we do in extremes. There was a thing about soya estrogen. How many of you remember that? Everybody, phytoestrogens, anything plant-based is not having any complications. How can it be? Anything you take in soya estrogen is also estrogen. It leads to increased estrogen, and that is one of the diseases which has made life of a woman miserable and more cancers because they eat lot of soya estrogens. So all these things, imported jewelries, imported toys, imported, and the way they use everything to put it into it, this is the industrial pollutant, and this causes all these things. So finally, sources can be personal care, drinking water, canned food, produced conventionally, kitchen products, cleaning products. Then what is there for us to live? Means we have to go back to the back ages where we are going to be in a forest, we are making our own wood and caveman. And that is what it looks like. But these are all man-made things. So we cannot avoid everything because unfortunately, fortunately, Corona has actually helped us in people buying somewhere outside and doing it. But we cannot be a norm. We are social animals. We are supposed to live among the people and we are going to do that. So half the time I just ate talking about EDCs. Let me see one slide each of what's happening in the gynecological system in here. So start from here, irregular menstrual cycle. It can lead to infertility, endometriosis, PCOS, breast cancer, and early menopause. In 18 years, 19 years, they are getting menopause. You cannot believe, my youngest patient attaining, it's not primary menopause. They get the cycles at 11 years, they're having regular cycle, then they have a premature ovarian failure at 18 years. That is my youngest patient who underwent menopause because of EDCs. But that is how it's going to be. One side we're talking about biological clock ticking, and one side we're talking about take care of your career, get married when you want, and then have children. Then what are we talking about? Something has to be done about it. We need a healthy woman, wealthy cycle. So we are talking about fertility, infertility, like I said, what all the things which can cause this problem. So impacts depend on the development time frame at which they are exposed. Is it at the neonate or as a puberty age group or later? And the routes of exposure, is it the oral or is it the injection, and the dose and the half-life? It's like just like any other drug. So when we say all this, finally affected in the center, I think the marker is not working, but understand by my hand language. It's showing the human. You have plants, vegetables, cattle, everything, and do not forget that from plants you have the processed food, soya milk, soya products. That huge intake of soya, which people have started doing it, has led to this thing, and dermal exposure, embryonic exposure, inhalational, oral, and everything. Whatever it is, we are surrounded by it. We have to accept, but we have to see what can it cause. Like I said, it is just not the hormone synthesis. It is exogenous estrogen, aberrant action of progesterone, and absent this thing. So the ER, PR, AHR are affected, and prenatal exposure can lead to affect sexual differentiation. So one side we are talking about men have become more feminine, women have become more masculine. We just don't mean only the red hair which comes out, but even in the thought processes, in the way the pelvises have changed, everything, it is a truth. It's because of the change in the hormonal status what is happening. So and it can affect the postnatal gonadal development and puberty itself, leading to 8-year-old getting a thing. I have never used so much of Lupride Depot 10 years ago as I'm using in the last 5 years to push the precocious puberty. 8-year-old kid with the onset of precocious puberty, and I have to give it for at least 2 to 3 years, the Lupride depot or generic analog, is just because of amount of precocious puberties I am saying, because we are low function there. So post-pubertal reproductive function and is also affected. This will work? This will work? Next slide, please. So it's a temporal modification of the age. It has become 7-8 years. Reproductive function, fertilization, conception, embryogenesis and pregnancy itself, and lactogenesis, and potential for masculinization of females and androgynization of the males also. So at puberty, if they're exposed, now you see this is something which I see. Even a 4-year-old kid want to put lipstick and want to look good. But that's something we cannot change it. But that's what we have to be careful about. So at puberty, there's a reduction of median age. There's a hypothyroid, like I said, external estrogen causes thelarchy, then pubarchy, then menarche. That is the way it has. Years of when we learned gynecology, we were told 1 year gap between each. You get the thelarchy, then you have 1 more year to have pubarchy, then 1 more year to have menarche. Now we are not seeing anything. Everything is camouflage on one paper. So peripheral precocious puberty, it is because of estrogen. But we are also seeing the central precocious puberty, the reason not known. It could be the HPO axis itself. Then PCOS, and when we talk about pre-diabetic status and HOMA-IR, we know the amount of PCOS we see. Even though they say South Asian people have the incidence is only 15 to 18, I personally see 1 in 3 patients having PCOS in my clinic. So that's the way it is. So it's wherever they're, depending on when they're exposed, they can have a prenatal period, child adolescence or adulthood, they have the insulin resistance or adrenarche. And look at the central place where we are talking about childhood, adolescence, at the level of adrenarche. We as parents put a lot of stress on the kid for, they have to become doctors, they have to become engineers, they have to become everything, including Modi. So that much of pressure we are putting, and we are putting them in the Chaitanya, Narayana colleges, leading to adrenarche, cytochrome P450, aberrant action, leading to more and more PCOS, which is happening. So half the culprit is parents and half them is that. So we know it dramatically disrupts ovarian function and obesogenic, and definitely all these are higher. These are all the studies which have said that it's not just this generation, but 3 generations are affected if we are exposed to EDCs. So this is what we talk about in, way back in 2007, we told that there is increase in fertility. When I was doing house agency, for us, what is a normal semen count was 80 million and above. By the time I came to PG, 40 million and above. Then by the time I started practicing, ठीक है, इतना तो count बहुत मुश्किल हो गया. So 25 million and above. Now in the last 5 years, 15 million and above sperms also is normal. So we should not call them as low sperm, because we cannot change what is happening around. Then the sperm count drastically came down that much. So that's again because of the EDCs which we are happening. So the sperm count, like I said, in the way it came down in the last 50 years, again, because of EDC. I hope at least men get up and make some noise now, at least. Till now only we are talking about it. Till men get up and say, "Hamara sperm count kyun kam nahi hua?" We don't want to have another, what is that guy, hero's name? Vicky, Ayushmann Khurrana. So please, if you want to have your own child, talk about EDC and don't get exposed to EDCs. So this is the evidence which is there, which says how the motility, concentration, volume, DNA integrity, embryo quality, everything came down. And how even in the woman, the oocyte number, fertilization, blastocyst formation, and even the quality is coming down because of EDCs. So it's not me talking. It's the evidence which is talking. This is again the same, how the placenta it is going to be affected and how the next progeny is going to be affected. It is not just in the placenta through the baby, it is also in the breast to the baby. So menstrual, I think I'll just, again here, one point I want to tell is again, the isoflavones from soy protein increases the follicular phase. So please don't keep telling the patients, eat lot of soya, it is good for you, estrogen is good for you. No, it is detrimental. Flaxseed will also cause this thing. So, like, where are the things we keep using? So, how it affects this is the thing. Endometriosis, the major culprit is the sanitary napkins with plastics in it. And this is very clearly told way back by even the North Indian Shepherd. And It has been detected in the rodents where they put the ADCs and saw that the implants which are put have started growing more. So it's the estrogen might not be causing it. Metaplastic theory is definitely the main thing. But once it forms, it doubles and triples because of the EDCs which is happening there. So this is the breast and endometrial cancers. The same theory holds good, but the most common culprit is the dioxins, which is leading to endometrial cancer and the breast cancer, which has increased in the recent times. So fibroid, the number of cells. We always know that estrogen is for hyperplasia, progesterone is for hypertrophy. So you have more and more estrogen, hyperplasia is going to happen. So that's where the cancers come. Or it can be benign like fibroid. Last 2 slides, bear with me. So my recommendation, what I thought when I was thinking out of the box is that if we can avoid plastic containers, please avoid them. Avoid canned food. I hate canned food, so I am fine with that thing. But there are certain times and all when we cannot avoid it because of preservatives or whatever. Consume the fresh and organic food, but then they say it is fresh and sell it for 3 times more charge. But how sure are we that it is fresh, and how sure are we it is not having lead in it? That only God only knows. So then avoid fast and processed foods and supplement diet with antioxidants, like I said, vitamin C, arginine and protein. And finally, organic sanitary napkins and menstrual cups. If we can at least prevent ourselves from having endometrial cancers, the only way to prevent is menstrual cups and organic sanitary napkins, which are made out of bamboo shoot or anything which comes, or reusable sanitary napkins which we have. So personal strategies, I think we ourselves at least first we should start, because our children actually live by example. They will see us and do what we do. So telling is not the solution. Like I said, hormones, they will look at it and say, look who is talking. That's the way the next generation is going to tell us. So please use personal water bottles, avoid heating already used food, limit the use of makeups, colognes and fragrances if possible, and open the windows daily whenever possible. So this is the last slide. What is the recommendation which has to be given by the government, by any society, is that proper identification, strict approach to risk management, precautionary principle, empower the consumers by saying what all it has, and safe workplaces if we can do, and healthcare professionals, we are the ones who are going to help them, and industry, agriculture, we cannot change it, and thorough research about what all we can do. And I truly believe that there is a single light of science, and to shine it anywhere is to shine it every day. Thank you all for having me.
Thank you, Dr. Manjula. That is an informative talk. The dirty dozens are those EDCs, and of course we cannot avoid completely, but somehow, as you said, we have to learn the natural way of living, that is going back to the old ancient ways. They did not have all these malignancies or all the PCOS and all the problems what you have enumerated. Thank you so much for your talk. I take pleasure in inviting the next speaker, Dr. Shweta Agarwal. She's an IVF specialist at Southern Gem Hospital, and she is been awarded APJ Abdul Kalam's Super Women Award. So this is apt as our Women's Day is nearing, and she runs an NGO too, and she has helped lots of infertile couples, and she's going to speak on the PCOS, the newer concepts in the management. Over to you, Dr. Shweta.
Thank you. Thank you, ma'am. And thank you, Dr. Sanas Farishta and Dr. Shesta, entire team of Fronters in Diabetics for inviting me for a talk here on newer concepts in PCO management. So PCO, as we know, it's as Madam Dr. Manjula Madam also highlighted with the EDCs, it's increasing, and PCOS every 5 to 10% of the women of the reproductive age group we see have PCOD. So we've been treating PCOD women since very long, and today I will just restrict my talk just talking about what are the newer concepts. So it's a very common disorder which is going to affect the ovulation. It's going to cause, we as infertility specialists, 1/3 of our patients are having PCO, what we see, and mostly affecting the childbearing age group. About 40 to 80% of the patients what we see are having obesity, and it's also associated with metabolic syndrome with insulin resistance in 30 to 40% of the patients. So we've been using a lot of metformin. We all know metformin is the drug which all very much we have been hearing a lot about the drugs for insulin sensitization. Metformin, it's used a lot in diabetics. We as fertility specialists, whenever we see our patients with PCO, we are using quite a bit. But now, more recently, myoinositol has been added in our PCO patients. So there's abundance of myoinositol isomer in our body. So particularly myoinositol is there in every cell of the body, and it has got a good role, a major role to play even in the ovary. The MI and DCI, the myoinositol and the D-chiro-inositol, they have specific duties to perform within the ovary. And what myoinositol does is it causes the FSH signaling. And DCI is responsible for the insulin-mediated testosterone synthesis, and MI is converted into DCI with the epimerase activity, which is helping in the conversion. So the balance of these MI and DCI is very important within the ovary for the normal ovarian function and normal, for the ovulation process. But this is what is disturbed in patients with PCO. The MI-DCI balance is disturbed because because the epimerase activity is insulin dependent, and in PCO, because of the systemic insulin resistance, because of the hyperinsulinemia and accentuated epimerase activity, more of the MI is converted into DCI. So there is the high DCI levels, which is causing hyperandrogenism. It reduces the efficiency of MI-mediated FSH signaling, which is essential for our follicular development and ovulation. So normally in every cell of the body, what we need is the MI-DCI ratio is different in all the different cells of the body. So what on an average in most of the body tissue, the ratio what we need is 40:1 in most of the tissues. But whereas in the ovary, within the follicular fluid, when the studies have been done, it has shown that for normal ovarian function, for the normal follicular development and ovulation, we need an MI-DCI ratio of 100:1. But what is happening in the patients with PCO is because of the high epimerase activity, higher conversion of MI to DCI, we are getting a ratio of 0.2:1. MI-DCI ratio is very much disturbed, and this is a newer concept that is probably leading to ovulation disorders, ovulation dysfunction in the PCO patients. So when the concentration of MI is reduced, and as we know, we need MI for the FSH signaling, for the follicular development, we need FSH. So because of this, in patients with PCOS, what we're seeing is increased insulin resistance and increase in the LH levels. So if the DCI concentration is above the limit what we need in the follicular fluid, it's not even when we do the IVF in all those patients, the fertilization rates are poor, the implantation rates are poor, the blastocyst formation rates are also poor. So what we need is an adequate supplementation of MI and DCI, and the supplementation, when we talk about supplementing the MI-DCI, the commercial products what we are available, we need to look at what is there in the market. So when we have a lot of representatives coming to us, a lot of companies making different MI and DCI combination. When we want to choose the combination, we need to look at the MI-DCI ratio of 40:1. So most of the products which are available have 550 milligrams of MI with the DCI of 13.8. So that is the most of the products which are available. So this is the ratio which is more suitable for PCOS, and in this particular ratio, it's going to help in maintaining your menstrual cycle, your ovulation. This increases the progesterone and SHBG levels, and it decreases the LH levels, maintains the testosterone levels, helps in correcting the insulin resistance. So combining the MI and DCI, it has a potential to improve all the signs and symptoms of PCO. It also helps in correction of the lab parameters. So both of them prescribed together is in the right concentration, is going to correct the ovarian inositol paradox. So this is also going to treat not only the fertility point, but also the metabolic parameters are corrected. It's going to have a healthy intra-ovarian milieu and improves the menstrual regularity. So this epimerase activity, which is unidirectional, and DCI administration alone will not be able to. Sometimes they say that only DCI is enough, or only sometimes they talk about only myoinositol is enough. But no, we need both MI and DCI. So it's important to provide the right ratio and in the right combination to improve the ovarian physiology. So that can be used as a monotherapy, or you can combine it even with metformin, because metformin has a different mode of action. So both metformin and MI-DCI combination both can be prescribed for the PCOS patient. So, and then talking about the safety during pregnancy, see, it's more of a natural product. Even the international guidelines on PCOS, which was given in 2018, they have talked about that myoinositol is safe. It can be continued even during pregnancy. So even if it's excreted in the breast milk, it is going to be safe even in the lactation. So the GI symptoms what we see with metformin are not there with the myoinositol. So the, people who are not very good tolerant to metformin, as we know, with, there are GI side effects with metformin. So those patients who are having side effects with that, we can just put them on MI-DCI combinations. And again, even during our IVF cycles, we try to put the patient for 2 to 3 months prior to the IVF on the MI-DCI combination that's going to improve the insulin, the sensitivity of the ovaries to the gonadotrophin stimulation, and is going to reduce the dose of the FSH which is required in our stimulation cycle, improve the egg quality, improve the fertilization rate, implantation rate, and the blastocyst rates. So just talking about some evidences. So this is a good study which demonstrated that combination, the concentration of MI, when they looked into the follicular fluid and compared it with the oocyte and the embryo quality in 53 women who had a normal response, they found that 38 of them had a mature oocyte in the fertilized group, and 22% had only a immature oocyte in the non-fertilized group. So the follicular volume, the MI concentration was significantly higher in group A, which had the myoinositol and DCI combination. And these are a number of papers, and it's a very busy slide, but what I'm trying to show is we've got a lot of evidence now to say that MI-DCI combination is very useful in the PCO patient. Lots of studies are there, Cochrane review, and a number of very good strong evidences what we have, the ESHRE and the various fertility societies have now concluded that it's like myoinositol MI-DCI combination, it's a proven drug which we can use in the PCO patients. And then again, when we talk about IVF patients with PCO, it's very important we talk about ovarian hyperstimulation syndrome. Whenever we are stimulating our patients with PCO, we are worried about the hyperstimulation. It's because of probiotics and the prebiotics. Prebiotics, they are actually the food for the good bacteria in the gut. So prebiotics are resistant to the digestive system's enzymes and they are not absorbed in the small intestine. So this allows their way to make it to the colon, and that's where they stimulate the growth and activity of the beneficial gut bacteria. So food which are rich in prebiotics are the garlic, the onion, the artichokes, the asparagus, the apples and the bananas. So we try to encourage taking food rich in the prebiotics. Then some antioxidants and anti-inflammatory foods, because PCO is a chronic inflammatory condition. Again, eating healthy foods, eating foods which help to reduce the inflammation is helpful. So antioxidant rich fruits like turmeric, berries, green tea. We encourage a lot of green tea nowadays. So all of these are going to help in improving the gut microbiota. We have to be mindful about the sugars what we are taking. So low sugar intake is also going to promote the lower the inflammatory system in the gut and contribute, reduce the gut dysbiosis. Stress, everybody is stressed. All of us are just running around. So we ignore the stress factor which can have an impact on the health, general health, plus the fertility health. So prolonged stress is going to have an impact on the digestive system, and that is the stress is going to alter the gut microbiota, and it's going to make the gut more leaky, and it has an impact on the sensitivity and motility of the gut. So stress has a mental, emotional, physical, as well as it's very important to be aware of that. So bringing in things like exercise releases endorphins. It's going to have a positive impact on our stress. Meditation, reading, trying to do self-care, taking care of. It's very important to take 1 to 2 hours out in our everyday schedule for self-care and taking care about ourselves. So these are the two things what I wanted to highlight with the PCO. What we are talking more recently is about the myo-inositol, which is an alternative to metformin, or not exactly, we cannot say metformin is out. We can give a combination of metformin and myo-inositol, and also we need to think about gut dysbiosis and its relationship with the PCO. So inositol, just to summarize my talk, so secondary messengers for insulin and its deficiencies contributing to PCO. Correction of the MI and DCI with the right combination of the drug is important, and a lot of ongoing research is building up our confidence in using this molecule. So we normally start 2 to 3 months prior to our fertility treatment. That's the time frame which helps in correcting the insulin resistance and gives a good response to ovarian stimulation and the success of our fertility treatment. And then again, gut dysbiosis, as we talked, is a newer concept. With fertility and PCOS, we need to focus on that and think of treating these conditions as well. So with this, we come to the end of my session.
So congratulations to Dr. Sweta about talking about the promising agent which is ready now, myo-inositol. And also the gut biosis, which is very, very important, newly touched it. But the PCOS and all that, we have to start. Manjula has given us a base. Yeah. These endocrine disruptive chemicals, they are acting from the age of adolescent. That is the problem.
In utero.
Yeah. From there, the girls are not going for any exercise and eating fast foods. And everything, they are becoming obese. More and more of irregularities of the menstrual irregularities.
Like what we talk about, the genetic etiology of PCO is like intrauterine exposure of the in utero fetus.
Yeah, epigenetic theory.
Yeah, epigenetic theory where they are exposed.
And sedentary lifestyle, food habits, these are making, we are living in a polluted world. Exactly. Our air and water, everything, food and everything is polluted. So that is the reason why they are becoming more and more irregularities and obese, and then more infertile, taking more hormones, and as Manjula said, early premature ovarian insufficiencies, premature menopause, and these more and more GDMs these people are getting. So out of GDM, girls, it is a vicious cycle. They will be having more of PCOS. So there is another study was given on this endocrine disruptive chemicals, studied in ART cycles. 239 women were studied, and 17% had a success rate where the ECS was more. Whereas who consume the less these chemicals from the daily food they limited, those had 54% of fertility rates. Even in the ART cycles also, this is making a lot of. So I could congratulate these frontiers of diabetes who has taken this mantle of giving awareness for the preventive and these aspects to come into the light. But this has to go into the public, and more people should have this awareness. Then only this menace can be, and that too the plastic menace. We know every day we are only consuming. Every day we thought of preventing this, but somehow or other we are into the daily routine, and we are exposed to more and more of chemicals and industrial pollution wherever we are residing. So, thanks for the nice talk.
Thank you.
Thank you, Dr. Shweta, for the enlightening talk. Now, I would like to invite Dr. N. Mohammad Ataullah. He is the Senior Consultant Physician and Diabetologist, ex-Associate Professor of Osmania Medical College, Consultant Physician and Diabetologist, Care Hospital, Hyderabad. He is going to talk about role of nutrition. Over to you, sir.
Thank you, Chairpersons, for that kind introduction. We will shift gears and come back to diabetes and obesity. We all know that, as has already been told, that we are what we eat, and something has been already alluded to: obesity, HOMA-IR, dysbiosis, all those things. And all those things matter for us also, as far as the practice of diabetes and obesity is concerned. So, my talk will be focusing on the reduction of weight and remission of diabetes. So the holy grail, whenever a patient comes to us in the clinic or office, he asks us, is there a cure? Is there anything which can be done? I'm off my tablets. So they ask all these questions, but then when you ask them to reduce the weight, then they are not eager or willing to reduce weight, as one of the speakers was telling in his previous talk. So they are not concerned about the weight, but they are concerned about the remission of the disease. So weight loss and diabetes remission is a holy grail, and how we can do that I'll be telling in 15 to 20 minutes of time. The most important aspect of people in India with diabetes is that generally also the intake of carbohydrate is quite high in our setup. So if you look at west, east, north, south, central part of India, the amount of carbohydrates which we consume is quite high, 60%, 70%. So that is the basic culprit which is the driving force for development of diabetes, and that's also the reason why we have high postprandial blood sugars, which are responsible for the microvascular as well as the macrovascular complications. These are my disclaimers. Now I will be going through the obesity trends in India, Southeast Asian phenotype. We have a specific phenotype here, and also obesity and diabetes association. A special term has been coined for this. This is called diabesity. So whenever a patient comes to us in our clinic or office, he has a high BMI, you feel that he is little obese, the first thing we ask the patient is, are you a diabetic? So 80% of the time, 70% of the times he will say that he is a diabetic. Even if he is not a diabetic, over a period of time, this patient who is obese, who has a high body mass index, is likely to develop diabetes. And also, what are the clinical evidences to show that cutting short of carbohydrates and reducing the weight will have some effect on remission of diabetes. Now, we also will go through the diabetes remission part, and what are the terminology, what is the definition of remission, and what is the classification, and how weight reduction is going to help in remission, and also dietary interventions which can be done with the help of low calorie diets, low carbohydrate diets, all those things. But we are all familiar, and most of the patients come to us and ask us about the keto diets, where absolutely there is no carbohydrate, and these diets have been shown to be detrimental. They may be useful in a short span of time, maybe for a period of 4 months or 6 months, but the amount of oil, the amount of fats which are taken by these patients are detrimental. In fact, there have been some studies which show that the mortality is increased in those patients who consume these keto diets. Lastly, I'll take you through the summary. So if you look at the diabetes trend, we all, whenever any lecture is incomplete without the numbers, and then if you look at India, about 10% of the people, just as the statistics say in US, about 1 in 10 person is diabetic here. 1 in 10% is pre-diabetic here, and 2 in 1 diabetic patients do not know that they have diabetes. So the number of patients with diabetes in India is quite huge. Right now we have about 79 million people with diabetes. This figure is going to reach to about 130 million people or 125 million people in the year 2035, and this is going to reach to 125 million people. So we are going to see a large number of people with diabetes in the days to come. Not only the diabetes, but there is a new entity which we have seen in the past decade, that is type 2 diabetes in young people. So we see just as PCOD and other gynecological problems are occurring at younger and younger age, we see patients at the age of 16 years, 17 years, 18 years who have type 2 diabetes. Previously, we used to think that these are type 1 cases, but later on we quickly realized that these people have type 2 diabetes. So that's also a huge problem in India. So prevalence of diabetes is increasing both urban as well as in rural areas. Now, the obesity trends in India, if you look at the US data, about 42% of the US people are diabetic. And if you look at non-Hispanic Americans, almost 50% of the blacks are obese. But if you look at the Indian data, both men and women have high percentages of obesity in India, about 18% for men. That is the ratio of the 2015 as well as 2019 statistics, which show that almost 20% of the people in India, both men and women, and this trend is increasing over a period of time, which means to say that you will be seeing more and more people with type 2 diabetes and other metabolic issues like PCODs, which have been discussed just now. Now, what are the risk factors for diabetes? You have modifiable and non-modifiable. We can't do anything about our parents. We can't do anything about genes. So the non-modifiable risk factors are genetic predisposition, family history of diabetes, race and ethnicity. We are Southeast Asians, we are Indians. Even if you go to moon, you will be a Southeast Asian only or Indian only. So in age about 45 years. So, but the recent guidelines from the Research Society for the Study of Diabetes in India has told that anybody above the age of 26 should be screened for diabetes. All people above the age of 26 every yearly, and if they have symptoms like polyuria, polyphagia, polydipsia, or if they are losing weight, they have to be screened more often. So the age limit at which you have to screen diabetes has come down drastically to 26 years, and for hypertension it's only 18 years. And modifiable risk factors are sedentary lifestyle and lack of exercise, obesity, which I'll be talking to you in some detail, unhealthy diet habits. Way back, some 20-25 years back, when I was reading an NIN textbook on diet and diabetes, the first sentence was, normal Indian diet is good for diabetes. But we have changed our diet so drastically, and we have westernized our diet, that we have become more obese and we are more prone for diabetes. Unhealthy diet and habits, stress and depression, altered intrauterine environments, what we call it as Barker's hypothesis or Barkerology, and environmental pollutants, which have been discussed just now, and inadequate sleep. Now, the Asian Indian phenotype. So the definition of obesity, definition of high waist circumference are different from the Caucasian or Western counterparts. Low birth weight as well as high birth weight, both are more prone for diabetes. Low birth weight and thin fat Indian phenotype. We have Professor Yagnik from Pune. He has a special study called thin fat Indian genotype. So when you compare a body mass index of both Indian and a Western counterpart, if the body mass index is same also, the amount of fat which we have in our bodies is much higher than the Western or Caucasian counterparts. Lower age at onset of diabetes, I told you, type 2 diabetes we are seeing at a younger and younger age. Increased NASH, this is again extremely important. This is going to prove very dangerously, because we are also seeing chronic liver disease, even hepatocellular carcinomas. In fact, it's replacing hepatitis B and hepatitis C. And increased abdominal fat, visceral fat, which is metabolically more dangerous. Increased inflammatory markers like hsCRP, low muscle mass, and low vitamin B12 and vitamin D. And lower threshold for BMI for type 2 diabetes. Even lean patients are becoming type 2 diabetic. So low serum insulin levels and insulin resistance. Rapid decline in beta cells. We have beta cell decline at a younger age, 10 years earlier than our Western counterparts. Low adiponectin, and also gut microbiota, which is entering in all fields, obesity, diabetes, and even gynecological diseases also. So Indians are more prone for obesity and diabetes. Now, the definitions of the obesity in India is anybody who has a body mass index of 23 or above is obese. whereas in the Western, we take it as 25. So this is an Indian diabetes risk score where they have taken into account the waist circumference, which is less than 90 for men and less than 80 for women. So these are the standards which we generally follow in our clinics. So this is a chart where you can look at the age, the scores like the age of the person, as well as the waist circumference, and as well as physical activity, so on and so forth. And you can come to a conclusion that whether this particular person is more prone to develop diabetes or not in the days to come. And Obesity and Diabetes Association, if you look at this chart, here they have looked at only obesity without dyslipidemia, obesity with dyslipidemia. So whenever any person has obesity with dyslipidemia, the chances that he or she is going to become diabetic are extremely high. So when BMI was combined with dyslipidemia, the risk of diabetes was extremely high. Now this is an estimated risk of diabetes due to high BMI. So 20 years and old obese patients, they are more prone to develop diabetes. Now the pathogenesis has changed, and now we are looking at more at the intra-abdominal fat as an important risk factor for developing diabetes. Now previously, which we did not consider intra-abdominal fat as an important risk factor, but this has been incorporated into the recent trials. The twin cycle hypothesis, liver fat and pancreatic fat both play an important role in the development of diabetes because of positive calorie balance or excessive intake of the carbohydrates. Ultimately, what these carbohydrates do is they can get converted to the fat ultimately into the body. So whatever you are consuming a high amount of carbohydrate is going to become fat inside the body. So can weight reduction reverse diabetes? This is the holy grail. This is the million-dollar question. Yes, it can. Now, what are the definitions of remission? So you have so many organizations giving us a definition of obesity remission, but then the ADA definition of 2021 is the most common one which we generally follow. Remission, the term remission should be preferred to reversal or cure. Suppose if you tell that you are curing him of diabetes or even reversing his diabetes, the patient may ask us, no sir, 6 months have passed or 1 year has passed, 2 years have passed, I have become diabetic again. So never use the term reversal or cure. So always use the term remission. So the term remission is to be preferred to reversal, which is defined as return of HbA1c to less than 6.5 or fasting plasma glucose to 126, and this should last for a period of 3 months in the absence of any glucose lowering therapy or anti-diabetic therapy. Partial remission, A1c of less than 6.5, fasting glucose of 100 to 125, this is for 1 year. Complete remission, A1c of less than 5.6, fasting of less than 100, of all medications for a period of 1 year, and prolonged remission, which is A1c of 5.6, fasting of 100, and off medications for a period of 5 years. But generally, remissions occur only for a period of 2 years. Afterwards, generally, you don't see a remission or patient becomes a diabetic once again. Now, this is the positive energy balance and negative energy balance. I won't go into the details because of the paucity of time. Now, what can be done? What are the various methods by which you can reduce the weight, or even without reducing the weight, you can go into a remission? So there are two types of diets. One is low calorie diet. Number two is a low carbohydrate diet. So low calorie diets are again divided into two. One is a low calorie diet which consists of 1000 to 1500 kilocalories per day, and very low calorie diet of less than 800 calories per day. So these are the two diets where you can see a weight loss of 10 to 15 kgs. So the driving force of remission is basically the weight loss. And carbohydrate diet, you may not have that much of weight reduction in low carbohydrate diets, but still you may have some remission. So low carbohydrates diets help in lowering insulin secretion, thereby reducing fat storage and improving the cardiometabolic function. So low carbohydrate diet, which consists of less than 26% of carbohydrate, that is about 130 grams of carbohydrates per day. And very low carbohydrate diets, almost 20 to 50 grams of carbohydrates per day. But the big question is, how long can the patients be on such rigid diets? Now here you can see in this picture the reversal remission of type 2 diabetes mellitus. So once obesity comes down, there is decreased fat in the liver, there is decreased fat in the pancreas, and this normalizes the function and patients become normoglycemic. Now, who are the right candidates? So whom should you choose? Who is the best candidate to have this remission? So the ABCDEFs are A1C, those who do not have a markedly elevated A1Cs, like borderline A1C say 6.8, 7.2. These are the patients who are likely to have remission. Body weight, the higher the body weight, the higher they lose, chances of remission higher. C-peptide levels, which is a marker of insulin in the body, higher the chances for remission if better C-peptide levels are present. Diabetes duration, shorter the duration of diabetes, better the chances of remission. Enthusiasm, patients, from the patient's point of view, highly motivated patients are more likely to have remission, and frequent follow-ups. Individuals should be willing for a frequent follow-up, and also men are likely to have remission more than women, and also people with good mental health are also likely to have remission. Now, what is the evidence of dietary intervention in diabetes remission? So, meal replacement therapy, can they help to any extent to have a low carbohydrate diet so that they can have a remission? So, this is a study, a small study where they have used about 600 kilocalories per day for 8 weeks, and they have seen that fasting plasma glucose, hepatic glucose output, as well as hepatic triglycerides have come down, and the average weight loss in the 8 weeks was about 15 kg. So in conclusion, the counterpoint study says that normalization of both beta cell function and hepatic insulin sensitivity in diabetic patients achieved a dietary restriction alone. Now this is another study, the DIRECT study, which showed that at 12 months, 50% achieved remission on non-diabetic state and off anti-diabetic drugs, and weight loss was the strongest predictor. So people who had a high weight loss of more than 15 kg had a remission of 86%. But then the big question is, how many people can have such amount of weight loss? This is again another study, DIADEM study from Oman, and they concluded that the intensive lifestyle intervention led to significant weight loss at 12 months and was associated with diabetes remission in about 50 to 60% of the patients. Same thing, another small study, Bhatt et al. From Pune, about 12 obese patients they have taken up, and they have shown that dietary supplements could be used as an alternative for low carbohydrate and have a remission. So these are some of the more evidences. So dietary interventions in diabetics can help induce remission in a select group of patients, and simple weight reduction in obese or overweight diabetics can still induce larger benefits even if remission is not achieved. So even if remission is not achieved, suppose the number of tablets may come down, the dosage of insulin may come down, a patient may feel better, because obesity has so many other connotations. So I feel it's the mother of all diseases. So osteoarthritis can come down, obstructive sleep apnea patients may feel better, they may be off their BiPAP or CPAP machines. So many benefits, cardiovascular benefits, hepatic benefits, non-alcoholic steatohepatitis, which is assuming a huge proportions these days. If you reduce just 5% of the weight, your liver fat content decreases, and also the kidney benefits, the heart benefits. There are so many benefits of reduction of weight. So can diabetes-specific nutrition help? Yes, it does help. Diabetes-specific nutrition can replace supplemental meal, partial meals or snacks as a component of medical nutrition therapy. So these are some of the attributes of diabetic-specific nutrition and benefits which we see. And specialized carbohydrate blend and fiber, maltodextrins as well as sucralose, they have low glycemic index, and postprandial peaks will be less if you consume this. High protein content provides a good quality protein and also improves the GLP-1 secretion from the alpha cells, and fat blend with monounsaturated fatty acids support the heart health, also improves the GLP-1 secretion. So these are again some of the indications that diabetic specific nutrition do help in reducing weight, do help in having a remission. And these are the benefits of some of the other formulas. The same thing. So the key takeaways which I want to tell you are, there is a strong association between overweight, obesity and diabetes, and remission can be partial, complete or prolonged. Even if you have a partial remission, the number of drugs which the patient is taking can come down dramatically and can be targeted in a specific group of people who are motivated, who have a recent onset of diabetes, who are obese, requires long-term approach, and it's difficult to maintain sometimes, and weight reduction should be targeted in all obese, overweight diabetics, irrespective of achieving a remission or not. So because there are some other benefits of reducing weight apart from remission of diabetes. So diabetes-specific formulas not only can help in maintaining blood sugar, but can also help in weight reduction and used as a meal replacement. Thank you for your patience.
That was a wonderful lecture, sir. Remission is definitely needs lots of motivation.
Yes, ma'am.
and overweight needs to be controlled.
Yes.
And you were talking about low carb and very low carb diet,
Yes.
which we require very tasty food. First thing
Difficult.
out of them, and Indians need motivation regarding this food.
Yes.
Low carb and very low carb are generally very expensive. So how many Indians can afford them?
Yes, it's a good question, madam.
We
It's
all
difficult.
doctors,
Yes.
though non-diabetic, we are all on millets. We are showing our dietary consciousness.
Yes, ma'am.
I've lost 6 kilos eating only millets. I avoided rice and everything. Only to make sure that I don't want to become a diabetic. But no, I'm not happy. Not really happy because some of the favorite diets are gone out of my list, bucket list. So many of them have given their feedback like they cannot avoid alcohol and low carb diets are not their preference of choice. What can we do?
Maybe Sir Raj Bhandari sir will come onto the stage next as a speaker, where he will give us a better idea of millets which have low carbohydrate, high fiber, and cost-effective way of using these millets to have a remission or to have a good effect.
Thanks a lot, sir.
Thank you, sir. Year 2023 is a year of millets. So I invite Dr. Raj Bhandari to tell us how they are going to help us in the long way. Over to you, sir.
Thank you. Let me tell you, good afternoon. It's a lazy hour and not a very glamorous time. But all the same, I'll try to make it as interesting as, So, we have a very distinguished panel, and it is their forte that I am including in, but I'm sure what would go into the plates would be from the kitchen. We have, being in Hyderabad is a great academic feast always. I come to the Indian Institute of Millet Research, IIMR, very often as the chair for their committees, and they have done amazing work. The NutriHub, which is the startup ecosystem, and similarly, the National Institute of Nutrition (NIN) is the premier institute where we are doing great work. Also AIMS, and now we see that Frontiers Diabetes has taken a lead, and I'm so happy that I'm talking to my community to impress upon them what I find. The key words that were used today one was the ancient was, and these are ancient grains that I'm going to talk about. We see that there has been an epidemiological shift in our entire disease paradigm. What was earlier communicable now has shifted to non-communicable. There was a group of scientists who gathered in Seattle, and you will be surprised they were to identify the major risk factors for mortality and morbidity. And 7 out of 10 of those risk factors were diet related. Now, that is a very, very important clue to where our policy direction should go. The other thing that came to light was that 1 in 2 persons on this planet is malnourished. And you would ask why 1 in 2 would be malnourished. Well, the spectrum of malnourishment is right from being a wasted child, a stunted child, a micronutrient deficient adolescent, and the spectrum of obesity and diabetes and other disease. So this entire spectrum, if you were to look at, 1 in 2 would be malnourished. And therefore, it becomes very important that we consider nutrition as an integral part of our preventive and promotive strategies. Now, it is good to have an interdisciplinary approach. A role of a dietitian and nutritionist becomes important when we are advising the patient or even prescribing. And what I'll do is I'll first introduce you quickly, because in the interest of time, to what millets. People have not even seen millets actually, and it is important to introduce the ancient grains, because after 1960s we found that these grains really vanished, practically became orphan grains. And it was only in 2018 that the Honorable Prime Minister declared that as the millet mission, where a 800 crore rupees fund was allocated, and we started talking about millets in public discourse. And then India presented to the United Nations General Assembly a resolution which was adopted by 69 countries, and FAO declared 2023, that is this year, as the International Year of Millets. So this is a big gain that we have achieved. So there are 9 types of millets that we have in India, but actually job steers and other millets grown in other regions, so there would be like 12. But there are many hundred varieties of these 9 types. So if I were to, the government of India declared them as nutri-cereals. Why? Because they are packed with nutrition and they have a great role in our food security, nutritional security, and being gluten-free, they are a good substitute for wheat in those who are gluten sensitive, and they have all millets by and large have a low GI, and they also help in combating cardiovascular diseases. So I will be presenting to you some of the evidences that we have in favor of how they work in cardiovascular disease and other and diabetes and so on. I consider millets as not superfoods but as smart foods. And why I say so? Because millets are good for you, good for the planet, and good for the farmer. And as the Honorable Prime Minister said, that they can withstand adverse agroclimatic conditions. So when nothing would grow at a temperature of, let's say, 55 or 55 degrees Celsius, it is only millets which is the hardy crop which will survive. And in government we have many feeding programs where we could introduce millets in those programs. We have the general, the flagship program, which is the Poshan Abhiyan, and the PDS and child-centric programs, and also disease control programs like nutritional anemia and Nikshay Poshan Yojana. So, you see, for now the 3 majors are rice, wheat and maize, and they deliver something like 50% of the calories consumed globally. And where millets on this planet, we talk of one planet, one health. There is only one planet, and the One Health has become a movement now. So planetary health is as important as our own health. And millets will not need any fertilizers or pesticides. They are C4 crops, carbon neutral crops, so they don't pollute the atmosphere, and they survive in
hot conditions, and our scientists have produced hybrids and varieties where the yield can be increased. This is the only disadvantage, that the yield is less, so the farmer doesn't grow. But now we have better varieties and multiple uses like feed, fodder, and fuel. Biofuel can be generated from millets. So they are good for the farmer as well because they are the last standing crops and they don't require agri inputs. And you see pearl millet, bajra, has iron which is 6.4 milligram% and zinc. And imagine ragi, that is finger millets, has 3 times the calcium more than milk. If ragi were to be introduced in areas like the Northeast and the Southeast Asia where people are deficient in calcium because of low intake of milk, this would probably help in overriding some of these deficiencies which are seen. So kodo has 3 times the dietary fiber, and pearl millet has 2 times the protein as compared to milk. And of course the antioxidants, the phytochemicals that millets have, they serve as antioxidants, and you would all agree that most the inflammatory diseases that we see in our body, antioxidants have a major role. So this is the chart which shows that certain types of millets are rich in specific nutrients. Proso will have more of protein, whereas pearl millet will have more of fat and the energy, so it is usually consumed in the winters, but it has a very good dietary fiber. And as you know, the NIN has recommended that the dietary fiber intake has to be something like 30 grams per day, 25 to 30 grams per day. So we have to build up our dietary fiber and the prebiotic property that they confer. So this is a nutrients mapping. You have, sorghum which has magnesium, foxtail which has thiamine, kodo which has folic acid, barnyard which has zinc. So these are the health benefits. And now I come to those specifics. There was a systematic review and a meta-analysis which was done, and we found that millets in the intervention group with a sorghum diet, sorghum would mean 60% of sorghum and 40% of rice diet. We found that there was a higher growth rate, a higher hemoglobin level, higher serum folic acid level, higher calcium levels, higher iron levels. And here you need to understand that sorghum, which we call as jawari, by the variety, the iron content could vary from 4 milligram% to 14 milligram%. That is the kind of variation in the type of variety that you choose. And this is in diabetes management that we found that foxtail and barnyard millets have a low GI of less than 55, and pearl millet and other millets, finger and kodo, will have intermediate GI. But here a word of caution that what was, it depends on we found that there was a reduction in systolic and diastolic pressure, and also lower the increase in blood pressure and oxidative damage that was noted. So in dyslipidemia, there was a decrease in LDL and in increase in HDL that happened. Triglycerides also became less, and in certain other studies we found the lower levels of C-reactive protein and reduced level of and the gut health was immensely improved, you know. We talked of prebiotics and we talked of probiotics, but we found that postbiotics, there was an increase in short chain fatty acids in stool samples which were collected, and therefore indicating that millets act as very good pre and probiotic because they go undigested, the insoluble fiber. Also in NAFLD we are conducting a study in ILBS. So finally, to conclude, I would say that, I mean, what Hippocrates in 550 BC said, that food is thy medicine. It was true then, but it might not be true today, because not all food is thy medicine. It is how you process that food, and the ultra-processed food could really be poison in the way that has been described earlier today. And we have different forms of consuming millets. So this is the final thing that I want to give you, the objectives of the International Year of Millets, that the government has said that we have to drive consumer demand, grow processed products, establish the most efficient and fair value chain, increase farmer productivity and resilience and incomes, because unless a farmer is benefited, he would not grow millets, and increase nutrition and health of the nation. And for all these, certain actions, proactive actions, have been taken by the government. I'm sure we'll witness a lot of activity in the year ahead. And I don't call it the year of millets, I call it the decade of millets, and even beyond that. Thank you so much for your listening. Before I step down, can we, wherever we go, we take a pledge. And if I can request all of you to stand up and just one-liner pledge, that will help. And I'll say, let's millet. And I would expect all of you to say that, yeah. So let's millet. Let's millet. Thank you.
Good evening, sir. It was excellent presentation, sir. And It was like millets are powerhouses of nutrients. And you also focused on the government activities, how much the government is taking the pressure to bring back good food to us onto our plates. And you are one of them. And thank you so much for enlightening us on millets and their role. And congratulations to Faraz, Srinivas and Shaista for planning so meticulously, and the topics were too good. The day started with the critical care, where nobody likes to go there, what we shouldn't do, and the day is ending with what we should do, what nutrients we should take, and what diet and exercise we should do. And also, the being women, we all of us are sitting for the women symposium over here, and it started with Manjula ma'am's talk on EDCs and all. And it's like we were all sitting on a tickling nuclear bomb which is ready to explode anytime. So we should concentrate on the EDCs and continue with the PCODs. And Ataullah sir, being a teacher, he excellently presented as usual about the nutrients and diet management in diabetes. And want to know from you expertise, like what is your experience in the post-COVID era? Like what are the problems which are increasing in the percentage, like the thyroid disorders, the infertility problems, and PCODs? Not only that, the maintenance of pregnancy and placental insufficiencies. These days we are seeing more of these cases. So any comment from you, ma'am, Manjula ma'am or Shweta ma'am? Any comment from both of you? Like placental insufficiencies or anything? Like any increase?
Thank you. Rather than then, during COVID, we did see that there's a huge increase in the second trimester abortions and number of abortions and everything. But post that, whether it is vaccine-induced, now it is again a fancy to say everything is because of vaccine. This because of vaccine. Whether it is disease or vaccine, I'm not bothered, but definitely menstrual irregularities have definitely increased. Whether it is vaccine or corona, but definitely it has increased. Thank you.
Saw a lot of menstrual irregularities in the last 2 years, especially soon after that second, third phase of COVID. We had lots of patients coming with menstrual irregularity. Those who just had COVID and recovering for the after the COVID, in that phase, definitely menstrual irregularities, and maybe we don't know long. There was a lot of impact. I have seen lots of patients post-COVID with sperm parameters being affected, and when we put them on certain medication and diet lifestyle changes, a lot of men improved also. So sperm parameters, there was a really big drop in the sperm parameters post-COVID. Female infertility, we don't know, maybe there might be a long term. It's not so obvious. With the female, we don't have obvious tests to say that ovarian reserve dropped down or not, but with men we know that there is a drop. Quite a bit as menstrual, this second trimester miscarriage, preterm. We had during that COVID era, we had a lot of prematurity also was very high.
Thank you, ma'am. I would like to invite the speakers onto the stage, please.
I request Dr. S.G. Mozam sir to please come on the dais and felicitate our speakers. Dr. S.G. Mozam sir. I request Dr. S.G. Mozam sir to please present the felicitation of Dr. Sweta Agarwal ma'am. Dr. Manjula Anagani ma'am. Dr. N. Muhammad Ataullah, sir. Dr. Raj Bandari, sir. Now, I request again Dr. S.G. Mozam, sir, to felicitate our panel members. Dr. Acharya Jain, ma'am. Archana Jain, ma'am. Next, Dr. Prabhavati, ma'am. Dr. Jyoti, ma'am. Dr. Biri Shobha, ma'am. And Dr. Pratima Raj, ma'am. I request all the speakers and panel members to please be on the stage for a group photo. Ma'am, please come ahead, sir.
Okay. Smile, smile.
Thank you, sir. Now it's the time for award ceremony, and I again request Dr. S.G. Muazzam, sir, to please come on the dais to give the award, to present the award. Now,
it gives me immense pleasure to welcome Dr. H.E. Khan Sahab, Basha Nawaz Khan Sahab. Please come on the dais, sir. Thank you so much for taking our time and gracing this occasion. May I request both of the dignitaries to be on the stage, please. Now we have, I would say, the most important two special awards. The first award, I think, is so well deserved for our leader, a philanthropist, teacher, academician, vision leader. If I keep on talking about Dr. Vasant Kumar, sir, lines would not be sufficient. So, sir, please, may I request Dr. Vasant Kumar, sir, to come on the stage. And sir is being awarded for Lifetime Achievement Award in Healthcare and Medicine. Please, may I request all the dignitaries to be on the stage for just 2 minutes. We have the next award. Again, it goes to my fellow colleague. Again, I would like to talk about her. So we've seen her grow as a student with us. She's been very supportive, and then right from a student to heading the department and now being the medical superintendent. So Dr. Pratima Raj is being awarded as Women Healthcare Excellence Award. May I request the President of FDRS, Dr. Shaista, to come on the stage? May I request Dr. Vasant Kumar sir to please share few lines, sir.
My dear friends, it's been wonderful today. I congratulate Dr. Faraz and the entire team for doing this wonderful job, for bringing us all together and spending a quality time learning from each other. Because this is a process, we learn from each other, we connect from each other, whether you are young or old, senior or junior. It has been a great time for all of us. I am sure Dr. Faraz will continue to impart this knowledge to all of us in the future. But let's all work together and prevent non-communicable diseases like diabetes and hypertension in future. But our country needs people like all of us to work together. So I'm looking forward to work with all of you along with Faraz in the future time too. Thank you so much.
Thank you so much, sir, for that kind words.
Good evening, everyone. Every day we grow a little older, and a little smarter. Okay, and our organization have also grown up. This is our 5th anniversary, and it is a milestone for us. It is a breakthrough. So we have grown a little, and today we want to launch a new program, a club, which is for the people. We are going to launch Type 1 Diabetes Club, that is MITAS program, and we have named it as MITAS, which will be led by our Meathead champions. It is run by them, for them, and it's of them. So I welcome all my Meathead champions on the stage for the launching. This program will be led by Dr. Faraz Farishta, and this Meathead champs will do the networking, and free distribution will be done for type 1 diabetic patients. Please play the video, Ishwar. So please welcome them with a round of applause.
Hi everyone, I am Faizan Ahmed. I am 27 years of age. I am a type 1 diabetic since last 15 years. I work as a lead analyst at a leading political consulting firm. However, being a type 1 diabetic myself, I always want to actively contribute to the society, and then I came across MITAS, Type 1 Diabetes Championship Club. I love the idea of their willingness to impact type 1 lives inspired me so much that I have enrolled to join this club as a facilitator with an aim to empower my fellow type 1s and actively contribute to the society when it comes to research, spread awareness and other impactful campaigns. I'm just looking forward to join this team. Thank you.
Hello everyone, myself Vidyaval. I'm a person with type 1 diabetes for the past 30 years. I got diagnosed at the age of 11. I'm a civil engineer by profession and also a certified diabetic educator. Type 1 diabetes never stopped me from doing anything in my life. In turn, it taught me a disciplined lifestyle. I'm happy to be a part of MITAS, initiated by FDARS. Thank you. Go. Hello, I am Girish Jain, entrepreneur, marathon runner, and person with type 1 diabetics from past 12 years. My idea of managing people's type 1 diabetics does not lie in making daily routine miserable or advising something that creates more problems than it solves. Advice should be blended with person's daily routine so that it can be followed for longer period. I am joining Vitas from FDRS to help people with type 1 diabetes to manage it with minimum modification in daily routine. Thank you.
Hello, myself Ramya. I'm a person living with diabetes since past 14 years. I'm a student and a part-time baker. I was diagnosed with type 1 when I was in 4th standard. It was a journey with many ups and downs, but everything comes with an experience. I want to share all my experiences with as many people as possible to help them manage their diabetes. It's an honor to be a part of Meta's Type 1 Diabetes Champions Club. I'm looking forward to make a positive impact through this.
Hello everyone, this is Vaishnavi. I am type 1 diabetic since 11 years now, and I keep checking my blood sugar levels multiple times in a day. This is a 24/7 job for all type 1 diabetics, and but this is all for me. This makes me live healthy and this happy. Well, I'm happy to be a part of Meta's Champions Club and reach as many type 1s as possible and help them lead a healthy and happy life. Thank you.
I request Dr. Vasant Kumar sir to please do the honor for our first Meethi champ, Miss A.R. Ramya. Our Meetha champ, Mr. Rudra Varan. Mr. Girish Jain. I request Baksha Saab to please give to our Mr. Faizan Ahmed. He has been a very good patient, I would say a champion. I have been closely watching him for more than a decade now, and he's become a political analyst, so he's doing a great job. He is showing all of us that type 1 diabetes cannot stop anyone. And not last but not the least, Miss Vaishnavi. We all loved your video, Vaishnavi. Let me thank you for that lovely video. I think SMBG is where 100 times we tell patients, 99 times they don't do it. So thank you all for joining us on the stage, and we'll continue with the session. So we have just 2 more talks left, and we'll just continue that.
Yeah, I would now ask Dr. Nalakshmi, the pain physician, to come and relieve all our headaches. She is a practicing pain physician for last 10 years, and hope I think so you will give a soothing balm to all of us.
Thank you for the warm welcome. It's good to see such a huge crowd. Sunday late evening, I suppose it's almost going to be night. And I thank the Frontiers Society for giving me this opportunity. So I know all of you have been hearing a lot about hormones and various things affecting various organ systems of the body by the hormones. So this is something a little different from what you have been hearing since the morning. How many of you are diabetics in this? Yes, I have seen some type 1 diabetics now, but other than that, how many of you are diabetics? And most of the diabetics experience some pain in any point of their life, mostly when it becomes a chronic diabetes. So my topic is treating the causes of diabetic pain beyond medications. So all of you, I suppose, belong to the general physician or the critical care group, where I need not introduce pharmacotherapy for you. I'm here to speak about interventions, both steroidal and non-steroidal, to relieve diabetic pain. So the most common causes of pain when we see in diabetic patients, it comes either from the most commonly the diabetic neuropathy or the diabetic foot, adhesive capsulitis, most commonly called the frozen shoulder, plantar fasciitis, and the carpal tunnel syndrome. So whenever we speak about diabetic neuropathy, as all of you know, it's a diagnosis of exclusion with symptoms and signs pertaining for the peripheral neuropathy. So most of the diabetic neuropathies in prevalence being more than 45%, and about 26% of the diabetic neuropathic patients have a very severe painful diabetic neuropathy. It could present even in an acute setting, and this is the most common cause of neuropathy seen in developed countries. It manifests both as sensory, motor, mono or polyneuropathy. So whenever we speak about the management of the diabetic neuropathy and subsequently the diabetic foot, we exclude the non-diabetic causes. The strict glycemic control is a must for any cause of pain in diabetic patients. And pharmacotherapy, as you all know, all the tricyclic drugs, the SSRIs, the anticonvulsants, and topical applications of xylocaine and capsaicin and nitrates. So what if the patient doesn't respond to these medications, or there are any side effects, or patient is not able to tolerate all these side effects? So is there any other way by which we can give the patient comfort zone by decreasing the medications? Most of the time we see that prolonged usage of medications, even the safer margin of drugs, do have some side effects, at least of edema or weight gain, particularly the neuropathic agents which we use in diabetic neuropathy. So there are some interventions which give a long-term relief, thereby decreasing the pharmacological treatment and even expanding the comfort zone of the patient. So when we talk about interventions, the most common thing being the lumbar sympathectomy, the other things being the botulinum toxin injections, peripheral nerve blocks and spinal cord stimulation. So lumbar sympathectomy, because the sympathetic block improves the vasculitis, the ischemia and the pain which we see because of the hyperglycemia and the dyslipidemia seen in diabetic patients. And whenever we speak about lumbar sympathectomy, we have a notion that it is useful only when there are autonomic symptoms. But most of us know that diabetic neuropathy is a small fiber disease. So does lumbar sympathectomy help in small fiber disease also? Yes, because most of the small fiber disease is because of the microvascular dysfunction, the higher circulating levels of the sympathomimetic hormones, that is epinephrine level, and the impaired sympathetically mediated vasoconstriction. So lumbar sympathectomy, though the etiology could be a small fiber neuropathy or diabetic autonomic neuropathy, it helps in both these conditions. We generally do it in fluoro guided, and this was one of my case. of lumbar sympathectomy for diabetic neuropathy. So whenever we do a steroid block, so how long is a steroid block going to act? And most of the patients have a notion that as long as and when you say that we are going to give a steroid block, patients say, no, we don't want steroids, and they get back. So is there any alternative for it? And steroid blocks do not work for a prolonged time. So yes, there is something called as radiofrequency ablation, which we do both for the lumbar sympathetic and in many other cases. So radiofrequency ablation prolongs the sympathetic block, which we do for a period of 2 to 3 years. Botulinum injections are particularly helpful in painful diabetic neuropathies. They help by inhibiting the neurotransmitter release and even the inflammatory mediators release. Around 48 units in each foot in around 6 to 4 distribution. We repeat it at an interval of 3 months, and it is seen that evidence has shown that successive botulinum injections, around 2 or 3 successive injections, decreases the intensity of the diabetic neuropathy. Spinal cord stimulation, yes, elective spinal cord stimulation is reserved for refractory cases which are not responding to any of these conventional treatments and any of the minimally invasive treatments of lumbar sympathectomy or botulinum toxin injections. But chronic diabetic neuropathic pain, whenever the patient is decided for a spinal cord stimulation, it is even shown to increase the exercise tolerance. If a patient comes with an acute peripheral neuropathy, most of the time we do not have time because lumbar sympathectomy is mostly a fluoro-guided procedure. So whenever there is a restriction of the equipment-based things, we can even go for simple peripheral blocks which give an immediate relief. So we generally put in a catheter still to buy in the time to which we arrange the lumbar sympathetic block. The other being the adhesive capsulitis, seen in around 40% of patients of diabetic neuropathy. So it involves the shoulder. Most commonly, there is loss of both active and passive movements. Ultrasound helps us for both dynamic evaluation and improves the sensitivity and specificity. So yes, we see in so many orthopedic clinics that most of the orthopedicians just give up blindly a steroid injection into the joint and it is done. But is it so simple, and is it every time the cause? Whenever we get a scan of patients suffering with frozen shoulder, we most of the time see that glenohumeral joint is not the main culprit. It is the adhesions of the ligaments which is the main culprit. So giving a shoulder joint injection most of the time doesn't relieve your problem. It only partially relieves your problem. That too when there is a glenohumeral joint involvement. So is there anything else which we can do? This is prolotherapy, in which we inject around 5% dextrose or normal saline with or without a local anesthetic. We do not use a steroid. Ultrasound guided, we free all the ligaments, both the coracohumeral ligament, the superior glenohumeral ligament. All these ligaments are ultrasound guidedly with around 30 to 40 ml of dextrose. When we free them, the range of motion increases and the pain automatically decreases. So there are some cases in which very severe frozen shoulder unresponsive to any of these treatments. So the other alternative is a radiofrequency ablation of shoulder joint. This helps to decrease the pain drastically. So the major nerves which supply the shoulder joint, being the suprascapular nerve, the lateral pectoral nerve, and the axillary nerve, all these nerves we do a radiofrequency ablation, and a radiofrequency ablation works for around 1.5 to 2 years. Physiotherapy is the mainstay of treatment, but with pain, most of them are not able to do their shoulder movements. So once their pain is decreased, the shoulder movements can be done easily, and the adhesive capsulitis, everything comes into control. The other common thing which we see in diabetic patients being the plantar fasciitis, that is inflammation of the insertion of the plantar fascia at the calcaneal tuberosity. I've seen again so many physicians and everybody locating the maximum tender point and just giving in some speck of steroid there. But steroids have a temporary role. Most of the time there is a recurrence of the symptom. So another important thing is the regenerative therapy, that is the platelet-rich plasma therapy, in which we take the patient's own blood, separate the PRP, scan for the plantar fascia along the whole length, look where the thickness is more or whether there is a tear, and inject the PRP. So regenerative therapy, particularly in chronic or long-term cases refractory to conservative management, particularly helpful in patients who have associated synovitis and arthritis, and even in post-surgical cases. The carpal tunnel syndrome, medial nerve dissection, I've seen n number of cases in my clinic where even after carpal tunnel release surgically also, in diabetic patients there is a high incidence of recurrence of the carpal tunnel syndrome. So ultrasound guided, just like the prolotherapy of the shoulder joint where we free the ligaments, We free the median nerve from all the attachments, and this gives relief. There is no surgical morbidity in any of these procedures. So a small note on radiofrequency ablation. It's a minimally invasive target-specific treatment. It reduces pain in several chronic conditions, like not only of this diabetic pain, we use it for knee osteoarthritis, low backache, trigeminal and glossopharyngeal neuralgias, post-herpetic intercostal pains, cancer pain. So there is a temperature control target nerve destruction. So whenever the temperature is more than 42 degrees, we see a nerve destruction. So the temperature which we control, the impedance according to that, we see that the sensory and the motor fibers of the nerve are not injured. Only the pain and the sympathetic fibers are numbed. So the function of the joint, like the shoulder joint or the knee joint, the function of the joint is intact. It is only that the pain is numbed. So yes, even by the pain transmission modulation, radiofrequency ablation helps to decrease the pain. So you have various types of radiofrequency ablation, both the conventional, the cooled and the pulsed. Whenever we do a pulsed radiofrequency ablation, we mostly do it for mixed nerves where the motor component is preserved. It is just a modulation, neuromodulation electrically, where short pulses are given at a lesser temperatures of less than 45 degrees where the nerve is not damaged. So the motor and the sensory component of the nerve is intact. So the function of the nerve, function of the limb, function of the joint is absolutely intact. It is only that the pain of the patient comes down, which helps in an early rehabilitation. That's it. Thank you.
Yeah, thank you, Dr. Nagalakshmi. See, we have got a very good advantage of both the neurophysician and pain specialist together working with us. One important question I would like to ask in Praveen, neurophysician and Nagu. See, all of us know diabetic patients have got so much amount of pain for neuropathy. As young as 8 years old, young females are trying to commit suicide because of neuropathy. So it should never be neglected. So at what point of time a neurophysician suggests them to go to a pain specialist? What are those clinical scenarios where a neurophysician asks you to refer to a pain specialist?
Yes, definitely pain is very bad. Many times, especially when I see all my medicines which I thought they are not helping at all, and patient keeps on coming with them, then I say no. It may be a painful periarthritis or a painful carpal tunnel syndrome, low backache, or a severe lumbosacral radiculopathy. These are the incidences when I definitely say just meet Dr. Nagal.
I will leave you, Dr. Nagalakshmi.
A small note in this juncture. Like most of the cases which are referred to the pain clinic are chronic after exhausting all the medications. So early interventions give better results, particularly with diabetic neuropathy.
Thank you so much, Dr. Nagalakshmi. My pleasure inviting Dr. Mohammad Alimuddin. Please come over to dais. He is the Chief Consultant in Diabetes working at Hayat Hospitals, the CEO of FS Endocrine and Diabetes Center, the Director of Diabetes Awareness Foundation. Through his career, he has Phillips Awards as Young Scientist of India by University of Medical Science and New Delhi 2015, Gold Medalist in MD Residency Program 2018, President Research on Diabetes Food Idea 2019, is appreciated for work on diabetes by Government of Telangana and Health Ministry 2021, certified in postgraduate course in Advanced Diabetes from Harvard Medical School 2022, is working on public health advocacy of diabetes in rural India. And over to you, Dr. Ali.
It gives me immense pleasure to be a part of this academic feast. But before I begin, I would like to thank all of you for being today on this weekend, staying together, for contributing to learning about diabetes. So after my brief thank you, let me start with the topic. So today my topic is about TIR and CGMS. So now with the advent of so many tests about diabetes, how do we check sugar without clicks? So the agenda is what is CGM technology, CTA, CGM utilization, patient case examples, ensuring success with CGM, and finally a brief question and answer session. So before I start my topic, can anybody let me know what is the cornerstone of diabetes therapy? Exactly. So I always say, if you do not know where you are going, then it is like you are going nowhere. Similarly, if you want to manage your day, the way you manage is by looking to your watch. Then you know how much time is there for the day and how you manage the day. So the only way we can manage diabetes is to measure sugars. So how are we monitoring sugars? If you have seen the earlier video, our METAS champion Ramya, she was in the video using an SMPG using a common glucometer. While when she came here, she was wearing a white color badge which is called CGMS patch. So now with sugars, then they came of the concept of A1C. A1C, as we all know, gives an average of 3 months of sugar. But as we can see, there are 3 people of same HbA1c, but their sugars are of varying capacities. In the first picture, as we can see, there is very low variability. The sugars are under control and it is between 70 to 180. And in the second picture, we can see it is moderate variability. It is only fluctuating from 170 to say 200 or 220. But in the third picture, we are seeing it with high variability. So why is TIR important? This is a very important slide which says if there is increase in TIR of only 10%, then there is reduce of 0.5% of A1C, there is decrease of abnormal CIMT, which is a surrogate marker for atherosclerosis, decrease of diabetic retinopathy, decrease of severity of albuminuria, and also microvascular factors, decrease in peripheral neuropathy and cardio-autonomic neuropathy. On the converse, if you see, even if there is 10% decrease in time in range, then there is increase in 64% of diabetic retinopathy, 40% increase in diabetic nephropathy, and 25% increased prevalence of diabetic foot. So, indications of time in range in diabetes management is there for both type 1 as well as type 2. In type 1, to monitor the insulin requirement and to titrate the dosage, and in type 2, diet and lifestyle. I always believe diabetes is a journey which should be traveled together with the patient. It should never be a doctor prescribing the pills and the patient on the receiving end. When you have a CGMS patch, the patient knows how much sugar is varying with his food and with his meal. If I have seen many of my patients, we normally say that rice is good and it lowers your glucose, but in Indian population with such a diverse genes, we have seen some patients are susceptible to rice and some patients to wheat. To know exactly what to do, the only way is to monitor sugars, and it can be done only through this CGMS patch and time in range. So TIR as time in range is simple, and the objective goal should be clear. There should be a clear direction. Then there is validation, and finally then there can be empowerment from the patient side. So the normal way we monitor sugars is by using a capillary glucose. We use a needle or lancet to prick, and then the CGM measures interstitial glucose. So this is a small patch where there is a transmitter on the skin. It monitors sugars in the interstitial fluid. Now there is a lag between finger stick and CGMS. If you can see, when there are sugars are rising rapidly, CGMS may lower the finger stick levels, whereas in rapidly falling sugars, CGM may show higher figures. So these are the device parts of a CGMS, and if you can see in this AGP report, there are the target range which is 70 to 180 is the normal range which we call time in range. Anything above it is called TAR, time above range. Anything below is called time below range. In this also there are 2 levels, level 1 and level 2. In level 1, anything about 180 to 250 is high, and above 250 is very high. So once you know your sugars when they are very high, very low, then it is easy for you to titrate the doses. So CGMS is here to stay, and there are multiple studies which show that in type 1 diabetes, regardless of insulin method, CGMS benefits everybody, and there are significant reductions in hospitalization, and most importantly, it benefits in engagement with the diabetes care, relief from cumbersome and intrusive finger sticks. So now even if you see in patients receiving basal glucose, the yellow line denotes that there is significant decrease in the HbA1c percent in TIR gain, or the sugars are more than 50% in time above range. So, do we have any recommendations for this new technology? Since last year, we have recommendations from both ADA and ACE, which says it is strongly recommended on patients who are on multiple insulin injections or pump, recommended on all patients on basal insulin, problematic hypoglycemia, and may be recommended on GDM or not on insulin. And how we select candidates for CGM is people who are suspected of having hypoglycemic episodes, uncertain about initiating CGM, and even in hospitalization, instead of pricking them repeatedly, you just put a small CGM patch and their sugars will be monitored. So this is the AGP report. So these are the targets for different populations. As you can see, in type 1 and type 2, the target range is for 70%, and it is relaxed in type 1 and type 2 patients who are older or at high risk. It is only for 50%, and in pregnancy the target is again 70%, because we know very well that anything about hypoglycemia and hyperglycemia is prone to cause fetal complications. Finally, there are always challenges in adaptation of any new technology. From the patient, it is always cost and coverage, but I am happy to say these days, with the advent of new companies, the prices are really coming down and there is increased coverage, and there is psychosocial resistance which can be dealt with samples from freestyle, and there are always problems from our side like clinics. There is increased work for staff. So a solution for this is to give them a quick start guide for the staff, and then another barrier is who owns the process. You can either give the responsibility to your counselor, registered nurse, or the pharmacy. Finally, I would like to say that CGM is recommended for all larger subsets of people with diabetes. Adoption is improving and it is the only way ahead. With every technology, there is always a resistance, but we all know that the change is the only thing that is constant in this world. Creating new workflows for CGM takes some time, but is rewarding in terms of patient outcomes and clinic revenue. So finally, I thank you everybody. This slide has been my last slide for past very few years, and I believe in that the purpose of living is to live a life of purpose. Thank you very much.
Thank you, Alim. Thank you for your wonderful lecture on CGMS. And now these days we have seen like days have gone where we were just checking a fasting blood sugar, post-prandial blood sugars, then came HbA1c. Now this current topic what we have clearly put it as CGMS. So those days have gone where the role of one-time instant blood sugar has gone now, because we have understood the sugars which are there is a dynamic phenomenon, changes minute to minute. And he has clearly put it as what are the specific indications of time of daily or particular seizures profile. So ideally speaking, all the patients who come to us at type 2 diabetes with uncontrolled blood sugars, HbA1c more than 8.5, or all type 1 diabetic patients, most of them need these CGMS profile testings. But there are so many other technical issues. That's the reason we are not able to use for plenty of patients. But if in all facilities are there and they can use that facility, urge all the clinicians to take the advantage of using this CGMS technology, so that you'll be able to adjust your medications properly, so that you'll be able to reduce the HbA1c, so that you reduce the long-term complications of diabetes. And thank you, Dr. Alim.
And in the recently I was reading that Apple iPhone, they are also coming up with a program of CGMS. Well, let's hope once that is successful, as they are checking the heart rate, now we can also have CGMS.
Thank you, sir. Now it's the time to felicitate our eminent speakers. To felicitate our speakers, I would like to invite Dr. Khan Sahab Basha Nawaz Khan sir to please come on the dais and felicitate our speakers. Haji Khan Sahab Basha Nawaz Khan sir. I invite Dr. Alimuddin sir to please come on the dais. I request Dr. Nagalakshmi ma'am to please come on the dais.
So at the last part, I would say we have introduced few new awards for the upcoming. There's always a lot of talks on the startup companies. So we're going to start the startup companies. We got few ideas on prevention of diabetes. Any startup who are planning to do something on how do you stop this NCDs. So we have introduced 3 awards. The first award goes to the best millet startup, that is NutriMagic. May I request Mr. Hari to come on the stage, please? The next award goes to Excellence in Resource Building in Clinical Research. May I request Uma Priya or Mujibuddin to come on the stage from Clinosol? And the last but not the least, the best specialty pharma startup of the year goes to Dyanova Healthcare. Woman. The last award goes to the best new startup, Laya IT Solutions, for designing the websites, for designing the healthcare setups, for doing a lot of digital activity. May I request Mr. Mahesh to come on the stage and take this award.
Thank you. Now moving towards the last but not least session, that is poster presentation, award ceremony and certificate distribution. For this, I would like to invite Dr. Ataullah sir to please come on the dais to present the certificates for the winners. The first prize for the poster presentation goes to Dr. Saad Hassan Muhyiddin. The second prize for the poster presentation goes to Miss Rana Gohar ma'am. The third prize for the poster presentation goes to Dr. Kunda Lakshmi ma'am. If she is not available, I ask someone to please come on behalf of Ms. Gunda Lakshmi ma'am and take her prize. She's coming. Thank you. Only prize. Only prize. The next scientific partner is from CIPLA. Next scientific partner, Dianova Healthcare. The next scientific partner, Alembic, touching lives over 100 years. Alembic. The next scientific partner, Jessen, pharmaceutical companies of Johnson & Johnson. Next scientific partner from Biocon. Next scientific partner from USV. Next scientific partner from Glenmark. Glenmark. Scientific partner AstraZeneca. AstraZeneca. Scientific partner Suprema.
Alkem Suprema.
Scientific partner Elkan Suprema. Scientific partner Denon. Scientific partner Bayers. The last scientific partner is Environ. I request Santosh sir to come on the desk.
What a wonderful day we had. Like throughout the day, our anchors have made us to make the busy in each and every session. So I take this opportunity to invite Mr. Arif and Rutuja on the stage, and I request the Farhad sir and Srinivas sir to felicitate them with the momentum. I invite Mr. Karthik from IMR to come on the dais. Thank you everyone for your patient listening, and now we conclude the entire program. I thank you each and everyone for making this event successful. Thank you so much. Have a great day.
అన్నా ప్యాక్ చేయనా పని చేస్తున్నా సెంటర్